Good morning. I'm Victor Ankumase, and on behalf of the staff of Sherry and Alan Conover Center for Liver Disease and Transplantation, I wish to welcome you to this year's Emerging Topics in Liver Disease Conference. It promises to be a very spectacular event with worldwide speakers being invited and our national speakers also participating actively in this program. This program was put together through the CME office, and I would want to thank the CME office, especially the senior CME coordinator, Ms. Juanita Young, as well as Liver Center coordinators, specifically Ricky Graves and JD Pantoya, for doing all this hard work to put this conference together. The sponsors of this program, in terms of pharma, are exhibited on the Zoom link, and you should see their names on there. There'll be a lunchtime product theater by Genentech that I'll get into later. So without further ado, I would want to start the plenary session one. I want to invite my co-moderators, Dr. Egwem and Dr. Shetty, who are both transplant hepatologists at the Liver Center at Houston Methodist Hospital.
We'll save the questions to the end. Just like to remind everyone to go to pollev.com and enter DeBakey, where you can enter all the questions. You may also text DeBakey to 37607. So we'll proceed with our next talk. I have the pleasure of introducing Dr. Guadalupe Garcia-Tsao. She's a professor of medicine at Yale University. She's the chief of digestive disease sections there. And today she'll be giving us a talk on portal hypertension. Dr. Garcia-Tsao's investigation focuses on cirrhosis, portal hypertension, and related complications, has authored more than 100 original research publications in addition to several society guidelines and position papers in this field. Welcome, Dr. Tsao.
Thank you. Hello, everybody. It is my pleasure to be here actually in this studio. I want to thank Dr. Ankumase for having invited me to give this lecture. And as I said, I'm going to give you an update on management. Knowing that the Baveno conference, I'm going to anticipate some of the things that will be spoken about at the Baveno conference that's coming up later on this year at the end of October, and I urge you to attend this meeting. So as you all know, cirrhosis has two main stages: compensated and decompensated, entirely different disease entities. Decompensation is defined by the presence of clinically obvious decompensating events, ascites, variceal hemorrhage, or encephalopathy, whereas the compensated patient is a long asymptomatic stage, and they're different diseases because their survivals are entirely different. While the patient remains compensated, the median survival is going to exceed 12 years, whereas once one of these decompensating events occurs, the median survival is now about 2 years. So what is the main driver of decompensation is something that we call clinically significant portal hypertension, which is defined by an hepatic venous pressure gradient, or HVPG, greater or equal to 10. Normal is 3 to 5. More than 10 is clinically significant. So how does this work? This is a cirrhotic liver. The first thing that happens is you have an increase in resistance because of this distortion. There's fibrous tissue, there's regenerative nodules, they all are increasing their resistance in the liver. This initially leads to mild portal hypertension. So like I said, normal is 3 to 5, so this is 6 to 10. This is mild, but it's enough to, the splanchnic capillaries sense this increase in pressure, and this leads to increase in nitric oxide, splanchnic vasodilation. So the splanchnic capillaries are vasodilated. This increases the flow into the gut, and then flow out of the gut and into the portal system. So now you have not only increase in resistance, but increase in flow. And now the pressure increases to these dangerous levels, which is CSPH. And it's only then that varices will develop. And not only that, this splanchnic vasodilation leads to effective hypovolemia. So the baroreceptors feel like there's underfilling. They lead to activation of neurohumoral system, renin, angiotensin, aldosterone, the sympathetic nervous system, and this leads to sodium and water retention, hypervolemia, and increased cardiac output. This is a hyperdynamic state, and this increases the flow even further and leads to this CSPH. Additionally, these neurohumoral systems are vasoconstrictive systems that will act in the intrahepatic circulation, causing vasoconstriction. So it's like a vicious cycle. Now, if you think about it, if there's increased pressure here and there's water retention, you're going to have ascites formation. If the flow increases more and more through these veins, they're going to get dilated until they rupture, and you'll have variceal hemorrhage. And with these are only one collaterals, but there's other collaterals that lead to portal systemic shunting, and this contributes to hepatic encephalopathy. So if you think about it, clinically significant portal hypertension leads to the main decompensating events: ascites, variceal hemorrhage, and hepatic encephalopathy. So which of these is the most common decompensating event? And this is a natural history story by Dr. D'Amico and his group. This is cumulative. So 10% of the patient will die, but the most common by far, ascites in 33%. This is this curve here. Bleeding is next, and all the others are cumulative. So you can see how encephalopathy and jaundice are really, really very rare events, 5% and 3%. The most common by far are ascites, number 1, and variceal hemorrhage, number 2. Regarding with what decompensating event you started off with, you can see here how ascites, again, is the one that is associated with the highest mortality, with the highest one with ACLF, but ascites is the next one, and variceal hemorrhage down here. So ascites is not only the most common event, but it's also the deadliest event. So if you think about it, when we see a patient with compensated cirrhosis, we want to prevent decompensation. But it's not only variceal hemorrhage. For years and years, we've been saying, okay, let's prevent bleeding, when in reality, we should be preventing ascites, variceal hemorrhage, and also encephalopathy, by the way. But now we can stratify these patients. We can say who are the most likely to develop these decompensating events. So in patients with mild portal hypertension who are very unlikely to decompensate, then our goal is actually to eliminate the etiology. And with this, we have a chance for the compensated patient to revert to a non-cirrhotic stage, or at least to prevent them from evolving to a clinically significant portal hypertension. It's the patients with CSPH that we are worried about, because they are the ones that are the most likely to decompensate. And how are we going to prevent this from happening? We're going to do this by lowering portal pressure. So how are we going to lower portal pressure? For more than 35 years, we've been using non-selective beta blockers, and they're still clearly relevant. They act by decreasing this increased flow. So the traditional beta blockers like propranolol and nadolol act first of all by beta-1 adrenergic blockade that decreases this increased cardiac output. But the main effect is actually their beta-2 blockade effect, which causes spastic vasoconstriction. So that's why we need a non-selective beta blocker. On the other hand, carvedilol is a very special type of non-selective beta blocker. It not only has these two actions, but it also has an alpha-1 adrenergic blockade action that we think, there's a vasodilating action, that we think vasodilates the intrahepatic circulation. And therefore, in all the studies that measure portal pressure, carvedilol has a greater effect in lowering portal pressure than propranolol or nadolol. So the issue is, okay, so we know that beta blockers are good at preventing variceal hemorrhage. And like I said, for years and years, we were concentrating on preventing variceal hemorrhage. But do we know whether beta blockers will prevent ascites, which, as I said, is in a way the worst and the most common decompensating event? And the answer to this came with the PREDESI trial. So this was published in the Lancet at the end of 2019. And this was a randomized controlled trial that used beta blockers, either carvedilol or propranolol. And the goal was not preventing variceal hemorrhage, it was preventing decompensation or death. So decompensation, the primary endpoints were ascites, variceal hemorrhage, and encephalopathy. These were all patients with compensated cirrhosis and CSPH. They actually measured the HVPG, and they all had more or equal to 10, and they had no or small varices. They excluded patients with large varices because it would have been unethical to randomize them to a placebo. So these are very super compensated patients. They gave them And you can see here the main results, the beta blocker had a lower incidence of decompensation. Again, this was a composite endpoint. But if you look, this is the main results are up here. So overall, you can see here that it was 27% in the placebo group versus 16% in the beta blocker group. This was significant. But if you look at ascites was in itself the only decompensating event that was significantly different. Ascites 20% in the placebo group versus 9% in the beta blocker group. This was significant. And high-risk varices, remember these patients had no or small varices. The development of high-risk varices was also different. There was a 40% reduction in the beta blocker group. So, and they actually, because they measured HVPG later on in the trial, they could see that the risk of ascites was associated with a decrease in HVPG, so that 6% of the patients who had a decrease in HVPG developed ascites, which is very low compared to 24% in those in whom the HVPG was not reduced. So there's a totally post hoc analysis. They compared those patients. Remember, these patients were either on propranolol or placebo or carvedilol or placebo. So when they look at post hoc analysis, it seemed to be that the risk of getting ascites was much lower with carvedilol, and the risk of dying was also much lower with carvedilol. Again, post hoc analysis, and this had to do with carvedilol being more effective in lowering HVPG. A higher percentage of patients had significant lowering in the HVPG. So just so you know, what doses did they use? They used carvedilol 6.25 to 25, or propranolol, as we usually have been doing, from 40 to 160, titrated to the maximum tolerated dose, keeping heart rate above 55 and systolic blood pressure more than 90. So if they would titrate up as long as the patient did not get hypotensive or bradycardic. So you'll say, well, CSPH, these patients were selected based on measuring the hepatic venous pressure gradient, which is a nuanced method, but it's also an invasive method. So how is this applicable to clinical? But now, we now know that actually CSPH can be determined non-invasively. So the patient has varices on endoscopy. This patient by definition has CSPH. If on imaging, like CAT scan or MR, there are collaterals, there's also evidence of having CSPH. But even less invasive is liver stiffness measures with FibroScan, more than 25, and this is based on both ANTICIPATE studies and the Baveno studies. More than 25 rules in CSPH, and 20 to 25 associated with a platelet count of less than 150 also indicates the presence of CSPH. It has nuances in the obese patient, but you can look at this PONS trial here that has a nomogram to calculate the probability of the patient having CSPH. So these models in the obese patient and patient with NASH, these models overpredict the presence of CSPH, so you can use this nomogram. So this is a paradigm shift. This is not on the guidelines yet. This will be discussed in Baveno. So what do we do now? We have a compensated patient. We do an endoscopy. If they have moderate to large varices, we start a non-selective beta blockers, or we ligate those veins. If they're small, there's optional to give them non-selective beta blockers. If they have no varices, we repeat the endoscopy in 2 years. So what is the new paradigm? You have the compensated patient. Again, we're talking about compensated cirrhosis. We measure liver stiffness and platelet count. If they meet criteria for clinically significant portal hypertension, what we're going to do, we're going to start carvedilol, and carvedilol would be the preferable non-selective beta blockers to prevent decompensation. If they do not meet criteria for CSPH, then we just repeat the liver stiffness and platelet count on a yearly basis. Obviously, if the patient has intolerance or contraindications to non-selective beta blockers, we go back to the old paradigm and you do the upper endoscopy. A totally different thing, because in the existing paradigm, our goal is to prevent variceal hemorrhage. Whereas now, with the new paradigm, our goal is to prevent clinical decompensation. We're talking ascites, variceal hemorrhage, and maybe encephalopathy. Remember, again, we're talking about the compensated patient. In the decompensated patient, we have to go back to the old paradigm. in the old paradigm would include actually non-selective beta blockers or ligation if you have high-risk varices. And let me just talk a little bit about carvedilol in this setting. In this setting, carvedilol this was a retrospective analysis of a prospective study that shows here that over time, when they followed patients who had high-risk varices who were randomized to carvedilol, which is the red line, or to ligation, you can see that overall the risk of decompensation was lower with carvedilol, which is what we're showing now with the Predesi study, and also all-cause mortality was lower with carvedilol than with ligation. It makes sense because ligation is a local therapy, whereas beta blockers, you're lowering portal pressure. So even in the old paradigm, if I had to choose between beta blockers or ligation, I would clearly choose beta blockers. Now, what else can we do to increase to decrease portal pressure even further? We can act on resistance, and for this we have the structural component, which is the majority of which we cannot reverse. We cannot get rid of fibrosis, but there's a functional component, and statins work on this functional component, and they cause vasodilation by increasing nitric oxide inside the liver. And this is a proof of concept study. You can see here the placebo group had no reduction in HVPG, whereas the simvastatin group had a reduction at 4 weeks of HVPG. It was modest reduction, but it was significant. And as you can imagine, if you're dilating the intrahepatic circulation, there's going to be more perfusion into the liver, and this is what the ICG clearance showed, that you have actually an improvement in perfusion and improvement in liver function. We had been trying different vasodilators in the past, like nitrates, etc., but you can see here how they would all reduce mean arterial pressure, but in this instance, statins have no effect on mean arterial pressure, which is a good thing. In cohort studies, this is a VA cohort of patients with hep C cirrhosis. This is a propensity matched study, and patients that were statin users had significantly lower probability of decompensation and a lower probability of dying compared to non-users. And you see the specific events. You can see here how there was a 50% reduction in ascites and a significant, this is a 61% reduction in the risk of variceal hemorrhage in the patients that were statin users. There's now a VA vocal cohort study where we're already enrolling patients to see if we can actually reproduce these studies in a prospective trial. And there's future NIH-funded trials to prevent decompensation that are eagerly awaited as well. So more to come. Now, very recently, this is in the last month or so, there was this study on metformin. This was a single dose of metformin that showed that in the placebo group there was an increase of 4% in the HVPG, whereas in the metformin group there was a decrease of 16%. Metformin seems to also increase cyclic AMP and cause vasodilation inside the liver, as statins do. So, but however, there's another VA study that looked at in patients with cirrhosis and diabetes, there was no significant effect of metformin on reduction of HCC, decompensation, or liver-related death. So there's more to come about this, but we're having things in the future to see if there's anything that we can add to the beta blockers to reduce portal pressure even further. Now let's talk now about the decompensated patient with variceal hemorrhage. So we have a state of what I call further decompensation, where the patient who has bled has a recurrent bleeding or has a second event like ascites. Let's talk first about the treatment of variceal hemorrhage and where do all the procedures that we have work. So first of all, with hemorrhage, there's an increase in bacterial translocation that will make this vasodilation worse and will increase pressure even more. So in this setting, so just to have that in mind, remember there's hypervolemia that's driving, again, this increased flow and increased pressure. So you should not over-transfuse these patients unless they come in with hemorrhagic shock. If you tank them up, you're going to just increase the pressure and they're going to bleed more. Of course, we're going to give antibiotics because we want to prevent this bacterial translocation from occurring. And then we're going to start an intravenous vasoconstrictor. In our case, it's octreotide. We have nothing else. But do not use beta blockers. In this setting, you want to cause vasoconstriction. Beta blockers are going to blunt the heart rate response to bleeding. So we have to use an intravenous vasoconstrictor. And like I said, the only one we have is octreotide. I have seen patients that are started on IV labetalol. We should not do this because, first of all, it has not been shown that this actually works for active variceal hemorrhage. And of course, this is the instance where you want to definitely do something local to stop by ligating the varix that's bleeding. And finally, when there's non-response to the standard therapy, we have to use TIPS, and I will be talking on when to use TIPS. So these are the three main guidelines. These are the three main initial activities. You cautiously transfuse packed red blood cells, you use short-term antibiotic prophylaxis, and you use a safe IV vasoactive drug, and then you do an endoscopy within 12 hours, and you confirm that this is variceal hemorrhage. How do you confirm that this is variceal hemorrhage? So first of all, if you see a varix spurting blood, there's no question about that. If you see fresh blood around the varix or a clot overlying the varix, or if you see a varix with a white nipple sign, which is like an old clot. So these are clearly evidence of bleeding. But what is important to note is that if you find varices with none of these signs, but you find nothing else that could explain that bleed, there's no Mallory-Weiss tear, there's no ulcers, this is diagnostic of variceal hemorrhage, and those varices have to be ligated. So you do this, you do the endoscopic therapy, you continue, normally what you would do, you continue the IV vasoactive drugs and the antibiotics for 2 to 5 days, and then you, when everything is fine, you discontinue the IV drugs and start non-selective beta blockers. But there are instances where there's uncontrolled bleeding. You cannot control the bleeding, or you cannot even do the ligation. And then in this instance, you need a salvage TIPS. The patient is bleeding out. Something needs to be done immediately. On the other hand, let's say the patient responded very nicely to the ligation, they're not bleeding, but then they rebleed within these 2 to 5 days. This needs a rescue TIPS right away. Now, who are the people that need a rescue TIPS? So they responded very well, now they've rebled. These are usually child C patients. And this is what led, and if you think about it, the child C patient has bled once, has bled twice, and now you put a TIPS in there. So they may stop bleeding, but they have incredibly high mortality. And this led to the idea of what if these patients are likely to fail standard therapy. What if we preemptively put in a TIPS before they fail? And this is what we call preemptive TIPS. That used to be called early TIPS. So you're putting the TIPS right away after you do the ligation. The patient is fine, but you're preemptively putting a TIPS because you know that these child C patients are going to fail. So this is the concept of preemptive TIPS. Now, think about it. These two instances, the salvage TIP and the rescue TIPS, you don't care if they have or they do not have contraindications to TIPS. You just put it in because it's life-saving. Whereas for preemptive TIPS, you're thinking about it because the patient is okay. So, but you have to do it quickly. You have to do it within 72 hours, but you have to consider if the patient is a candidate or not for TIPS. And these are the patients that have been excluded from P-TIPS studies. Old patients, as I said, patients that are very sick, so they have a child score more than 13 points. If they have had overt encephalopathy or encephalopathy without precipitating factors, they have kidney failure, sepsis, heart failure, and pulmonary hypertension are important because they'll get worse with TIPS, so you have to do a cardiac echo. HCC beyond Milan and complete portal vein thrombosis you need to figure out, and so you have to do Doppler ultrasound or cross-sectional imaging. I would surmise that actually at this point, portal vein thrombosis is not such a contraindication for TIPS. And yeah, so this is what we have. So this is the seminal study of Garcia Pagan that looked at child C 10 to 13 points. So they excluded 14 and 15 points. And they included another group that has been very controversial, which is child B with active bleeding when you're doing the endoscopy. And they randomized them to preemptive tips versus standard therapy. You can see this is survival was significantly better in those with preemptive tips. And so the absolute risk reduction was 25%, half and half of each, child C and child B. Then the Chinese came. These are mostly hepatitis B cirrhosis, and they included not only child B with active bleeding at the time of endoscopy, they included every child B patient, so that in a way, only 22% were really the high risk patients, all the rest were child B. Nevertheless, they did show a difference in survival, a better survival in patients that got preemptive tips. But the absolute risk reduction was actually lower because they included less sick patients, so 13%. Now, these are mostly hepatitis, cirrhosis from hepatitis C or alcohol, whereas the Chinese were mostly hepatitis B cirrhosis. We don't know if this applies to NASH cirrhosis. NASH seems to be an entirely different concept, but we'll have to wait for that. And there's a recent small randomized controlled trial that was a negative trial. They included mostly alcoholic cirrhosis. And they could not find any differences in survival. And not only that, they found it difficult to do that tips within the 72 hours, and to do the tips per se. So this was a negative trial that highlights the problems that we have had in real life in doing preemptive tips. Now there's an individual meta-analysis that was just published at the beginning of this year that looked at all the studies. The problem is that there's only 2 randomized controlled trials that use standard of care. The Garcia-Pagan study that I just showed you in the Chinese study. But overall, the results of this meta-analysis show that, in fact, there was an improvement in survival with all the studies. Because they had individual data, they could actually build survival curves. And you can see here that the child C, 10 to 13 points, clearly they have a better survival. But when they looked at the child B patients that are the controversial ones, they found that if you had a B of 7 plus active bleed, there was no differences in survival. But if you had a B more than 7, so B is 7, 8, and 9 points. So you can see here that if they had child B of 8 and 9 points and active bleed at endoscopy, there was a survival benefit. Again, very post hoc. We have to wait for more data in terms. But the 2 candidates would be child C 10 to 13 and B more than 7. So when we did the endoscopy, so now the new paradigm would be the moment the patient comes in, you decide whether you have to be thinking. You do, is this a patient that's P-TIPS candidate or not? All right. So the P-TIPS should be placed within 72 hours. This is what it was called early tips. And it's the patient who came in with child C 10 to 13 points and perhaps child Bs who were actively bleeding at the time you did the endoscopy. These are perhaps the candidates for preemptive tips, but you also have to consider who are not preemptive tips candidates. These are child A patients, child B7 who are actively bleeding or not at endoscopy. So the early child B, you do not want to put at preemptive tips, and the 2 sick patients. So you continue the IV drugs for 2 to 5 days. If they bleed, you do a rescue tips. If there's no bleed, you start secondary prophylaxis. And the secondary prophylaxis was non-selective beta blockers plus ligation. And this is based on a million trials. I mean, this is the area of portal hypertension where there's more trials. And clearly, if you do not do anything after a bleed, 60% of the patients are going to rebleed, whereas the lowest rebleeding rate is in those that got ligation and non-selective beta blockers. However, all these trials were done without stratifying patients between compensated and decompensated, because at that time we just would put every patient with cirrhosis in there. So we had an opportunity to get the individual data of these trials. These were 4 randomized controlled trials that compared ligation alone versus ligation and beta blockers. And in child A patients, the compensated patients, it didn't really make a lot of difference. But in child BC patients, there was a definite benefit of combination therapy versus ligation alone. This is survival. So you can see here how In this case, non-selective beta blockers were the key component of combination therapy, particularly in child B and C patients. So you have to have the beta blocker in these patients to prevent rebleeding. Now, the compensated patients are the ones that are more likely to have ascites. And people have said that non-selective beta blockers are harmful in patients with ascites. And so this is a very nice study that looked at patients with direct responsive ascites or refractory ascites, and looked at heart function or renal perfusion pressure. And you can see here that in patients who have direct responsive ascites, the systolic function did not change after non-selective beta blockers. This was propranolol. And the renal perfusion pressure went lower, came down significantly, but went under the threshold that perfuses the kidneys only in one patient here. Whereas in patients with refractory ascites, the systolic function decreased significantly and the renal perfusion pressure also came down significantly, and half of the patients were under that threshold. So in the way you can see here that 55%, 11 of 20 patients went under this perfusion pressure, and 4 of them actually developed HRS-AKI. So that ain't good. So, but you also have to think that half of the patients did not go down, and this was entirely related to the mean arterial pressure. So in patients with refractory ascites, use non-selective beta blockers very cautiously, maintaining the MAP more than 65 and and systolic blood pressure more than 90. So what do we do if someone fails standard therapy with ligation and beta blockers? Where we do a TIPS. And TIPS is really very good at preventing rebleeding. In this study, which is the only study that used covered TIPS stents, you can see here that was 0 rebleeding. The problem with TIPS is always more encephalopathy. So TIPS is still recommended as second line in patients who have bled despite combination therapy with non-selective beta blocker and ligation. But I would think, and I wonder if Baveno is going to conclude this as well, that we have to think of TIPS sooner if the patient already has difficult to treat ascites, has portal vein thrombosis, or had been compliant to non-selective beta blockers before they bled. Maybe do TIPS in those patients. So this is, so in patients who have bled once, and the patient is on non-selective beta blockers and ligation, if the patient is child BC that does not tolerate the beta blockers, I would go directly to TIPS. If the patient rebleeds, clearly you have to do exactly the same thing that I indicated initially, and you do ligation and everything else, but the patient cannot leave the hospital before getting a TIPS. That has to be during that admission for a rebleed. If the patient has refractory ascites or complete PVT, I would also consider TIPS. But in these two instances, you have time to think about it. It will be in a semi-elective way. So what have I told you today is that in compensated cirrhosis, rather than screening for varices, we should be screening for clinically significant portal hypertension. And in these patients, portal pressure reducing strategies, non-selective beta blockers for now, can prevent cirrhosis decompensation. In patients with acute variceal hemorrhage, think of preemptive TIPS at the time of admission. Non-selective beta blockers should not be avoided, but should be used cautiously in patients with refractory ascites and discontinued if the systolic blood pressure is less than 90 or the MAP is less than 65. And consider TIPS. Think of TIPS earlier if the patient cannot tolerate non-selective beta blockers or has conditions that would otherwise call for TIPS. Thank you very much for your attention.
Thank you, Dr. Garcia-Sao, for that very informative talk. I'd like to remind the audience to send in questions. You can join by web by going to pollev.com or join by text. There you enter DeBakey, D-E-B-A-K-E-Y, or text DeBakey to 37607, and we'll be addressing those questions at the end of this session. We're going to go on to our next talk, and it is my pleasure to introduce our colleague, Dr. Joseph Galati, who's the Medical Director of the Sherry and Alan Conover Center for Liver Disease and Transplantation here at Houston Methodist Hospital. He is the Director of Liver Specialists of Texas. His clinical interests include chronic alcoholic liver disease, primary liver cancer, and chronic hepatitis C. He has over 25 years of experience treating liver disease patients, and he will be speaking to us today about when to refer the chronic liver patient for liver transplantation. Dr. Galati?
Well, good morning, everybody, and thanks again to Dr. Ankoma for inviting me to be on the program again today. Another great annual program that he's put on and directed, and want to thank all the organizers for all the hard work in pulling it together, especially with the COVID-19 restrictions and doing it virtually. But I think we're doing pretty well with it virtually right now, and hopefully next year we'll be back in person with everybody. So today's topic that I'm going to be talking about for the next 15 minutes or so is when to refer patients with chronic liver disease for liver transplantation. And this really is probably one of my most favorite topics to talk about, because when you think about it, the proper referral and the timing of the referral for a patient with decompensated liver disease truly is a life-saving decision that others are able to make to get them to the transplant program. So it's a very worthwhile topic and discussion to make sure everybody knows about this. So the main thing about when to refer, more importantly, we should be saying when to call. When do you need to call? And that is probably the most important thing. And through the years, what I've noticed is that many times the phone calls and the alerts that there is a patient that is sick, that is decompensating, that needs our help, just never comes, or it comes too late. So the most important message is you need to call to make that referral for a liver transplant. So key thing, always make that call. Now, one of the most important things about referring for transplant is we have to have an understanding of the facts as far as when patients should be appropriately evaluated and the myths. There's a lot of misunderstanding about liver transplantation, about the patients that are good candidates for transplant. And so part of our job every single day is to educate our colleagues and to help them to make the proper decision. Now, some of the things that I hear, some of the things that I've heard on phone calls is as follows. Many times we'll get a phone call or some questions about a patient at an outside clinic or an outside hospital, and they'll say, look, the patient is just too old. Well, 60 years old is not too old. Many times, and one of the more popular reasons for not calling or having hesitation is that they're still drinking. They have not gone through 6 months of sobriety, which I'll talk about a little later in the talk here. The patient is too obese. They're still smoking. They're not sick enough. I really do not think they're sick enough, so thus I am not going to refer them for transplant consideration. In many cases, these are ill-founded decisions that others make. So the key thing is you want to know the proper patient, the right timing, and the indications to send somebody on for a liver transplant evaluation and when to start the referral. Now, the main thing here to think of is that we want to have everybody cast as large of a net out there as possible, meaning we would rather get phone calls on patients that would be considered early rather than having such a narrow window for referral that patients that should have been referred never end up coming to us. And because of the nature of their liver disease and how sick they are, many times patients don't survive. So the key thing is throw the net out wide to catch as many patients as possible and then make the decision on how they should be evaluated. But if you're working with a net that's this small, this restrictive, you're going to miss appropriate candidates and lives will be lost. No doubt about it. So remember, cast the net out really wide for everybody. Now, if you look back a number of years ago, back to the 80s when liver transplantation was just starting out, mid-80s into the early 90s, we would, in a sense, list a different kind of patient. Many times we would evaluate patients and put them on a list strictly for a quality of life issue. This may be profound fatigue, or if somebody had a condition like PBC or sclerosing cholangitis, we would put them on strictly for intractable pruritus or itching. Their synthetic function was still good. They were still functioning at a high level, but had no life-threatening complications. But yet, For quality of life, we would refer patients. Now, that whole system has changed a number of years ago, and everything we're doing now is based on the MELD score, which again, I'll be talking about in a minute. So a certain way that I'd like you to think about how to refer patients for transplant, there has to be a certain gestalt. How are you thinking about this? And there's really two major concepts here. One is to look strictly at the complications that these patients have had, regardless of the disease that they have, whether they have hepatitis B or hepatitis C or autoimmune hepatitis. The disease itself does not dictate the need for referral. So think of it really at a high level. What are the complications that this person has had? Not necessarily the disease they have or the underlying condition. So think complications versus the disease. They do meet in the middle, but as I'll show you, we really want to look at patients that are having significant complications from their cirrhosis and portal hypertension. Now, if we look strictly at the list of conditions that we may evaluate, or conditions that lead to cirrhosis and portal hypertension and complications, it's sort of a long laundry list of the usual suspects. There's viral hepatitis, an assortment of autoimmune diseases, bile duct disorders, alcohol-related liver disease, drug-induced liver injury, drug overdose from, let's say, acetaminophen, amyloidosis, there's primary oxaluria, liver cancer, be it hepatocellular carcinoma or cholangiocarcinoma, are indications and diseases that would warrant transplant. And of course, things like cystic fibrosis. But this is just a laundry list to be aware of, that these conditions may at some time progress to the point of needing transplant. But today, the main way to think about referring for transplant is an index complication, which is listed here. It may be the development of ascites, hepatic encephalopathy, a confusion state with an assortment of neuropsychiatric complications. If they have a variceal bleed, or if they develop hepatocellular dysfunction to the point where their MELD score is 15 or greater. So these are the index complications that you need to be aware of. Now, the other term that we like to use a lot is, when we look at our patients with liver disease, it's determining whether or not they have had impairment of their underlying hepatic synthetic function. And the things to look out for are low serum albumin, the development of ascites, a prolonged INR, and the development of hepatic encephalopathy. So sometimes in the conversation, we will be talking to other colleagues or amongst ourselves and say, this patient has significant loss of hepatic synthetic function. What we're talking about is low albumin, prolonged prothrombin time, and maybe they've developed hepatic encephalopathy. Now, you've heard me talk about the MELD score, and that stands for Model for End-Stage Liver Disease. There are 4 lab values that we measure the MELD score by, and it includes bilirubin, the creatinine, the serum sodium, the INR, and there's a question on the online calculator with regard to whether or not they are on dialysis. Now, there are numerous online MELD score calculators, and all of them are fine. And by plugging in these 4 numbers, answering the question about the role of dialysis, you will get the patient's MELD score. Now, the MELD score is important because it is going to give you a rough estimate of the 3-month mortality for this person. And the interesting thing here is, if the MELD score is increasing, the higher the number, the survival goes down, mortality goes up. Now, the inflection point in the MELD score seems to be around a value of 15. And you could see on this curve that the patient's survival is pretty good, close to 100%, until they reach about a MELD score of 15. And then at that point, there is a progressive downward slide in survival, and that is why the MELD score 15 for transplant is one of those pivotal numbers that we use to guide the need for evaluating and referring a patient for transplant, and then ultimately putting them on the transplant list. So for referrals today, how do we look at all this? Well, certainly patients that have fulminant hepatic failure, those are patients that urgently need to be referred for transplant. Worsening renal function in the setting of chronic liver disease, if they are developing hepatorenal syndrome, type 1 or type 2, which is associated with a high mortality, and so we want to get these patients referred sooner than later. Any sort of rapid decompensation in a cirrhotic. So maybe there's a cirrhotic that you've been taking care of that has been doing relatively well, but at the first sign that they have an abrupt decompensation, it is time to get them referred for transplant. Typically, this abrupt decompensation is going to be associated with a rise in their MELD score. Many times, patients that have sclerosing cholangitis, again, they may be doing relatively well and stable, but if they are getting into a problem where they are having recurrent bouts of cholangitis, again, red flag, they should be referred for transplant at that time. And in a similar fashion, patients with acute alcoholic hepatitis should be considered for liver transplantation as well, due to the potentially high morbidity and mortality that's associated with this. Now, of course, there is a list of contraindications to liver transplantation. When should we not think about transplant? Well, of course, MELD scores less than 15. This comes from the AASLD guidelines, but I would say sort of less than 15. I would not use that as a hardened rule to say, well, the MELD score is 14, so I'm not going to refer to them. I think you have to keep in mind 15 or greater is a definite, but less than 14, less than 15, certainly we do evaluate a lot of patients in that category. And of course, patients that have severe cardiopulmonary disease, they have HIV/AIDS in many cases, ongoing alcohol or illicit substance abuse is a contraindication, uncontrolled infection, and malignancy outside of the liver would be a contraindication. Now, a few final comments before we wrap this up here. What do we do with this patient, the alcoholic? And if I would say there is one topic or one type of patient that creates the most misunderstanding, it is what to do with the alcoholic patient, especially somebody that has been actively drinking or recently drinking. Now, the sad thing is study after study has shown that roughly 95% of patients that are actively drinking are just never referred for liver transplant consideration. There's never the suggestion to call a transplant program to get their thoughts on what to do with these patients. And each one of these patients with alcohol use disorder present different challenges, and it really is not a one-shoe-fits-all. And one of the conversations that we have on a regular basis is that this is a self-induced problem. Why should we refer a patient for transplant if their alcoholism was a self-induced problem and they're only going to drink again and destroy their liver? Well, what I always like to say is, if we're on the topic of self-induced diseases, what about smoking and all of the lung disease, the heart disease and lung cancer that that creates? We're really not wanting to withdraw or hold back therapy on smokers. If they need chemotherapy, if they need surgical resection of a tumor, if they need treatment for COPD, we gladly give it to them. We never really enter into the equation, well, you have been smoking, so we're not going to treat you properly. Same thing for heart disease. How much of heart disease is due to lifestyle changes or lifestyle decisions that people have made? Diabetes that was not well controlled. Their diet was atrocious. They never exercised. They were obese and never really stepped up to try to lose weight. Smoking also is a major contribution to coronary artery disease, and of course, uncontrolled hypertension. So again, there are many, many conditions that we treat that are self-induced or self-inflicted, similar to alcohol, but yet we do not have that bias against the alcoholic patient. And that really is problematic because so many patients that could potentially be evaluated and saved are simply just not referred. And again, one of the conversations we hear is that a particular alcoholic patient was not referred because of the 6-month rule. And this is something that was developed in the earliest days of transplant. And what was initially discussed was if patients had alcohol-related liver disease and cirrhosis, that they had to remain abstinent in a program for a minimum of 6 months. There are even some programs around the country that will say 1 year. Unfortunately, none of this is really rooted in research. And while there are some benefits of remaining abstinent, certainly, it should not be a universal decision to say a patient with alcohol-related liver disease should not be referred if they do not have 6 months or longer of sobriety. And so in summary, when you are looking at referring a patient for transplant, what are the things that you should be thinking about? Well, number one, has the person had an index complication? Have they developed ascites, variceal hemorrhage, or developed hepatic encephalopathy? The second thing is their overall clinical course. Is it worsening? Has there been a rise in their MELD score? So understanding the MELD score, how to calculate it, what lab values are associated with the MELD score will help you along in understanding that. And lastly, we would rather receive more phone calls, more inquiries for early cases rather than have a single patient not referred because of some misunderstanding or not realizing that that kind of patient would be a very suitable candidate for transplant. Thanks very much. I hope you have a great morning and an excellent conference through the rest of the day. Thank you very much.
Thank you, Dr. Galati, for that excellent talk. Before we proceed with our next speaker, we'll take a couple questions. And maybe we can start with the first one on the bottom. So this question is probably for Dr. Garcia-Tsao. Patient who has liver cirrhosis and has been compensated, is there any role for preventive tips?
The answer is absolutely not. All right, and I'll show you why. And this comes with why. Did you hear me? And this goes to why hepatic encephalopathy is a high complication of TIPS. The compensated patient is totally fine. They look like any of us sitting here. They have no ascites, no encephalopathy, no variceal hemorrhage. If you can show this slide now, yes. Let me show you this slide. This is what TIPS is like, all right? Hold on 2 seconds. This is TIPS. It's a bridge, it's a metal stent that bridges the hypertensive portal vein with the normotensive hepatic vein. It's great because it decompresses all the varices all the blood is now going away from the varices and into the systemic circulation. The problem is that you're deviating blood flow away from the liver. So it decompresses the varices, it normalizes portal pressure, but by shunting blood away from the liver, it can lead to hepatic encephalopathy and liver insufficiency. So in a patient who's totally compensated, it's almost a mortal sin to put in a TIPS. You are only going to give them liver insufficiency because now the liver is not getting blood. And already Dr. Kola said how important it is to have flow to the liver. So definitely not. And this is the reason they get encephalopathy, because the liver metabolizes ammonia, and if you're deviating blood away from the liver through this shunt, you're going to get more ammonia to go into the systemic circulation and more encephalopathy. So that's why we should not put a TIPS in a compensated patient, and this is why you get encephalopathy. This is the main complication, the bane of the existence of TIPS when we put it in for refractory ascites or we put it in for variceal hemorrhage. The problem is exactly encephalopathy.
Thank you. And another question, and this comes up quite often, the question is, do you consider liver transplant evaluation simultaneously as you're considering TIPS? Sometimes this is not even the inpatient scenario, it might be the outpatient for the refractory ascites. Do you automatically evaluate for transplant if you're considering TIPS?
So because of this problem with TIPS, right, especially in a patient with variceal hemorrhage, especially if the patient, for example, just has variceal hemorrhage and no ascites, because this can happen. That's why variceal hemorrhage is not, if the patient does not have ascites, I'm cool with that, and I would put it at TIPS in without even considering liver transplant. But if it's for refractory ascites, and you're afraid that by putting a TIPS in, you're tipping this patient who already has refractory ascites to having now liver insufficiency or more encephalopathy, it may be good to have them already being at least considered for liver transplantation.
Excellent, excellent. I guess we can move away from TIPS and ask a separate question on spleen stiffness. I know you mentioned liver stiffness. Is spleen stiffness slowly growing in data? How do you see that as in our clinical practice? How do you like using that?
So many, unfortunately, many centers in the U.S. don't even have liver stiffness. Do you see what I'm saying? So spleen stiffness, bottom line, there's not enough evidence to look at spleen stiffness. The anticipate studies all looked at liver stiffness. So spleen stiffness, I think is I think that we need more studies to figure out if that will also let us know. But it may be, because the platelet count is a measure of hypersplenism. So spleen stiffness in a way could help us more in determining whether the patient has clinically significant portal hypertension or not.
Excellent, excellent. Excellent. I think we'll return to our talks and we'll take more questions a little later. So our next speaker is Dr. Chris Cowley, who's the director of Liver Institute Northwest. He's a clinical professor there at Elson S. Floyd College of Medicine at Washington State University. Dr. Cowley is internationally recognized as a clinician, educator, and researcher in liver disease. He's had several major international clinical trials of new treatments for hepatitis C, primary biliary cholangitis, primary sclerosing cholangitis, and NASH. His translational and laboratory research focus on role of iron as a cofactor in NASH and novel murine models and biomarkers for NASH and PSC. Today, he'll be talking to us on what is new in metabolic liver diseases, focusing on hemochromatosis, Wilson's disease, and alpha-1 antitrypsin. Welcome, Dr. Cowley.
Thank you so much. Can you hear me?
Yes.
Great. I want to thank the organizers for the invitation to present this talk, and I'm sorry I'm not there in person. And I look forward to being there in person at another time. And the agenda looks fantastic, and I congratulate you on another successful conference. So my task is to talk about what is new in metabolic liver disease. I have to cover hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency. And so we've known about the mechanism of inorganic iron transport for many years. And the absorption of iron requires a very coordinated process that begins with first iron being reduced from 3+ to 2+, and this is done by a enzyme in the brush border of the intestinal absorptive cell called B site B, or ferric reductase. And this sits right next to DMT1, which is divalent metal transporter 1. And this is a transporter for iron, copper, manganese, many other divalent metals. So the iron is reduced to 2+, enters the absorptive cell, where it can either be used for energy or metabolic processes, can be incorporated into ferritin, or can go through the absorptive cell and then cross to the basolateral side and exported through the basolateral iron export protein called ferroportin. And this sits right next to hephaestin, which is named after the Greek god of iron. And hephaestin is a peroxidase, which then oxidizes iron back to 3+ so that it can then be absorbed. And a tremendous amount of research over the past 5 to 10 years has really clarified the role of hepcidin a 25 amino acid circulating peptide as the master regulator of iron metabolism. And for those that are interested in reading more about this, we just published a review article in Hepatology Communications, which is the ASLD's online journal, and has nice figures and a detailed description of hepcidin. But hepcidin is produced in the liver in response to both tissue and circulating iron stores and secreted into the circulation, and then does a variety of things. Hepcidin is responsible for blocking absorption of iron in the intestine. And how it does that is by binding to ferroportin. And by binding to ferroportin, ferroportin is then internalized and degraded. So now iron does not have a mechanism for getting out of the cell. So the intracellular iron concentrations increase. And as a compensatory response, iron absorption is turned off at the mucosal level. And so this is how iron absorption is controlled and iron stores are regulated. Hepcidin is also important because it blocks release of iron from macrophages and reticuloendothelial system cells that also store iron in the spleen and other organs. So the way hepcidin works is it's induced, binds to the export protein, internalizes the export protein, and blocks absorption. So when you have low hepcidin, you get increased iron export and therefore increased iron import. And when you have high hepcidin, you block the process and you don't absorb or release iron from absorptive cells. So this is how the whole process works. Now, we know a great deal more, and this is what's new, if you will, in iron regulation. So we know that there are two different types of absorptive cells. There are cells that absorb two different types of regulatory cells. One type of cell is on the hepatocyte sensing circulating iron stores. And then there's another type of cell that senses tissue iron stores. So tissue iron stores are sensed by sinusoidal lining endothelial cells, which secrete BMP6 and BMP2 in response to increased iron. And by contrast, circulating iron is sensed in the hepatocyte by a combination of HFE, hemojuvelin, and transferrin receptor 2 and transferrin receptor 1. And these bind to these receptors called ALK2 and ALK3, resulting ultimately in phosphorylation of this complex of SMAD proteins, 1, 5, and 8. Once they're phosphorylated, they're activated, they enter the nucleus where they bind to hepcidin promoter regions and increase the transcription and therefore translation of hepcidin. And so this interaction between HFE, TFR1, TFR2, and hemojuvelin ultimately by phosphorylating SMAD158 increases hepcidin expression. The key deficiency in hemochromatosis is that this mutant HFE protein is trapped intracellularly, so it's not able to make it out to the cell surface on the hepatocyte, and that leads to a dampened hepcidin response to circulating iron. So you don't have enough hepcidin for the amount of body iron stores, so you turn off the inhibition of iron absorption, leading to unregulated iron absorption over time, ultimately leading to increased tissue iron stores. Now, we have many other forms of hemochromatosis other than type 1 hemochromatosis, and that's why we need to classify iron disorders in a more detailed manner. First of all, it's always important to remember for a clinical hepatologist or gastroenterologist that you have primary and secondary iron overload disorders. And to an iron expert, a primary iron overload disorder is where you have increased iron that is related to hyperabsorption of iron from a diet that is not secondary to some response. It's not iatrogenic, and it's not related to a compensatory response to an increased need to produce red blood cells. Hemochromatosis would be the classic example of that. Secondary iron overload, by contrast, is something we see much more commonly if we practice in a transplant setting, because we know that patients with cirrhosis, patients with decompensated liver disease, and interestingly, patients who have had a portosystemic shunt all have increased iron in the liver. The mechanism by which portosystemic shunt leads to iron overload is still unclear and has not been sufficiently studied. And then there are other iron overload disorders, for example, transfusional iron overload or iron overload due to excessive iron administration, for example, in patients with end-stage renal disease. I mentioned iron loading due to liver disease, and the reason that iron overload occurs in 4 to 10% of patients with end-stage liver disease is that you actually have a situation where you have hepcidin synthesis and transcription reduced because you have reduced hepatocyte mass. So that's a reason that iron overload occurs in end-stage liver disease. The other reason that iron overload can occur in liver disease is in patients with alcohol use disorder, where chronic excess alcohol use actually suppresses at the enzymatic level production of hepcidin. And this is an explanation why we often see patients with alcohol liver disease frequently presenting with iron overload manifestations and sometimes confused with hemochromatosis. Now, when you take primary iron overload disorders, these are classified using the online Mendelian inheritance in man classification system into type 1, type 2A, type 2B, type 3, and type 4. I just gave you a very, very quick overview of how iron absorption is regulated at the hepatocyte level. And I mentioned hemojuvelin is a transmembrane protein in hepatocytes that is involved with iron sensing. And I mentioned hepcidin as the master regulator. And I also mentioned transferrin receptor 2, and a balance between TFR1, TFR2 is key to detecting the level of circulating iron. So mutations in all these various proteins can lead to iron overload. The final common pathway, just for the purpose of simplifying the mechanism, is a inappropriately reduced hepcidin production for body iron needs, and therefore unregulated hyperabsorption of iron. So type 2A and type 2B result in juvenile hemochromatosis. So these are disorders where patients present with severe iron overload at a much younger stage in life, and I'll talk about this briefly. And then ferroportin associated hemochromatosis is divided into two categories that I'll mention briefly. So this is from our American College of Gastroenterology practice guidelines. It was published a couple of years ago. And the classification system is a little bit more detailed here, but it's good to know for the boards. And type 1A is what we refer to as classical hemochromatosis. And this results in a cysteine to tyrosine substitution at amino acid 282. It is a homozygous mutation in the vast majority of cases and is autosomal recessive and leads to the classic findings of hemochromatosis, where patients present in their 40s and 50s. Men are affected more than women, and it's generally a moderate phenotype. Type 1B is the other type of hemochromatosis associated with HFE relatively commonly. This represents about 7% of phenotypic hemochromatosis cases. And here you have a compound heterozygous mutation with C282Y and H63D. It's also autosomal recessive with a very similar phenotype, but generally milder. And then there are some other mutations, for example, S65C. This is not considered to be associated with clinically significant iron overload in the absence of another cofactor. For juvenile, you have mutations in hemojuvelin, autosomal recessive, mutations in HAMP, autosomal recessive. These result in much earlier onset of disease, severe endocrinopathies, and cardiomyopathy. Type 3 hemochromatosis is associated with transferrin receptor 2 mutations. It's also autosomal recessive and is intermediate in phenotype and age of presentation between hemochromatosis type 1 and hemochromatosis type 2. And type 3 hemochromatosis, I mentioned. Type 4 is interesting because there are two mutations and two different phenotypic presentations. Type 4A, some argue, should not be called hemochromatosis, but should be called ferroportin disease. And This is a loss of function mutation in ferroportin. And these patients will have iron deposition in the spleen. They don't tolerate phlebotomy very well. They have high ferritins and frequently do not have elevated transferrin iron saturation. And type 4B, or non-classical ferroportin disease, is associated with a gain of function mutation in ferroportin, where a ferroportin cannot be internalized after hepcidin binding. So this is resistance to hepcidin, and these patients will develop fatigue and joint pain and may not develop the classic features. So some people call this non-classical ferroportin disease, and some people call type 4A more classical ferroportin disease. So the putative gene for hemochromatosis has been known for a long time. We know this gene encodes a non-classical HLA class 1 protein, and there are 2 mutations I've already mentioned. Now, one very important aspect of doing genetic testing in patients with suspected hemochromatosis is, although in the early days of recognizing hemochromatosis, I and others used to lecture that, in fact, there's no point in doing hemochromatosis gene testing in patients who are not of Northern European descent. And all of the initial surveys showed that if you look at patients with the phenotype of hemochromatosis, high transferrin iron saturation, high ferritin, increased liver iron stores, the vast majority were C282I homozygotes. Whereas if you look at Mediterranean populations or more heterogeneous populations in the US, you see much lower likelihood of C282I homozygosity in patients with the phenotype of hemochromatosis. So, for example, this mutation has not been described in Asian or Asian Pacific populations or native populations, but it is now clear that there are random cases everywhere where patients have this mutation. And therefore, I think it is reasonable to do HFE gene testing in any patient, regardless of their racial ancestry. Now, we know that the gene mutation patterns in HFE hemochromatosis are very clearly associated with the phenotype. So C282Y homozygotes is the most common mutation. They have the highest level of liver iron content. The iron deposition in the liver is uniform and represent the majority of Caucasian patients. The compound het or compound heterozygote C282Y863D comprises pretty much the remainder, 1.5 to 7%. They have lower liver iron content, and the S65C and 863D mutations are unimportant. They may lead to iron overload only in the presence of another risk factor. We published this paper many years ago, but it illustrates a key finding, which is that if you look at the C282Y homozygote, the compound heterozygote, and all other genotypes for HFE, and compare their liver histology, you can see that the C282I homozygotes have the cleanest, if you will, phenotypic presentation. They have very little iron in Kupffer cells or mixed pattern of iron staining. They have very little inflammation and very little steatosis. Whereas if you look at the C282I863D compound het and other genotypes, you see that there's a much greater heterogeneous deposition of fat, inflammation, and mixed pattern of iron staining. What does this tell us? It tells us that if a patient is not a C282I homozygote, we should look for another cause. You want to be more careful about looking for viral hepatitis. You want to be more meticulous about taking an alcohol history, maybe considering NASH, etc. So juvenile hemochromatosis, what are the key features? Early onset of disease, no gender predominance of men versus female, dramatically increased iron stores, clinical symptoms similar to HFE hemochromatosis, with hypogonadism and cardiac disease being the most common, and premature deaths due to cardiac disease being the mode of mortality for many patients. TFR2 or type 3 hemochromatosis, relatively rare in the US, but described in Portugal, Italy, and Japan, similar to type 1 in terms of degree of iron loading, pattern of iron deposition, and response to phlebotomy, but possibly earlier age at onset. And ferroportin disease, if you will, is the one that's associated with isolated hyperferritinemia, normal or only slightly increased transferrin iron saturation, iron accumulation in Kupffer cells, tolerate phlebotomy poorly, which makes sense because they cannot get iron out of the cells because the ferroportin is not functioning properly. And it's generally less severe than HFE. Let's talk about diagnosis. So these are familiar to most in the audience, but I just want to review a couple of key points. Most would agree that we start with transferrin iron saturation, unsaturated iron binding capacity, and serum ferritin to determine, is this patient at risk for hemochromatosis? That is determined by transferrin saturation. Is this patient got iron overload? That's determined by ferritin. The next test in a suspected hemochromatosis case is to do the HFE gene test. This is a PCR test, so it's only going to tell you whether the patient has the mutation or not. And most of the panels that you order the test in will test the C282Y, the 863D, and the S65C. And some of you may have seen, I see this 2 or 3 times a year, where a patient gets the 23andMe test, finds out that they're homozygote, and presents for a further evaluation. So you need to be able to look up the SNP and compare it to what the gene mutation actually is. Now, once a patient has been confirmed to have HFE-associated hemochromatosis, meaning they're C282I homozygote or compound heterozygote, you do not need to do any other test to make a diagnosis. You've already made the diagnosis. So then you need to determine, does this patient have advanced fibrosis in the liver or not? Because that determines their risk of cancer. So historically, we used to do a liver biopsy in patients who are HFE positive to determine prognosis based on fibrosis stage. And in patients who, of course, you've done the HFE gene test and they're not C282I homozygote or compound heterozygote, then what can you do? Well, then you historically would do a biopsy both for prognosis and for diagnosis to determine, does this patient really have increased iron in the liver or just suspected iron based on ferritin? This is very important because ferritin very typically is elevated in NASH, very typically is elevated as a acute phase reactant, and does not always reflect increased body iron stores. So now there are some new tests like FibroScan and MRI that I'll talk about in a minute to determine iron content in the liver. But the important point is that if you do not confirm HFE hemochromatosis based on a genetic test, you really want to make sure the patient truly has iron overload in the liver before giving them a diagnosis of hemochromatosis. Now, if you do a biopsy, and this is a kind of thing that would appear on the boards, and you see something like this, this is Pearl's Prussian blue. You see a beautiful pattern of iron staining, starting with the periportal hepatocytes as shown on the right, and with a decreased density of iron staining as you get through the pericentral hepatocytes. And this is a fine reticular pattern of iron staining with very little iron in bile duct cells and reticuloendothelial system cells until the disease is more progressed. By contrast, if you look at the other forms of hemochromatosis, you can see, for example, in juvenile hemochromatosis, here associated with hemojuvelin, huge amounts of iron. Again, most dense in the periportal hepatocyte, but you see how different this is from what I showed you on the last slide. And then when you look at type 3 or transferrin receptor 2 hemochromatosis, you can see based on the stainable iron pattern here, very similar to HFE hemochromatosis, maybe a little more dense and maybe a little more a greater gradient. And then when you look at ferroportin disease in early stages, you can see the iron is all in macrophages, very little iron in hepatocytes. But then as the disease gets to very late stage, then you start to see spillover into hepatocytes as well. So the histology can be helpful in patients who are not C282I homozygotes. Now, MRI scan has become a very important second-line test in assessing patients before we go to a biopsy. And why is that? MRI utilizes the characteristics of iron being paramagnetic. And therefore, when you do an MRI, you're giving a high energy radio frequency pulse to the liver, you excite all the protons, and then the protons eventually will relax back to equilibrium. That relaxation time is quantifiable. And it was discovered that the relaxation time is inversely related to the iron content. So the faster the relaxation time, and here shown as S to the -1, compared to the biopsy iron concentration, you can see an R value of 0.96, which is pretty phenomenal. And even at very low levels of liver iron content, normal being up to 2 milligrams per gram dry weight of liver, you can see the transverse relaxation rate correlates very well. This is the inverse of the correlation of the relaxation rate, correlates very well with biopsy iron concentration. So this is one test called Ferroscan, which is commercially available. But most of you who practice in a setting where there's sophisticated MR available will have something called MRI T2 star, which also can give you the same answer and doesn't require the Ferroscan. Now, I mentioned you might need to do a biopsy for prognosis, because we know in hemochromatosis, when a patient has cirrhosis, their risk of liver cancer is dramatically increased and not eliminated by phlebotomy. Are there non-invasive tools we can use to determine who is at increased risk without doing a biopsy? Well, we published a paper now many years ago, and there were 4 or 5 papers that all came out about the same time, all showing very similar things, showing that if you take patients who have the phenotype of hemochromatosis and classify them into cirrhosis or not, if a ferritin at the time of diagnosis is less than 1,000, their likelihood of having advanced fibrosis is less than 2%. Whereas if their ferritin at the time of diagnosis is greater than 1,000, their likelihood of having advanced fibrosis is well over 40%. And this was in one series, and other series have shown slightly different numbers, but the concept is the same. Using serum ferritin as a tool to look at what the patient's risk is in terms of advanced fibrosis after you've confirmed based on genetic testing makes a lot of sense. Because if a patient has a low liver iron has a low ferritin level and confirmed to be C282I homozygote, those patients don't need a liver biopsy. Now, what are our goals of treatment? That hasn't changed much in many decades. Our goal is phlebotomy therapy to reduce the ferritin to less than 50, reduce the hematocrit to 75% of baseline, to avoid vitamin C supplementation, which dramatically increases the absorption of iron by acidifying the duodenal contents. Now, there are other therapies that are currently being developed, such as small molecule hepcidin mimetics that are given subcutaneously, and other types of small molecules, and oral iron chelators, such as deferricyrox, for patients who are anemic and have hemochromatosis who cannot tolerate phlebotomy. Now, it's important to counsel patients about modifiers of disease expression, and far and away the most important is alcohol consumption, which dramatically increases iron absorption by suppressing hepcidin even further. There's a syndrome called dysmetabolic iron overload syndrome, which is associated with insulin resistance, where iron overload can occur. And excess iron and vitamin C intake, of course, can increase iron absorption. We do not usually recommend a vegetarian diet or avoiding meat to avoid iron overload, because one phlebotomy will remove 250 milligrams of iron, which is about 10 times what you would get, 20 times what you would get in a meal. And so you can remove a lot of iron by phlebotomy. And so we don't necessarily counsel patients. But those that want to reduce their phlebotomy intake are on the border of needing phlebotomy can sometimes, by becoming vegetarians and avoiding excess sources of iron, can in fact mitigate their need for phlebotomy. So in summary, the workup for iron overload in the current era hasn't changed much. First test is transferrin iron saturation. If it's greater than 45%, genetic testing. If they're homozygote or compound heterozygote and ferritin is less than 1,000 and their liver tests are normal, then you can essentially follow them if their ferritin is normal, because you'll see many patients diagnosed early now because they have family screening. If they have an elevated ferritin, you can begin phlebotomy. Regardless of their genotype, if their ferritin is greater than 1,000, we recommend a liver biopsy, although some are using MR elastography or FibroScan. The key point with those is that iron can falsely make the liver stiffer on FibroScan and on MRI. So if the number is low, you're good. But if the number is high, then you might need a biopsy. For patients who do not have this genotype, Currently, genetic testing for other forms of hemochromatosis is not widely available. We just published a review article that is on PubMed, came out a few days ago for testing for 2 to 4 hemochromatosis, but these are specialized labs. In the remaining minutes, I'd like to give you an update on alpha-1 antitrypsin deficiency and Wilson disease. So the pathogenesis of alpha-1 antitrypsin deficiency is a single amino acid substitution that causes a glutamic acid to lysine substitution at amino acid 342 of the alpha-1 antitrypsin protein. This mutation leads to a folding change in the amino acid, and therefore, because the amino acid is, because this mutation leads to this folding change, the cleavage site for this polyprotein is hidden from the protease. And therefore, you form this very, very big polymer that is growing and unable to be cleaved into its appropriate polypeptide. And therefore, you get accumulation of alpha-1 antitrypsin in the endoplasmic reticulum that is unstable and therefore polymerizes and cannot go through the secretory path to get out of the liver. And here's a pathophysiology of alpha-1 antitrypsin deficiency from a very nice recent review by Pram Mistry from Yale. And here's the mutation leading to protein misfolding. There are protective mechanisms that can unfold the protein that affect the rate of polymerization. And then you get binding to chemical chaperones, you get macroautophagy, and targeted protein destruction. This is the mechanism that are protective. And this is why fever, concomitant hepatitis C, and alcohol consumption can all suppress the protective mechanism breaking down the protein. Once the protein polymerizes, it gets stuck in the endoplasmic reticulum. That leads to oxidative stress, apoptosis, and activation of profibrotic pathways, leading to asymptomatic elevated liver enzymes. And then when this occurs in the very early neonatal period, infants frequently will start with elevated enzymes and then compensate with the protective mechanism and not develop symptoms. Often a second hit is needed, but not always. And these are some of the typical characteristics such as smoking, chronic other diseases leading to progressive liver damage and cirrhosis. So it's important to start by phenotyping or genotyping patients who have a low alpha-1 antitrypsin level. The most common phenotype associated with liver disease is the PiZZ, but up to 75 allelic variants have been described. It is important to know that a patient may have a low alpha-1 antitrypsin level and have PAS positive diastase resistant globules in the liver, but still may not have that as the reason for alpha-1 antitrypsin deficiency. I just saw a patient with metabolic syndrome, type 2 diabetes, central obesity, hypertension, hyperlipidemia, who also has the PiSZ phenotype, but has an alpha-1 antitrypsin level that is almost normal and has increased globules in the liver, but clearly has NASH-related cirrhosis. Generally in PiZZ and most cases of disease, you have 10 to 15% of normal values. But remember, alpha-1 antitrypsin is an acute phase reactant and therefore may increase 3 to 4-fold during acute inflammation, and therefore may be falsely high when you're working up the sick inpatient with liver disease because they're very ill and their alpha-1 levels may be elevated. Unfortunately, there is yet no available therapy, although clinical trials with some therapies are underway. This is what the biopsy looks like. If you see this on the boards and you see the PAS positive diastase resistant as a Q, then you know that's the diagnosis. You may see chronic liver disease, not just in ZZ, but also in SZ, the Malton mutation, and even in MZ, which is a heterozygote. And as I mentioned, self-limited hepatic dysfunction is not rare, 15 to 19% at 2 months, and about 1% at 12 months. So there's a lot of protective mechanisms that kicked into the healthy newborn to prevent them from getting chronic disease. One of the important factors to keep in mind is that coexistent liver disease and alpha-1 antitrypsin deficiency has been well described, and they're overrepresented in cases of cirrhosis, you can see here, and in cases of chronic liver disease. So when you look at transplant series, for example, there's a higher proportion of alpha-1 antitrypsin globules, and it probably means that it's another cofactor that can accelerate disease with other chronic diseases. Here's a useful slide on testing. Start with the family history, neonatal cholestasis or hepatitis, cryptogenic cirrhosis, or unexplained cancer. Consider a biopsy. Here's the levels. Low is less than 100, normal is 100 to 200, high is greater than 200. And you can see phenotypic testing is appropriate, and you get intermediate levels in SZ, overlapping with MZ, but also overlapping with normal. And so you can see that in most cases of which is normal, the levels are greater than 100. Phenotype testing is the next goal, is the gold standard, and genotypic testing for the SERPIN1A gene. SERPINA1 gene is the gene that is the gene of interest, and sequencing is available. In the closing minutes, let me talk about Wilson disease. The pathophysiology is related to copper overload. The gene is localized to chromosome 13 and codes a P-type ATP7B, and resulting in decreased biliary copper excretion, leading to hepatic copper accumulation and copper in extrahepatic sites being deposited. So the regulation of iron metabolism is at the level of absorption. The body does not have a mechanism to get rid of iron. That's why we do phlebotomy. The regulation of copper metabolism is at the level of biliary excretion. So it's when the excretory process through the bile ducts is impaired, in this case, by this mutation in ATP7B, that you get copper overload. The clinical features, as you know from previous review courses, include neurologic, chronic active hepatitis, if you will, cirrhosis, portal hypertension, and acute liver failure. The clinical pearls are a Coombs negative hemolytic anemia, low uric acid, low alkaline phosphatase, and a high bilirubin alkaline phosphatase ratio. These are often not seen, so they're not particularly useful, but they can be pathognomonic. But a Coombs negative hemolytic anemia in a patient with unexplained acute liver failure is Wilson's until proven otherwise. How do you make the diagnosis? Well, serum copper is not helpful. Urine copper is helpful. And a urine copper in Wilson's is greater than 100. This is micrograms per 24 hours of total excretion. So if you get a copper concentration back and it says microgram per liter, it's not correct. It's not useful. You need the total micrograms excreted in a 24-hour period. Ceruloplasmin is also an acute phase reactant. So although in Wilson disease, it's usually less than 20 and frequently much lower, in the setting of an acute presentation, the ceruloplasmin can frequently be in the low normal range. But one of my clinical pearls for you is, although you can see a low normal ceruloplasmin with Wilson's, you will never see a high normal or a high level. And hepatic copper content is how you make the diagnosis. Normal is up to 45 to 50. And in Wilson's, it's usually very, very high. You can also calculate the serum free copper concentration, which may be useful. So here's the diagnostic accuracy of ceruloplasmin. And here's a somewhat recent study comparing Wilson disease patients, heterozygotes, wild types, and validation group. And you can see that essentially the ceruloplasmin is a pretty good test in terms of its area under the receiver operating curve, and in most cases can distinguish Wilson disease from the reference group, with the caveat being in patients that have an acute inflammatory response. The biopsy shows frequently macro and microvesicular steatosis, so it's in the differential diagnosis of patients with NASH. And you can see that urine copper, particularly in fulminant Wilson disease, is extraordinarily high. And in most patients with Wilson disease, the urine copper is going to be greater than 100 micrograms per 24 hours. The ATP7B mutation is much less useful in making the diagnosis of Wilson disease, although it is increasingly available. If you're going to find a mutation, it's the H1069Q mutation, which is present in 30 to 70% of cases. And then there are a variety of other mutations in various exons that could explain Wilson disease. And this is about as good as we can get in terms of being able to test for this. So other than the H1069Q mutation, genetic testing, in my opinion, is not particularly helpful because it is rare in most cases of Northern European or Central European descent. Hepatic copper levels, though, also may be falsely elevated in any disease where the bile ducts are affected. Since copper is excreted through the bile ducts, if you have a bile duct disease such as PSC or PSC, you can see hepatic copper content that are over the concentration that you see in Wilson disease, although they're much higher. I've seen many patients with Wilson disease in the 200 to 300 range for micrograms per gram dry weight. So the take-home message there is if a patient has a cholestatic liver disease, do not assume they have Wilson's just because their hepatic copper is elevated. And in fact, in many cholestatic liver diseases, the pathologist will do a copper stain to confirm that there's increased copper in the bile ducts to confirm that it's a biliary tract disease. Management is straightforward. Avoid copper-rich foods, family screening using ceruloplasmin, and chelation therapy with D-penicillamine was the standard of care. But now the first-line therapy, according to the latest guidelines, is trientine, which increases urinary copper excretion, decreases copper absorption, but does have the main side effect of gastritis resulting in iron deficiency anemia. And so for patients who cannot tolerate this, they may be a candidate for D-penicillamine. Zinc acetate is also approved. This has a different mechanism of action in that it doesn't help excrete copper, induces intestinal cell metallothionein and blocks absorption of copper, and it's useful for maintenance therapy. So in summary, keep in mind that hemochromatosis may be due to non-HFE cause. Start with the phenotype in making the diagnosis. Consider that compound heterozygotes often have a cofactor, such as alcohol, viral hepatitis, or some other confounding factor. For patients who are anemic and have hemochromatosis, deferricyrox, which is an oral tridentate iron chelator and available on the market, can be used. Keep in mind that heterozygous alpha-1 antitrypsin deficiency is a cofactor for many diseases, and both geno and phenotyping is available. Keep in mind that chronic cholestasis may mimic Wilson disease, and genetic testing, although commonly available, is not as useful for Wilson disease. And always keep in mind family screening for these diseases. Thank you so much for your attention.
Thank you very much, Dr. Cowley, for your presentation. Now we're going to go to the Q&A session, and we'll have all our speakers available. I'd like to remind the audience, you can send in your questions to pollev.com, enter debate key. Also, you can join by text, text debate key to 37607. Thank you. All right, so we will continue with our questions, and I have one question for Dr. Caldwell. In which patient with cirrhosis who's developed portal vein thrombosis would you consider a full evaluation or workup for hypercoagulable state?
Can you hear me okay?
Yes.
Okay. Yeah, it's a good question. It's only found an identifiable genetic change is only found in about 10% of cirrhosis patients having PVT. We might do it if there's some question about recurrence or risk of deep vein thrombosis in some other area, but we don't routinely do it anymore. We used to do it a lot, but it's just not really all that useful. And part of the reason for that is because cirrhosis patients already have an acquired hypercoagulable state with protein C deficiency, and so if you're trying to make a decision based on a genetic risk of how long do you treat, you're probably going to be treating them indefinitely because it's unlikely you're going to change their risk profile if they've already shown you that they're prone to thrombosis.
Thank you.
If I could follow that up, Dr. Caldwell, and ask, in patients who have esophageal varices and are undergoing banding and also have a portal vein thrombosis, is there a transition point on when you decide to initiate them on anticoagulation?
That's always a little bit of a thorny situation because, the varices aren't really going to bleed more so by anticoagulation. It's not even clear that if someone's on anticoagulants and they have a variceal bleed, that it's going to necessarily be worse. So what we usually do in most cirrhotic portal vein thrombosis, and this is real different than a non-cirrhotic getting a portal vein thrombosis, but in cirrhosis, most of the time, you have time to evaluate, maybe even wait a week after you've banded so that any band ulcers heal, and then start anticoagulation. I just came from seeing a patient with pretty extensive portal vein thrombosis into the mesenteric and the splenic. We're going to be, and he's iron deficient, so we're going to be electively scoping him on Monday, and then probably start anticoagulation. He's fairly asymptomatic, other than ascites, and he's going to get a tap in the meantime. It's real different than the non-cirrhotic portal vein thrombosis patients tend to be, they can have agonizing abdominal pain, presumably from venous congestion. So the speed that you have to initiate, or that you should initiate anticoagulation in cirrhosis, you usually have a little time to evaluate. We usually recommend banding, even though, as I said, variceal bleeding, as Loopy has said, is pressure driven. And so I think you have a little time to wait, if that answers the question.
Yes,
Thank you. Dr. Galati, question came through about patients with liver cancer, so referring patients with liver cancer, and if they're candidates for a liver transplantation, if you could speak on that.
Well, certainly we are seeing a large portion of our patients are being referred and evaluated for liver cancer. And, generally speaking, we're going to evaluate patients to see that they are within Milan criteria.
Yeah.
And working with the patients from there. We have, modalities to treat the patient pre-transplant if they're suitable for a transplant, either with TACE, RFA, or chemoembolization, RFA. So with that said, yes, certainly as we see more patients with NASH, we're seeing more HCC. I wouldn't let the development of HCC be a reason not to refer the patient. Many of our patients are diagnosed with what is suspicious for HCC. They will go off the route to maybe go for surgery with an attempted resection, only to find out that these patients decompensate, or they will start some therapy that is not typically within our pre-transplant guidelines, and they become too sick, or other problems with the disease. They get to us late, and there's expansion and complications. So I would say certainly yes, evaluate. The other challenge that we face is not only based on the size of the tumor, but if we have tumor invasion of portal vein and surrounding structures, the complications that creates, and again requires a center anywhere to have a comprehensive liver surgery and oncology program.
Thank you.
Excellent. Thank you, Dr. Galati. The next question is for Dr. Garcia-Tsao, and the question focuses on commenting on options for dizziness and hypotension in patients who are on beta blockers for portal hypertension without ascites, and is there a role for midodrine in these patients? And maybe we can start with talking about beta blocker titration, difference between coreg and the non-selective blockers.
Sure. So as I said, carvedilol is much more effective in lowering portal pressure than propranolol is, but carvedilol has that vasodilating effect. And that vasodilating effect makes these patients more prone to hypotension. So that is a problem. And that's why we have been shying away from carvedil for many, many years. But now the evidence is clear that it's related to better clinical outcomes. So what we do is, if we identify someone with CSPH, or we would start carvedil, we start at the lowest dose. It's 6.25 every day, and then you titrate up. You would titrate up exactly the same as you would the propanol. You could start at 40 or 20 BID for propanol, and you go up, and you limit it to when the patient is symptomatic, and or they have a blood pressure that's a systolic of less than 90, mean arterial pressure less than 65, or a heart rate less than 55. I think cardiologists are much more bold than we are, but we stop at 55. Now the question, so that's the dose that is the previous one to having these symptoms or hemodynamic endpoints. Now the question that has come is that many patients on carvedil, you can reach the maximum dose and there's no effect on heart rate or blood pressure. In those cases, you just stick at the highest dose that was used in clinical trials, right? Even if the heart rate is 80, there's no, from earlier studies when I was a fellow, there's absolutely no correlation between heart rate and the decrease in heart rate and the decrease in portal pressure. So we're just trying to maximize the dose of beta blockers that they can use. Now the question that was asked to me, that's actually a very cool question. You know, can we overcome like stopping the beta blocker by giving some that will increase the mean arterial pressure? Midodrine has been tried in decompensated patients with refractory ascites and the combination with octreotide and midodrine. Even the two of them together in the decompensated patient is a very weak vasoconstrictive combination. So, I mean, it's a great idea. Maybe we should be testing it to see if the patient would be more accepting or less symptomatic with the beta blocker, but I'm not sure that this would work. We have no data of midodrine in compensated patients. So that's actually a very interesting idea.
Thank you. So next question is for Dr. Cowley, and it is, are there commercial labs available to test for non-HFE mutations or ferroportin disease available, and in which patients would you pursue that?
Yeah, excellent question. So, so there are several labs available, and if you don't mind the self-promotion, we just published a paper literally 2 days ago that was on PubMed, and it's called Clinical Application of Genetics, or Application of Clinical Genetics. And it specifically talks about hemochromatosis type 2 to 4 and where you can get the gene testing available through commercial labs. So there are different types of tests that are reasonable. For both hepcidin and hemojuvelin, there's one mutation that is reasonable to test for. It's the 340 mutation. But other than that, most of these are often private mutations, meaning that the only mutation will occur in one patient. And this is true particularly for ferroportin because it's an autosomal dominant mutation, and many mutations are only present in one patient, in one family, in a proband. The key, though, is before you do the genetic testing, which can give you the patient a bill for $1,500, and there are panels available through these genetic testing services where you can test for all of them. It's to make sure that your patient really has phenotypic hemochromatosis. So I would say in my experience, particularly given my interest, I get calls from all over the country of so-called patients with hemochromatosis who are HFE negative. It's probably 1 or 2% of the time that they actually have hemochromatosis. So you want to rule out a secondary cause. You want to obtain a family history. Usually there's some history of consanguinity or something else, unless it is ferroportin disease. And you want to confirm increased hepatic iron content. So if the patient has more than 4,000 milligrams per gram or more than 70 micrograms per gram dry weight of the liver, either by biopsy or estimated by MRI scan, no other explanation, you've excluded alcohol consumption to excess, those are the patients where I think it is useful to do genetic testing. If there's a family history of unexplained iron overload and they're HFE negative, then absolutely it's worth it. But I would reference this paper in clinical applications of genetics that we literally just have published, and I can share the link in the chat box as well.
Excellent. Excellent. Thank you, Dr. Cowley. There's a follow-up question for you. Is there a role for the use of testosterone in hemochromatosis patients who are getting anemic during phlebotomy but have persistently elevated iron stores?
I think the testosterone is interesting for patients who have hypogonadotropic hypogonadism. Testosterone is useful, and this would be confirmed with either sex hormone binding globulin or with testosterone levels. But in the patients who are not who don't have decreased testosterone levels, I'm not aware of data that show that you can improve erythropoiesis with testosterone. We certainly used to struggle, and Steve and Joe and Lupe can probably all attest to the fact that we had these patients with advanced disease who had iron overload, who didn't tolerate phlebotomy because they were anemic, and so we used to give them EPO and try to phlebotomize them. But now that we have deferricyrox as an available option with an oral iron chelator, I think the risks of testosterone, if it's not needed as a supplement, outweigh the potential benefits, and I would just use an oral iron chelator such as deferricyrox.
Thank you.
Thank you.
So I have a question for Dr. Galati, and then he has a question for the panel as well. So he'll have to answer our question first. Question comes through. You spoke about when patients should be referred. For our primary care providers out there, when you talk about the first decompensating event, if they have a patient who has cirrhosis, develops ascites, maybe has their first paracentesis, and they put them on diuretics, would that be a patient that they should go ahead and refer? Oftentimes they worry about being too early with referring these patients. Could you speak on that a little bit, and then you can ask your question?
Yeah, no, it's a good question, and sometimes we'll get phone calls to say, gee, I don't want to bother you. The patient really is doing sort of okay. They changed their diet. You'd never be incorrect with not reaching out to your local center to possibly get some advice. You may have that opportunity, it's sort of a teaching moment, to double check, are they screening for HCC? Are they on the proper diet? Have they been screened endoscopically for varices? So I would say the phone call is valuable to make sure that the ongoing care is not just Lasix and spironolactone and the ascites went away. There's a far more comprehensive look at that patient. So I would say yes, check in, chat with the individual. You may want to give them a 90-day window to say, hey, all right, you started them on diuretics, they're on a better diet, they're not developing encephalopathy or renal dysfunction or any electrolyte problem, low sodium. Let's watch them. Call me back in 60 or 90 days. So that's the way I would look at it. The question I had was for Chris, in that we have had, albeit rare, but occasionally they come up, a person that was transplanted, let's say for NASH, and they definitely did not have hereditary hemochromatosis pre-transplant. Now they are 6 months post-transplant and their ferritin is 2,000. Their iron saturation elevated. How do you approach this patient?
Yeah, it's a common clinical problem, and the first thing that you have to consider is that in a Caucasian population of Northern European descent, 1 out of 250 people are going to be homozygotes. Okay, so there is a possibility that the donor could have been an unrecognized hemochromatosis patient. And, increasingly, we used to do time zero biopsies, And then we used to do immediate post-transplant biopsies, and we still do time zero biopsies in many places. And so you have a baseline liver that may or may not get an iron stain. So it's always important to look at the donor and see whether the donor had iron in the liver at the time of transplant, because you may have inadvertently transplanted a homozygote into a patient that is now going to develop iron overload due to all of the perturbations that occur post-transplant. I've seen many patients who had rapidly rising ferritins, and it's unclear what the mechanism is post-transplant, and the majority of them do not have iron overload. We know that since the defect is predominantly in the liver, when you do a liver transplant, and these are people you said that you excluded hemochromatosis prior to transplant. So the first and foremost thing would be to make sure that you have not transplanted a hemochromatosis liver into the recipient. You can go back and do genetic testing. And sometimes what happens is that the patient actually is not expressing the phenotype, and they will express the phenotype. So now, if you do gene testing in the recipient, of course, you're not going to get the answer, because the mutation is in the liver, not in the patient, right? So the only way you can make the diagnosis is by either going back and testing the donor, or by measuring iron content in the allograft. But I would say always important to look at the time zero biopsy, see if there was iron overload. And then the important thing is to look at whether the transferrin iron saturation is elevated in addition to the ferritin. An elevated saturation with the ferritin is almost always likely to indicate an iron metabolism disorder, whereas a normal saturation with a high ferritin, even with iron overload, is more likely to reflect a secondary cause.
Thanks. And Dr. Garcia was going to expand a little further on her
Yes, I didn't
answer.
answer that question completely, so I'm thinking about it. So we start with carvedilol because it's more effective, but if with the lowest dose of carvedilol, the patient gets hypotensive or bradycardic, then we would go to propanol, start at 20. All right, so and then you go up with the propanol. So if carvedilol is the preference beta blocker, if they cannot tolerate, you can still go to propanol or nadolol that do not have that vasodilating effect. The other important thing I wanted to say is that we're seeing NASH cirrhosis. I mean, that's all we're pretty much seeing in the clinic right now. And these patients usually, I mean, a lot of them are hypertensive. They're going to tolerate the maximum dose of whatever, and many of them are already on carvedilol. So in those particular cases, we just titrate the dose as we would. So we make sure that they have CSPH, or they are on another hypotensive medication. So we just talk to the primary care doctor and say, this, just switch them. Can we switch them over to carvedilol? So this is something that one can do without really starting the patient on a beta blocker. If the patient is already on something to lower blood pressure, you can just say, can we switch them to carvedilol, for example?
Okay, excellent. Thank you.
A question for Dr. Caldwell. The patient case that you presented was really interesting with portal vein thrombosis and increasing flow by occluding the splenorenal shunt. What would you recommend in terms of looking for these shunts in these many patients that we encounter? Is that something that there may be benefit to doing, identifying these shunts and then perhaps getting them occluded?
You have to be cautious with it. The patient that we did that with was having refractory encephalopathy. And that's the reason that we kind of pursued that route. And we didn't occlude the entire shunt. Our IR guy, Wael Saad, put in two stents side by side, and then into that shunt, and then occluded one of them. So basically, we got about a 50% reduction and in flow. And he also measured blood flow into the liver. did some occlusion testing to see what occluding the shunt entirely was going to do. So when you see these, though, if you take the whole thing down, you can tremendously exacerbate portal hypertension, because it's a good decompression route through the left renal vein. And so you have to be cautious. We've had people that we've done Berto on for bleeding gastric varices, and then have them have refractory ascites and hydrothorax, have to do a TIPS, and I'm thinking of one patient in particular who didn't do well. And so I think you got to take those shunts cautiously. And the IR people, if you think they'll benefit, particularly those people having refractory encephalopathy, and you think that they might benefit, you just have to have your IR people step cautiously and carefully. And that guy had a remarkable recovery, though, and we weren't expecting that, so it was quite a surprise.
So, Steve, your patient had ascites?
No, he did not.
I see. So when we suspect, when we look for shunts, it's mainly in the compensated patient with cirrhosis. They have no ascites, they're totally fine, and they're getting encephalopathy, and there's usually a recurrent encephalopathy. Yes. And then we look for these shunts, and then we try and see, why outside it's an expert in this, but we still evaluate, what is going to happen if you occlude that shunt? Are they going to get now varices and esophageal varices and variceal hemorrhage? Or because now you're occluding that shunt. That shunt is like a TIPS, So now if you occlude that, are you going to get now ascites or variceal hemorrhage? So it's a lot. It's not you just say occluded. You have to think about what's going to happen with this patient.
Yeah. And we routinely. I'm glad you mentioned that, because if we do a Berto, and usually, I'm talking about for a bleeding gastric varix, and we don't feel like glue is a good option, the cyanoacrylate, we do a Berto, then we routinely do an upper endoscopy in the next in a few weeks to look for esophageal varices.
Excellent. Thank you. Our next question is for Dr. Galati. And Dr. Galati, you mentioned that there are a few contraindications when considering liver transplantation. Just if you could comment on, should non-transplant referring providers make judgment calls on whether to refer a patient if they have coronary artery disease or history of cancer, or should that be left more to the transplant center?
I would say it's a great question, and I would still think that the responsibility to deny somebody transplant certainly is a big deal, significantly impacting on their survival. And the line between being correct and being incorrect is very, very thin. And so it comes down to experience and realizing that somebody has coronary artery disease, they're obese. We have over the years continued to push the envelope on who's a suitable patient, and especially with coronary artery disease, we have new interventions, both invasive and non-invasive. And so a patient that may not have been a candidate 5 years ago is now a suitable candidate. And having all of that information, the latest breakthroughs, certainly a conference like this is very helpful, but there may just be a misunderstanding where if they had come, we could have looked, troubleshoot the problem, and get them evaluated. So I would say unless it is an absolutely flagrant case of metastatic malignancy outside of the liver, that may be an easier case, but there's a lot of cases that are in the gray zone that I firmly believe should be looked at and decided upon by the transplant center.
Thank you. And our final question will be for Dr. Cowdley. In your clinical experience, what's the first clinical manifestation, non-laboratory, first clinical manifestation of hereditary hemochromatosis?
Yeah, so I would say joint symptoms are the first. The majority of patients are asymptomatic. So 40% of patients to 60% of patients will have no symptoms whatsoever. But if they have one symptom, it's going to be joint symptom. And the one thing I would say is that it is increasingly rare to see the patient with the classic bronze skin changes and MCP arthropathy. But if you examine the patient, they frequently will have a hypertrophic second MCP joint. And it's something that I've picked up time and time again. And when you ask the patient, they'll say that, oh, they overuse, or they have another explanation, but it's very clear when you examine those patients that they have MCP arthropathy. The second point is that several studies have now shown that it's not just chondrocalcinosis in the knees and MCP arthropathy that are the symptoms in hemochromatosis. They also have a much higher rate overall of joint symptoms that includes both back problems as well as what is often misdiagnosed as degenerative joint disease. But I would say arthropathy and arthritis, followed by fatigue, followed by abdominal pain. So that the very nonspecific reasons to consider hemochromatosis once again highlights the need to do screening using serum transferrin iron saturation or unsaturated iron binding capacity.
Excellent. Thank you. Thank you, Dr. Cowley. And with that, we'll conclude our first session. Thank you to all our speakers. I would like to remind all our participants to visit the virtual exhibitor hall during breaks and lunchtime, and we'll be back in about 15 minutes. Thanks.
Thank you.
Good morning again. Welcome back. This is the plenary session number 2, where we'll be talking about fatty liver, what is new. It gives me great pleasure and privilege to introduce my co-moderator, Dr. Mark Baker. Mark is an outstanding transplant surgeon who works with us at the Sherry and Alan Conover Center for Liver Disease and Transplantation. He has a keen interest in liver perfusion for our transplant patients and also deceased donor. He'll be the co-moderator for this panel, and I'll turn it over to Mark.
Well, thank you, Dr. Nkomase, for that kind introduction. It's my pleasure to introduce our first speaker, Dr. Jacob George. Dr. George is professor of hepatic medicine at the Storr Liver Center, Westmead Institute for Medical Research, and is the head of GI and hepatology at both West Hospital and the Western Sydney Local Health District. He is a part of the University of Sydney Department of Medicine and Westmead Hospital in Sydney, Australia, which should make us all jealous because that is one of the most beautiful cities in the world. Dr. George undertakes basic and clinical research on MAFLD, hepatitis C, liver cancer, and hepatic fibrosis. And it's our privilege to hear his talk today, MAFLD, Clinical Utility, Epidemiology, Pathogenesis, and Natural History. Dr. George.
First of all, thank you so much to Professor Nkomase and the organizers for asking me to talk on MAFLD, Epidemiology, Pathogenesis, and Natural History. It is indeed a great pleasure. I have come to Houston a couple of times before, but unfortunately, this will have to be a virtual presentation. So as many of you, or perhaps all of you know, the new name for non-alcoholic fatty liver disease is a term that was coined by an international panel of experts, and it is now MAFLD, or metabolic dysfunction-associated fatty liver disease. The name MAFLD comes with a very simple definition, and it states that if you've got hepatic steatosis in an adult and are either overweight or obese or have type 2 diabetes, then you have MAFLD. On the other hand, if you are a normal weight individual based on ethnic specific criteria, you need to fulfill at least 2 metabolic risk criteria to be classified as having MAFLD. Immediately you can see that this definition is very simple. It's a set of positive criteria, meaning that irrespective of whatever other disease you might have, if you meet these criteria, you also have MAFLD. Importantly, the 2 papers and the definition suggest that it can be used in all settings, in rich countries, in poor countries, and in developed and developing countries, and also across all health systems. The 2 papers so far, as many of you would know, has had greater than 1,500 citations. So starting off with the epidemiology, what is the burden of MAFLD? Now, this is using the NAFLD definition, which excludes other liver diseases, and this was published in Hepatology by Zubair Younossi. And you can see his global estimate was that about 1 in 4 people in the world have fatty liver disease, highest in the Middle East, lowest in Africa, but perhaps this is because there were fewer studies reported from Africa. There were also high numbers with 1 in 3 people in South America. And the prevalence of steatohepatitis in the general population that he estimated was between 1 and 6%. Since then, however, very, very recently, there has been a paper published on the global prevalence using the MAFLD definition in overweight and obese individuals. And the standout feature of this paper was that 1 in 2 people globally suffer from MAFLD, including up to 80% of people from Eastern Europe and about 70% of people from South America, including those from Brazil. And you can see the percentages in all the other countries. So truly, metabolic dysfunction-associated fatty liver disease affects half the global population, and it is going to perhaps be the only disease that we deal with in the next few years. What about MAFLD prevalence in the US? This is a paper published from Texas by Stephen Harrison, looking at 630 patients attending a colonoscopy. And of these patients, as you would expect, the mean age was 56, and 50% of the patients were male, and 50% were obese. The prevalence of fatty liver disease was about 38%, getting closer to the MAFLD definition and prevalence that I mentioned in the previous slide. And of the people with MAFLD diagnosed by MRI PDFF, he offered liver biopsy to those. 52 refused, and so this is a small subset of 192 that had a biopsy, and about 14% had steatohepatitis. Now, importantly, what this study showed, and this will become relevant when I talk about natural history, is that no patient had cirrhosis on biopsy. Significant fibrosis was present in 6%, and bridging or F3 fibrosis in only about 2%. And I think this 2% number will become even more important when I talk about natural history. Factors associated with the presence of steatohepatitis were race, obesity, and the presence of type 2 diabetes. This is a nice slide that looks at the prevalence of fatty liver disease, steatohepatitis, and comorbidities, looking at it in two ways. On the top, it's looking at comorbidity prevalence in a MAFLD population. And you can see that whether you have MAFLD or metabolic steatohepatitis, obesity is highly common, 50% in MAFLD and 82% in steatohepatitis populations. And equally, type 2 diabetes, dyslipidemia, hypertension, and metabolic syndrome are frequently present, and more so in the population with steatohepatitis. If you look at it the other way and look at the prevalence of steatohepatitis and MAFLD in populations with known obesity, in other words, if you look at an obese population, 90% have MAFLD and 37% have steatohepatitis. If you look at diabetics, it's about 50%, and so on and so forth, indicating the close linkage between these two, between the comorbidities and the liver disease that we see, emphasizing the primacy of metabolic dysregulation and the appropriateness of the name MAFLD as opposed to the previous definition. This is from that earlier study that I mentioned, again highlighting why MAFLD is a good name. And in this global study of overweight and obesity, if you look at the prevalence of all of these metabolic dysregulatory phenotypes, you can see that type 2 diabetes was present in 20%, metabolic syndrome in nearly 60%, abdominal obesity in 84%, emphasizing yet once again that MAFLD, the term MAFLD, best describes the disease we see in clinical practice. So what about pathogenesis? I honestly believe that we need to think about it in 4 levels. Level 1 is the external level, whether we choose to have a healthy diet and exercise, or whether we take the Western lifestyle currently. Level 2 is the organ crosstalk between all the various organs that shapes the liver disease. Level 3 is, and sorry for the typo here, level 3 is looking at the individual organ, which is the liver. And then level 4 is to look at the cellular level and looking at the individual hepatocyte and its crosstalk with the other cell types. Now, when you look at level 1 and the factors governing dietary choices and patterns, what you immediately realize is that it's not so simple. What a person chooses to put in his mouth and the amount of activity and exercise he does depends on his personal choices, very important sociocultural factors, his community and environment, and his or her agricultural, industry and market factors, governmental factors, and global factors. So it is not simply a disease of an individual, but of the whole system. So when you look at it, MAFLD very much is an interactome between genes and the environment. So food composition, family history, genetics, mutations, metabolic inflexibility, thermal intolerance, infections, and physical activity. So I like to really think about MAFLD as a soup or an interactome disease, very distinct from hepatitis C, where you have a single target. In MAFLD, I'd like to point out to you, we will not find a single golden driver or target that will allow us to find the magic bullet in terms of therapy. Level 2, as I mentioned, is metabolic crosstalk within all the organ systems in the body. And you can think about this as systems that are trying to preserve metabolic homeostasis. And to maintain homeostasis, the neuroendocrine axis that comes with our appetite regulatory centers and also our frontal cortex elicits multiple and complex responses that ultimately govern caloric intake, muscle mass, and physical activity. And so the brain interacts with the muscle, with the pancreas, and the adipose tissue. And at the next level, it then influences the liver, which interacts with the duodenum, the terminal ileum, the gut microbiota, and bile acids. And finally, these all shape the liver response. And all of these circles, it's important to remember, are interconnected. For example, adiponectin signaling from adipose tissue impacts the liver. FGF21 produced by the liver impacts the central nervous system, and similarly with other proteins such as cholecystokinin. The next level, and in terms of individual organs, and for us, obviously, it's the liver, but you need to think about the environment, the built environment that we live in, and the neuroendocrine axis and all the organs interacting and causing what I would like to call meta-inflammation. And meta-inflammation, if you're a neurologist, you're only interested in what happens in the brain. It happens in adipose tissue, liver, muscle, blood vessels, and in the pancreas. And so as your homeostatic responses decrease, as your body weight increases, and there's inflammation across all of these tissues to give you meta-inflammation. At the organ level, what we see is the primacy of peripheral and hepatic insulin resistance. When you have peripheral insulin resistance, you get increased lipolysis in adipose tissue, release of free fatty acids into the circulation, which are then taken up by the liver to produce hepatic steatosis, or the triglyceride storage that we see. Some of it is oxidized, and while it's oxidized, it gives rise to oxidative stress and injurious processes. At the same time, when we get peripheral insulin resistance, we get hyperinsulinemia. Excess dietary glucose and peripheral glucose activates de novo lipogenesis in the liver, and the liver tries to get rid of the triglyceride by producing atherogenic dyslipidemia with elevated VLDL secretion. So the complications for the organ, the liver, when you get hepatic steatosis through peripheral and hepatic insulin resistance, is increased CRP, fibrinogen, lipid peroxidation, atherogenic lipidemia, dyslipidemia, elevated blood glucose, increased free fatty acid delivery to the liver, and low HDLs. And as an outcome of these, an increased risk of steatohepatitis, atherosclerosis, and type 2 diabetes. Now, what happens at the last level, level 4, within the cell? And what you know is that once you get all of these effects acting on the individual cell, whether it's omega-3 fatty acids, lipids, saturated fatty acids, cytokines, or low levels of adiponectin, you activate intracellular signaling pathways such as I-kappa B, the inflammasome, junk, ceramides, and then they cause the transcription of inflammatory mediators that result in cell death, inflammation, and fibrogenesis. And this is really trying to show it all in the one diagram. So you have the adipose tissue and the liver, you have dietary factors, all impacting the liver to give you cell death, inflammation, infiltration by monocytes and myeloid cells, and steatohepatitis, and subsequently fibrosis. What about the natural history of the disease, the last part of my talk? First of all, from a clinical point of view, it's important to remember that the vast majority of cases of fatty liver disease are undiagnosed. Steatohepatitis, as shown by Stephen Harrison's paper in Texas, is about 6% of the general population. And in some of the patients that we see, it ends up in end-stage liver disease and cardiovascular disease. And underpinning all of this, there is no currently approved treatment. In terms of the natural history of the disease, this is a paper published by Paul Angulo back in 2006 in Hepatology. And I think it's a really key slide looking at Japanese office workers, and they did some very interesting statistics. And they looked at the sequential development of what happens to the patient. So the first thing that happens on the metabolic journey is increased weight, particularly truncal adiposity. And in that study, the next thing was the atherogenic dyslipidemia with a low HDL and an elevated triglyceride. The next one is the elevated AST and ALT when they come and see the general practitioner or the clinician, gastroenterologist or hepatologist. And then subsequent to that, you get hypertension, hyperglycemia, and type 2 diabetes. And this is very much the chronology of the disease that we see. So when you see someone with an elevated AST and ALT using the normal ranges in most laboratories, their body weight would have been increased and they would already have atherogenic dyslipidemia. On the other hand, if you use the Prati definition of 19 and 30, I suspect that liver lipid accumulation would occur earlier on based on the physiology up there, straight after body weight increase, before you get all of these other features. Now, the natural history in a schematic, as I showed you, 50% of the population worldwide have MAFLD. Of these, some of them will develop MAFLD with fibrosis stage 0 to 3. Some of these individuals will go on, a quarter perhaps up to develop cirrhosis. Some will develop liver cancer, even though liver cancer can arise in non-cirrhotic patients. And many of our patients are going to develop cardiovascular disease or extrahepatic cancer. And in fact, extrahepatic cancer and cardiovascular disease are the primary cause of death in patients with MAFLD. Now, when you look at a population perspective, and I think this is very, very important to understand, there are a couple of studies that show essentially the same thing. This is looking at the NHANES 3 cohort that had fatty liver disease, and then they looked at mortality as an outcome. And they used different models that adjusted for different things. And what you can see is compared to people with no hepatic steatosis, those with MAFLD or metabolic steatohepatitis, in this population-based study, there is no excess all-cause mortality, no excess cardiovascular mortality, no excess cancer mortality, and no excess liver disease mortality in these individuals. So at a population level, fatty liver disease does not increase mortality. And when you look at the causes of death, 39% of the patients that did die died from cardiovascular disease, 26% from cancer, and a sentinel figure that you should remember, only 2% died a liver-related death that wasn't significant enough to show up in these figures. They did the same analysis and cutting the data using the NAFLD fibrosis score, And irrespective of how you might argue about the utility of the NAFLD fibrosis score in a population-based cohort, the results are exactly the same. The mortality was almost entirely from cardiovascular disease. And of the 778 deaths, 37% cardiovascular disease, 21% cancer, 17% diabetes, and again, that figure, 2% from liver disease. So liver disease related endpoint at a population level is low. And then we have to think about how do you think about this when you look at biopsy series and the patients that we see every day at a clinical level. Are we trying to say that patients do not die from liver disease? I think what these two studies are saying is that at a population level for our patients, we need to be thinking from a governmental and policy level more on the cardiovascular disease, diabetes, and the cancer morbidity. Having said that, there aren't enough gastroenterologists to even cope with the 2% of patients that would die from their liver disease. So this is when you then look the other way, looking at mortality in patients with MAFLD. And this is Leon Adams's paper from the Mayo Clinic. And when you look at this population-based cohort, but again, it's a tertiary hospital-based cohort with a particular interest in MAFLD because Paul Angulo was involved, you can see that there was a slightly increased risk of death in patients with fatty liver disease. And the cause of death, again, malignancy and heart disease. And liver disease, as opposed to the 2% previously, was much higher, which is really due to selection bias. There's a subgroup of patients, as you know, and we've had a very big interest in this. And this is a paper that's been published in abstract form, confirmed many times after. But looking at patients who are lean, in other words, normal weight individuals, and looking at their long-term outcome. And you can see that patients with lean fatty liver disease also have a poor long-term prognosis, equally bad compared to the non-lean patients. So if you've got fatty liver disease, what it's telling you is that you've got metabolic dysregulation and you need to do something about it because your long-term outcomes are not rosy. Obviously, if you've got fatty liver disease with cirrhosis, this is a study that we published in 2011 with 247 patients. You can see that patients with fatty liver disease, 20% develop liver-related complications over a period of 7 years, and 13% either die or undergo a liver transplantation. And again, this was followed up with the study that we were involved with Villa Gomez published in Gastroenterology 2018. And you can see when you look at the annual incidence, if you have bridging fibrosis, you're very likely to die of vascular events or non-hepatic cancers. Once you get cirrhosis, you're more likely to die of liver disease or HCC. And as soon as you go from A5 to A6, there's a big jump in the risk of decompensation and of HCC. Now, what tells you and what predicts progressive liver disease and death? And all the studies that have been shown suggest to you that it's fibrosis. So this is the Angulo study. F4 does the worst, the cirrhotics. Unossi said the same thing. Hannes Hagström in 2017 from Sweden show exactly the same thing that we would expect. And then when you look at the mortality, you can see the mortality ratio significantly increases once you get F4 and F3, but much less so in F0, F1, or F2. And this is highlighted in this slide. And if you look on the right-hand side is the slide, the figure that I showed you before. When you're looking at liver-related outcomes, it's the F3s and F4s you've got to worry about. These are the patients we need to see. And if I can just tell you that there aren't enough gastroenterologists or hepatologists even if we limit the patients to the F3, F4 to look after. Whereas if you look at all-cause mortality, even at F1, things increase, and it's the cardiovascular mortality and the diabetes mortality and the cancer mortality. This is a population-based Swedish study published in 2021 by Hannes Hagström in Gut, looking at the causes of death in MAFLD. And these were 10,000 patients with biopsy-proven fatty liver disease. And what they were able to show is if you had fatty liver disease, as opposed to a non-fatty liver disease cohort, you can see the increased risk of death. And so what do these patients die from? Extrahepatic cancer was number one. So I think the population-based studies are suggesting cancer is number one. Then the excess mortality is from cardiovascular disease. And then obviously cirrhosis. This is the incidence per 1,000 years. So highest risk is cancer, then cardiovascular disease, and liver disease from cirrhosis and HCC. Again, that 2% that came from the NHANES study that I mentioned. It's a small number. The majority are from the other diseases. When you look at patients from that same study, again, when this is looking at the cumulative event rates, it's highest in cirrhotics and lowest in the group with simple steatosis, which is not significantly different or not much different from the patients without fatty liver disease. Now, when you look at the mortality outcomes in NHANES, looking at the NAFLD definition or the MAFLD definition, you can see NAFLD and MAFLD overlap for about 75% of cases. 16% have MAFLD without NAFLD. In other words, they may have Hep C, hepatitis B, or alcohol. And then there is this small group with NAFLD but don't have metabolic dysregulation. And what you can see is whether you use all-cause mortality, cardiovascular mortality, other-cause mortality, or cancer-related mortality, the highest risk is in the non-NAFLD MAFLD, in other words, this group. So it's very, very important when you treat your patients with Hep B, Hep C, or alcohol. If they've got metabolic dysfunction, you need to treat them because you're doing them a disservice because they will otherwise die from other related causes, but also including cancer-related mortality. This is the same study that, a much bigger study that was published in CGH in 2020. And this is looking at 9 million Koreans, looking at the NAFLD definition and the MAFLD definition. And you can see the MAFLD definition identifies 10% more patients. And in both these studies, as you can see, if you look at incident cardiovascular disease, it's highest in patients either with both fatty liver disease or MAFLD only, and very low in that small group of patients with simple steatosis without metabolic dysregulation. Another reason why the MAFLD definition is better. And the MAFLD definition equally identifies more patients with significant CKD. So in summary, Mr. Chairman, ladies and gentlemen, I hope I've shown you in this talk about epidemiology, pathogenesis, and natural history that MAFLD is common and affects half the population globally and certainly in Texas. The pathogenesis of MAFLD is complex at 4 levels, and so effective management will only occur in the context of targeting each level of pathogenesis. We need to target the societal level, the neuroendocrine interrelationships, the liver, and finally what happens within the cell. In terms of the natural history, MAFLD is a slow and progressive disease, but important to remember that most patients will die from extrahepatic disease and cancer. Yes, some will die with end-stage liver disease, and there will be enough and more patients that we see if we just are limited to the F3 and F4 fibrosis. And perhaps I would like to leave you with one more thought. It is important to recognize, because liver disease is probably the first part, apart from adiposity, of metabolic dysregulation when you have liver fat accumulation. And so it is very possible that when you have liver disease, even simple steatosis, it accelerates the progression of extrahepatic disease, whether that's cancer or cardiovascular disease. And so it is telling us that in primary care, the presence of hepatic steatosis is not a benign lesion for a person, and it's a call to arms to improve your metabolic health, to improve your long-term morbidity and mortality. Thank you very much.
Well, thank you, Dr. George, for that incredible overview of MAFLD. Before we introduce our next speaker, I just wanted to point out how you can interact with our discussion for the question and answer session afterwards. There's two methods. One is to join by the web at pollev.com, enter DeBakey, D-E-B-A-K-E-Y, and respond to the activity that way. The other is to join by text off your cell phone by texting DeBakey to 37607, and you can text in your message. This will allow us access to your questions for our question and answer session after the talks. Our next speaker comes from right here at Houston Methodist. It's Dr. David Victor. Dr. Victor is a transplant hepatologist and is the director of the Metabolic Liver Disease Program at the Sherry and Alan Conover Center for Liver Disease and Transplantation. Dr. Victor is heavily involved in research and serves as the Director of Clinical Research for Academic Hepatology in the Department of Medicine, and he is the Associate Director of the Gastroenterology Fellowship Program at Houston Methodist. He is an Associate Professor of Clinical Medicine at Weill Cornell Medical College, and he is an esteemed colleague of ours, and it's a pleasure to introduce you, Dr. Victor, for your talk on fatty liver disease evaluation in the primary care setting.
Thank you, Mark. Thank you, Dr. Nkomase, for having me to this conference. It's always fun to be sandwiched in the middle of two talks about the same topic because you're unsure of exactly how much you'll overlap. But I think I've done a good job, and I wanted to thank Dr. George for redefining our definition of NAFLD now into MAFLD. These are my disclosures. We will go over the old definitions of NAFLD to make sure that we're all on the same page for this talk, because this will be focused mostly on patients who have liver-related complications of metabolic liver disease. NAFLD is by definition hepatic steatosis by imaging or histology. Non-alcoholic fatty liver is simple steatosis alone, whereas NASH, which is the disease we are the most concerned with, remains a histologic diagnosis where hepatic steatosis and inflammation with hepatocyte injury or ballooning is seen with or without fibrosis. And just a reminder for everyone, the normal values we work with typically are an ALT of greater than 19 in females, considered elevated, as well as greater than 30 in males. NAFLD is the most common cause of liver disease in the United States, with a prevalence of 20 to 30%. It is estimated that 25% of people have NAFLD worldwide, where we just heard MAFLD is greater than 50%. It is the etiology of greater than 90% of asymptomatic patients with elevated liver enzymes. We often see it in 5th and 6th decade of life, consistent with the epidemiology Dr. George just showed us. But only 1.5 to 6.5% of patients have NASH. It is the most common cause of elevated ALT and diabetes. And NASH is expected to rise 63% by 2020. 4.9 to 21 million Americans will have NASH by that time. In perspective, there are 7.8 million people currently living with breast cancer, which is the world's most prevalent cancer. So no matter how we look at it, this will be a disease that will touch us all, from primary care to hepatology to all medical specialties. So recently, and we will reference this paper from gastroenterology in 2021, the AGA had a multidisciplinary group come together and focus on the NASH epidemic with a call to action for our primary care and specialty groups. The spectrum of NAFLD was excellently discussed by Dr. George, so we won't spend much time on it. But it is important to notice that your mortality dramatically increases as you reach the levels of NASH. This increases with the degrees of fibrosis, and especially after F3, as we have just seen. The metabolic syndrome in the primary care setting is important to remind ourselves of the definition, that it requires three of the following: central obesity, hypertension, triglycerides greater than 150, HDL that is low, and an increased fasting glucose. We think that this is the underlying insulin resistance that drives our metabolic liver disease problems. In our prevalences in high-risk populations, as we just saw, it can be as high as greater than 90% in our bariatric patients, where 5% are noted to have cirrhosis. Recently, in the call to action that I referenced, it specifically highlights aspects that the PCP must be aware of. It says NAFLD is one of the most common causes of abnormal liver enzymes, but also to note that the ALT and AST can be normal in many cases at all stages, including patients with advanced fibrosis. It also notes that liver fibrosis has been linked to morbidity and reduced overall patient survival. NASH and fibrosis are reversible with weight loss. Alcohol also must be considered and can overlap the histologic features of NAFLD. They again highlight that a ratio of increased AST to ALT greater than 2 should indicate to the primary care doctor to further evaluate for alcohol use. So this is a patient who came to my clinic. And the quote is from the primary care doctor who sent me the consult. She said, "This is a young man with fatty liver of uncertain etiology. He isn't very fat and he doesn't drink or eat a lot of fast food. Rule out other etiologies of liver disease." He was noted in college to have elevated liver function tests when the campus physician switched his Prozac to Effexor and was noted to have elevated liver function tests. On fall break, he came back and saw his primary care, to which he complained of right upper quadrant pain and with increasing LFTs. During that visit, he underwent an ultrasound, and it was showed to have fatty liver. He does note that he's gained 30 pounds since graduating from high school 8 months ago. He has a family history of diabetes. He drinks 2 alcoholic drinks twice a week, but he does love Monster energy drink, drinking 2 to 4 cans per day. That is not him on the right. It's just a representative example of his enjoyment with this drink. In the call to arms paper, they highlight the things that we must assess for non-alcoholic fatty liver disease in the initial setting. We must look for obesity, type 2 diabetes, metabolic syndrome, alcohol use, the pre-existing liver disease. We must evaluate the liver function, our hepatitis panels, and other causes of liver disease that may influence the liver to be inflamed without being from NASH. So in my clinic, the patient was noted to be 5'11", 201, with a BMI that was overweight at 28, but the exam was otherwise nonspecific. He had an AST of 119, an ALT of 241, moderately low ALK phos, a moderately elevated GGT, a normal IgG, but a low hemoglobin A1C, but an increased fasting glucose. His cholesterol showed a low HDL. His ferritin was moderately elevated, and he had a moderate ANA. His fasting insulin was elevated. So one of the reasons we focus on his diet consumption was that we know there's an association between sugars and fat accumulation in NAFLD. In this older study from 2012, we see that 47 patients were challenged to drink largely 1 liter of cola, 1 liter of milk, 1 liter of diet cola, or water for I think 6 weeks. They showed no change in fat mass across the groups, but in the cola with fructose, it had a significant increase in liver fat, visceral fat, and their triglycerides. In a even more distant study at this point, that I've not been able to take out of my deck for some time because it highlights that between sugars of glucose or fructose, the consumption after 10 weeks of 25% of their daily energy requirements, which I hope no one is recommending to their patients, that they had similar weight loss. But the amount of visceral fat or central obesity increased dramatically in the fructose group alone. At our first visit, I challenged the patient on his way back to college to lose weight and alter his diet. We asked him to avoid Monster energy drinks that have about 20 grams of sugar per can. The patient at this visit did divulge to me that his parents had purchased the freshman eating plan and that at the cafeteria he eats pizza or fettuccine alfredo for lunch and or dinner every day. So given that, we started him on fish oil for his moderately elevated triglycerides. We ordered a glucose tolerance test, and we discussed a biopsy if he did not improve his liver functions, given the myriad of problems and his increased levels. At our second visit in 3 weeks, he had gained 3 further pounds. He was still eating a largely high-carb diet, but he had cut out his Monster energy drinks. His liver functions were largely unchanged. We had checked his HFE genotype, which was normal. We had his IgG remained under the upper limit of normal. We could not do a FIB-4 score, which we'll explain what that is a little bit later, because he was under 30. So we had done a FibroSure, which is another non-invasive marker of liver fibrosis, that had showed severe steatosis without fibrosis. I had ordered an insulin and glucose tolerance test, but it had been done incorrectly. But it did show glucose levels consistent with insulin resistance. So non-invasive markers of advanced fibrosis in NASH, I think, are the most key component to the primary care evaluation of patients who have metabolic liver disease or non-alcoholic fatty liver disease. These are ways for us to perform non-invasive tests based on simple blood testing or existing blood testing values to give us an idea of, does the patient have advanced fibrosis? So we reference the FIB-4, which is the test I use mostly in patients over 30. It can't be used in patients under 30 because of their age being part of the equation. It has a fantastic negative predictive value. It is not as good as the ELF test, or the ELF test, which is currently not available in the United States, but may be the test of choice coming in the future. As you can see, the Fibra test is very good if it has a very good specificity, but a moderate negative predictive value. The FIB-4 score, which we've created a dot phrase for those of you who work at Methodist to use in your assessment for patients. If a FIB-4 score is less than 1.3, you have a 95 to 97% negative predictive value that they do not have advanced fibrosis. What is nice about this test in the primary care setting is that it's not the best test if you have a high level. So this is a wonderful test to rule out patients, but if someone rules in, they do not necessarily have advanced liver disease, and that can be dealt with further testing. So this is the potential diagnostic algorithm that we came up with for our metabolic liver disease clinic. We asked the primary care and early treaters of this disease for patients who have suspected NAFLD to rule out other diseases, perform a FIB-4 test. In those that have a low FIB-4 score, that are low risk, everyone gets lifestyle modification. And we ask that they repeat them between 1 and now 3 years. In those that have an elevated test, we ask to consider a referral to our clinic for us to help triage. After triage, we consider forms of non-invasive fibrosis testing, as well as possible biopsy. Those with low risk, we repeated the test and considered lifestyle modifications. The call to action paper puts more onus on the primary care doctor, asking for FIB4 testing or NAFLD fibrosis scores, and if low risk, to repeat in 3 years. Intermediate risk, they ask you to move toward transient elastography or markers of fibrosis that are ordered through the primary care, and only those with higher risks of fibrosis to be referred to the hepatologist. As Dr. George mentioned, we are going to suffer under the weight of this disease as it becomes more and more. So what is transient elastography? The trade name is FibroScan. Transient elastography is a painless, non-invasive, reproducible sound wave test of the liver that tells us about fibrosis. It has a pretty good sensitivity and specificity, but it is unreliable in patients who have obesity to some degree. So there are some limitations, but this can be done in the clinic and can be ordered through our clinic. This test is widely available and has become easier and easier to find. But it's not the only marker of fibrosis. MR elastography, shown to the right, with less fibrosis at the top, moving down to, I guess I do have from top to bottom, going from F0 to F4, can show us a great degree of fibrosis without biopsy. The sensitivity and specificity are pretty good. It has a whole liver evaluation, and it also allows us to follow the fat fraction, which can be helpful in monitoring disease progression and improvement. So for our patient, our differential at the time that I saw him after our second visit still included NAFLD, NASH. He had an positive ANA, so autoimmune was there. Mildly low ceruloplasmin, so you always worry about Wilson's in a young man. Hemochromatosis was much less likely. Drug-induced, occult alcohol, and something weird or pediatric is always on my differential. So I was uncomfortable with his level of liver function despite his FibroScan, or FibroSure, so I underwent biopsy. He had mild NASH, or steatohepatitis, ballooning the hepatocytes, but 90% of his liver had been replaced with fat. He had a NAFLD activity score of 6 out of 8. He showed no Mallory-Dank bodies, but concerningly, he had grade 2 fibrosis. No evidence of iron was noted. So for everyone to remember, steatosis is these large circles that are typically washed away on our typical H&E stain, but it can be simple where there's no increased activity. As you can see, there's increased blue here. That's my level of histology knowledge at this point, which means blue is bad. So we see that there's increased in NASH. And then this is a trichrome stain that shows that there's increased fibrosis that can be associated with this fat in the liver. So I severely counseled the patient on a low-carb, calorie-counted diet. We talked about the progression of disease and kind of scared him a little bit. So over the next 3 months, he lost 25 pounds on a 75 or less carbs per day. We sent him to endocrine, who started him on metformin for insulin resistance, and vitamin E. This is his weight trend over the next 3 years. As you can see, the secondary things that came up were the AST and ALT that dropped dramatically and mirrored his weight loss. The increases you saw were when he finished college and started having to cook for himself. He had some dietary indiscretions, gained weight, and after further dietary counseling, he was again able to control his AST and ALT with weight. So because of this type of patient, we have created the Metabolic Liver Disease Center, or program. This program focuses a lot on diet and exercise because it is consistently the most effective treatment. These programs require intensive work with the patient and directed counseling. So the ASLD asks, who should we treat for NAFLD? We ask that people with comorbidities of obesity, hyperlipidemia, insulin resistance, and type 2 should be considered. Pharmacologic therapy, which we'll hear about in our next lecture, should wait for patients who have fibrosis. but everyone should be talked to about diet and lifestyle, and we should try to improve weight loss, and exercise may be enough in some people, but unlikely. The lifestyle recommendations that we give from the ASLD are caloric reductions of 750 to 1,000 calories. We ask for weight loss and exercise and no heavy alcohol consumption. As you look at the asterisks at the bottom, fructose is vilified again, and that caffeinated coffee, which may even be coffee alone, may have some beneficial effect on non-alcoholic fatty liver disease. So for lifestyle intervention, and this is why it's so important to objectively talk to your patients. In 31 obese patients from this study in 2010, 7% weight loss showed significant improvement in NAFLD activity scores. A weight loss of 5% will improve their steatosis, with greater than 10% improvement in steatosis and inflammation in NASH. This is our weight loss pyramid, which I think at this point is the most effective treatment for non-alcoholic fatty liver disease in NASH. You see that 45% of patients with a weight loss greater than 10% will resolve any fibrosis and their NASH. The problem here, even with these moderate goals when you put it in paper, is that only less than 10% of our patients will reach weight loss of 10% or greater in 1 year. So we struggle with maintaining and achieving these goals because losing weight is hard. A lot of this has to do with diet perception. This is one of my patients brought this to me because she was so angry when I told her that she should check her calories rather than eat what she thinks is healthy. She was the most upset with this graphic because they had to include a roll for the ribs to get the calories near her salad and the carbs close to the Oriental grilled chicken salad. This is further shown in a paper where a group of patients undergoing intensive weight loss therapy were given diets of 1,600 calories apiece. They were then asked to rate the calories of these foods. As you can see here, they significantly underrated foods that they considered healthy, whereas foods that they considered bad, they overread the calories in this. So this tells us that our perception of food needs to change in our patient education. We've talked about the prevalence of obesity with Dr. George, so you can see that it is continuing to increase, and that at one point we think in 2030, up to 60% of patients in Texas will be obese, with 30% or greater being severely obese. It is a global pandemic, as we've heard, but in Texas in particular, we have a significant obesity problem throughout the state, with up to 40% of our population currently overweight. We have a huge Hispanic population in our state as well, which is a distinct problem in our patient population because of this PNPLA3 in Hispanics. This is a genetic polymorphism that increases your risk of fibrosis. This has been well studied in our Cameron County Hispanic cohort, where 52% of the patients were asymptomatic and were noted to have NAFLD on ultrasound. 50% of the population had diabetes and were metabolically unhealthy. They noted in this cohort that central obesity and alcohol use for men presented with advanced fibrosis or advanced markers of NASH at 30, whereas PNPLA3, central obesity and diabetes, presented at 51 for women in this cohort. So they are presenting earlier and more often based on their genetic predisposition. We've also heard that, as Dr. George said, lean NASH, and this is a study by one of our colleagues here in 9,000 Brazilian patients, that lean NAFLD is not metabolically benign and also should be considered when you look for patients with metabolic liver disease. NASH can be treated effectively with bariatric surgery, but probably doesn't need that for everyone, but it should be something we consider counseling in those patients who are not improving with lifestyle intervention. As you can see, it is the most effective weight loss with bypass, achieving 25% weight loss at 10 years in comparison to diet alone, where they had an increase over the time period. So our current treatments for NASH, and we'll hear more about this, but largely what we want to focus on in the primary care setting is lifestyle modification, clear goals for weight loss, and working on pharmacotherapy with our transplant hepatology colleagues and hepatologists and gastroenterologists for those with highest risk. We think that any steatosis should be counseled on weight loss. We talk about diet and especially the avoidance of fructose. We talk about portion size. As you can see here with this graphic to the right, the current plate we eat on has the potential to have about 2,000 calories per plate, whereas the plate from the 1950s was the size of our current salad plate and has the potential for about 800 calories. The optical illusion at the bottom shows the same portion of food on 3 different size plates. In many studies, they will show that food on smaller plates is perceived as more food, and patients are happier and more satiated with less calories using these methods. We encourage calorie counting. I encourage our MyFitnessPal app in conjunction with our weight loss center. I ask for patients to develop a consistent approach to addressing their diets and from our provider level. We encourage exercise, both aerobic and resistance exercise. And we will talk about pharmacotherapy in a few minutes. I want to point out to our primary care group and focus that we do have a new set of guidelines from the AGA on cancer screening in NASH. I'm running a little short on time, but it is important to show that any patient with advanced fibrosis or cirrhosis should be screened for HCC in NAFLD. But those without advanced fibrosis, at this point, we are not recommending screening. The further recommendations are below. The problem here is that NASH patients are hiding in plain sight. How do we find them when only 5% of the population ends with cirrhosis and NASH? Identification remains crucial. Following these algorithms, whether it's the call to action algorithm we recently submitted or a more aggressive that I'd gone over previously, we must stratify our patients better. In the future, I'm hopeful that pharmacotherapies will help combat steatosis and fibrosis, but I do not think these will ever replace diet and exercise to modify our metabolic risks. Thank you very much.
I want to thank Dr. David Victor for a very clear talk on fatty liver disease in the primary care setting. I think that was really well done and very, very useful. It now gives me great pleasure to introduce the next speaker, Dr. Vlad Ratsu. He's an internationally renowned hepatologist with a great interest in fatty liver disease. Apart from being a colleague, he's a very good friend of ours. He's professor of hepatology at the Université Pierre et Marie Curie Hospital in France, Paris, France. He's had extensive research interest in the field of non-alcoholic fatty liver disease, the mechanisms, risk factors, progression of liver fibrosis in viral and metabolic diseases, as well as the treatment of viral hepatitis and hepatocellular carcinoma. His talk today will be the current and future treatment options in non-alcoholic fatty liver disease. And welcome on board, Vlad.
Hello, my name is Vlad Ratsu from Sorbonne University, Paris, France. And I would like to thank Dr. Victor Ancomase for the invitation to the Emerging Topics in Liver Disease Conference from 2021. I'm very sorry that I cannot join my friends, Victor, Mark Gabriel, and all the others that I've seen over the years, but I will have to do this presentation remotely. And this presentation is about current and future treatment options for NASH. So the overall objective in treating patients with NASH is to prevent progression to cirrhosis and its complications. This should be the objective of every treatment, including pharmacological therapy. Now, in order to achieve this, usually patients that have steatohepatitis with some degree of fibrosis are chosen to participate in the pharmacological trials, and in clinical practice, this is true as well. Our therapeutic efforts in terms of curative treatment are directed towards these patients. Now, of course, there are no approved drugs for treating NASH, so most of our efforts so far in the clinic rely on dietary and lifestyle changes. Now, there are some problems with the dietary interventions as a treatment for NASH, and the problems are very nicely shown in this randomized controlled trial that has looked into usual care versus brief lifestyle counseling or enhanced intensive lifestyle counseling over 2 years. And as you can see on the graph here, although there is an initial weight reduction in people who were subjected to intensive lifestyle therapy changes, this weight loss is not maintained in the second year of the study. And that is despite a very strict monitoring program to ensure adherence to the study protocol, which consisted in quarterly PCP visits, monthly lifestyle coaching, meal replacement, or even weight loss medication. So it is very difficult to maintain the weight loss initially achieved. And the reasons for that are partly physiological, because there is an increase in some gut-derived hormones, for instance, ghrelin, and there are other hormonal adaptations as well that induce a permanent increase in the sensation of hunger that tends to bring back a sufficient intake of nutrients in order to regain the baseline weight in these trial participants. So this is dictated by physiological adaptations as well. Now, another inconvenient truth is that although these trials are effective in inducing weight loss, in the long term, this may not necessarily translate into clinical benefit. And this is another study, the look-ahead study published in 2013 in the New England Journal, has shown that despite improvement in surrogate markers of cardiovascular benefit in the beginning of the trial had to be stopped after 8 years because there was no difference in terms of cardiovascular outcomes between people who have followed the intensive lifestyle counseling and diet and those that were in the control group. So the effectiveness of these non-pharmacological intervention in the long run is very limited. There are many limitations to a non-pharmacological approach. As I said, implementation is difficult because most hepatological institutions lack specialized resources for doing that efficiently. There is clearly difficulty in maintaining lifestyle changes over the long term and associated metabolic effects. There is individual variability in the metabolic response. As I explained, there are some counter-regulatory mechanisms to increase appetite in response to changes in diet. And also, and I don't have time to go into this, there is insufficient improvement, most probably, in patients that have already reached an advanced stage of liver injury in NASH. So for all these reasons, although it is important to introduce dietary changes and lifestyle, healthy lifestyle in these patients, and it's probably even more important to do that in a prophylactic way than in a curative way. So although this has always to be implemented, we'll still have to turn towards drugs specifically targeted to treat NASH. For the moment, there are no such approved drugs. So the ones we have so far are synthesized, are shown in this table here. Here are the drugs which have the highest level of efficacy, the highest level of evidence in terms of proven efficacy to improve the histological condition in steatohepatitis. So pioglitazone is probably the one that has been best tested before the era of pharma-sponsored trials, obeticholic acid, semaglutide, and then there are some other drugs that have a much lower level of evidence for histological improvement. Liraglutide, vitamin E, Orlistat, UDCA, and pentoxifylline, some of them very low level of evidence. However, my main message here is to say that despite the high level of evidence for these first three drugs here, there is no definitive proof that these drugs are effective in treating steatohepatitis. And the reason for that is simply because none of these drugs so far have gone into a completed phase 3 trial that has shown in a large number of patients with long-term outcomes that these drugs are beneficial for NASH. So they should not be used over the counter, although most of them are available in many countries over the counter. Now, there are some other drugs that might not have direct benefit for steatohepatitis, but might have collateral benefits that could be important for patients with NASH and associated comorbidities. Those are metformin, statins, and GLP-1 receptor agonists and SGLT2 inhibitors, which are drugs targeted for diabetes and obesity. Metformin has been shown in observational studies to reduce the risk of liver cancer, to increase survival in cirrhotics. Statins have been associated with a reduced risk of complication in cirrhotics, a reduced risk of liver cancer, maybe less portal hypertension, and maybe a reduced fibrogenesis as well. However, none of these data come from controlled trials, so it is very difficult to really be sure that those are not artifacts that are due to observational studies performed in very selected populations. So therefore, the drugs that are now being tested, they follow a very strict regulatory pathway, which I'm trying to show you here. Most of these trials need to have in phase 3 histological endpoints that are obtained after 12 to 18 months of treatment. And the histological surrogates that need to be corrected or improved in order to achieve approval are resolution of NASH and fibrosis reversal. And if one or two of these surrogates are being met in these trials, then the drug supposedly will get conditional approval. Now, a first controversy here is to determine whether resolution of NASH and fibrosis reversal merit the same level of confidence in terms of being surrogates for improvement of NASH, or is one of the two, particularly fibrosis reversal, more important than resolution of NASH? So a lot can be said here, but as you are certainly familiar with the many articles published in the literature, many authors consider that fibrosis reduction is more important than NASH resolution because in long-term natural history studies, it has been shown by many of these researchers that fibrosis stage is a much better predictor of outcomes than the presence of steatohepatitis. Now, what is very interesting is that the same authors have recently published a very nice long-term study in gut, partly based on histological assessment in most of these patients, that has shown the exact opposite, which is that even, of course, if cirrhosis and fibrotic NASH have the worst survival, patients with non-alcoholic steatohepatitis, even without fibrosis, as you can see here, differ after several years of follow-up from patients who have simple steatosis. So even steatohepatitis without fibrosis increases the risk of long-term outcomes. This is one of the numerous data in that study that has shown increased mortality after adjustment for all the comorbidities, including the metabolic syndrome, in patients that have steatohepatitis over those that have simple steatosis. You can see here that there is a significantly increased risk, which grows higher in patients who have fibrosis, and of course, even higher in patients who have cirrhosis. So I think that this whole controversy between whether steatohepatitis is less important than fibrosis needs to come to an end, because nowadays people should recognize that steatohepatitis is the process that drives fibrogenesis anyway. So going back to the pathway for registration in these trials, what is important is to understand that once the efficacy on histological, generally accepted surrogates, such as a resolution of NASH and fibrosis reversal has been achieved, the studies need to continue because the definitive proof I alluded to in one of the earlier slides is to show clinical benefit. And clinical benefit is defined both by progression to cirrhosis and by the occurrence of complications of cirrhosis and liver-related mortality or overall mortality. So therefore, all these phase 3 trials need to have an extension period, usually of 4 to 5 years, sometimes with a liver biopsy at the end of this period, that has to prove that the having achieved the resolution of NASH and fibrosis reversal will translate into clinical benefit. And then you get definitive approval in these trials. Well, we have witnessed in the past years many failures for very interesting molecules, which all of them had a very strong pathophysiological rationale. And these are shown here on this slide. So what are the reasons for these many failures? Very briefly, some of the reasons can be shown here. One of them is the animal models, which are not very predictive of the human pathology. What is interesting in terms of animal models is that not only the model itself is not predictive, but the animals themselves have become very different from real animals in the wild. I mean, lab animals have become very different from wild animals. And this has been very nicely shown in a series of articles by Barbara Reremann's group that has shown that wild mice are very different from lab mice. Now, of course, lab mice, the advantage of them is that genetically speaking, they're very homogeneous. So it is easier to work with this because you eliminate a lot of variability due to genetic differences. However, as they became very homogeneous in terms of genetic background, they have lost and they became very far away in terms of other characteristics that might impact the liver, and in particular microbiota. And what this series of articles have shown is that the microbiota of these mice is highly different from those running in the wild. So you end up with animals that are even more distant from the humans than the generic wild animals. And therefore, when you test them in pathogenic models, the results that you obtain are sometimes extremely distant from what you can see in the human disease. So some of the failures of the drugs using these models from lab mice can be explained by the fact that if researchers have used wild type animals, then the results could have been much more predictive of the ultimate efficacy or failure of these drugs in humans. So this is one of the problems. Another, and this is very nicely shown in some studies that have compared gene expression between humans with the disease and mice in the animal models, and you can see here a very striking difference both for NAFLD and for inflammatory diseases, where there were a lot of failures as well of immunomodulatory agents in trying to control some human diseases. You can see here very large differences in gene expression patterns between humans and lab animals, and this can explain some of the lack of predictability of the results from preclinical models into the human disease. Another reason is that maybe what we call NASH or MAFLD has a very wide heterogeneity in terms of pathways of liver injury, patient characteristics, and all this is shown here in this cartoon taken from this excellent review here. And this might translate, this large variability might translate into variable natural history, but also maybe variable response to therapy. So if we try to treat patients that have very different forms of NASH with the same drug, maybe there is no surprise that the trial might be negative, because possibly the drug might work only in a subcategory or a subgroup of patients that have more homogeneous features of NASH than in the at-large variety of NASH that might be extremely heterogeneous. And finally, a third aspect that might impact the efficacy and might explain some of the failures that we have seen is the fact that although we by definition eliminate alcohol intake, it is not at all clear that we're very successful in doing so reliably and robustly. And it's also not very clear that we're successful in monitoring what happens during the trial in terms of alcohol intake. And that even more so if you consider that sometimes it's not a matter of what people drink, it might also be a matter of endogenous production of alcohol. It has been shown that some of the microbiota species, I think here is a strain of Klebsiella, might be responsible for intestinal production of alcohol, which then, of course, is conveyed through the portal vein system to the liver. So all this makes that probably these trials would have to be much better targeted to specific subpopulation of NASH patients if we want to avoid future failures. So going back to the type of different drugs that are now being tested in all these trials, you can see here that there is a chain of events, each one determined by different triggers: metabolic dysfunction, de novo lipogenesis, lipotoxicity, everything that's written on the right hand here, mitochondrial dysfunction, ER stress. that explain inflammation, hepatocyte injury and death, and then fibrogenesis, which will result in cirrhosis. So trying to improve this chain of events is extremely difficult because no drug can act on all these levels. But one of the hypotheses that is being put forth in these trials is that improving the metabolic milieu with metabolic drugs, or improving chronic inflammation or lipotoxicity with anti-inflammatory drugs might result in less steatohepatitis and less drive for fibrogenesis. Of course, using fibrogenic drugs could also be a way to do that. However, the problem with fibrogenic drugs alone is that all the upstream mechanisms will be left intact, and therefore the disease will continue to provide fibrogenic stimuli, and it will be very different for an antifibrotic drug to be efficient. And then maybe we also need drugs that are able to control in cirrhotic patients some very specific mechanism of cirrhotic decompensations that are no longer specific to NASH, such as portal hypertension, intestinal permeability, bacterial translocation, and so on. So it is a complicated story, particularly because some of these drugs have pleiotropic effects. So it is difficult to assign them to a specific bucket and therefore to also predict their effects robustly. So let's go through some of these drugs that are the ones that are most advanced in development. First of all, GLP-1 receptor agonists. This cartoon shows in a simplified way how these drugs work. They reduce very strongly body weight, and this is through central as well as peripheral effects. They improve glycemic control by increasing insulin secretion after meals, reducing glucagon secretion. They might improve lipogenesis specifically as well, and they have cardiovascular benefits that have been very well demonstrated. All this might culminate into improvement in steatohepatitis, although it is not very clear how much of these non-weight loss related effects could account for an improvement in steatohepatitis. Anyway, this last year, we had the results from a phase 2b study of subcutaneously administered semaglutide in patients with non-alcoholic steatohepatitis over 18 months. And the results are very clear in the sense that the high dose of semaglutide performed much better than placebo for resolution of NASH. However, despite the very long treatment period, which was 1.5 years, there was no clear and statistically significant improvement in fibrosis, which of course raises a lot of questions about the relationship between the two. There was a very clear biochemical improvement, and there was also better control of glycemic homeostasis, and also a very strong, at that dose of 0.4 milligrams per day, a very strong reduction in body weight. So again, the discussion here being whether all the beneficial effect is conveyed through body weight, or if there are some other non-weight reduction related effects. And we submitted an analysis at the coming AASLD meeting in November to try to analyze that. Another drug that looks very promising is a pan-PPAR agonist. You know, there are 3 different isotypes of the PPARs, and this one is a weakly potent pan-PPAR agonist, so both alpha, delta, and gamma, that has shown good metabolic improvement in patients with dyslipidemia and diabetes. So this drug was tested this time in a very short trial, phase 2b trial over 6 months, only an international trial where people with very active NASH, defined by a high activity score on the SAF scale, were treated with 2 doses versus placebo. And here again, the results are spectacular in the sense that the high dose of lanifibranor with a dose responses related effect was more effective than placebo for NASH resolution, more effective for fibrosis reduction, and more effective for when both outcomes were combined, NASH resolution and fibrosis reduction. And so this drug will go now into phase 3, and I think the phase 3 already started, just like with semaglutide. A third drug that is in phase 3 is the resmetirom, which is a selective thyroid hormone receptor agonist. So there are 2 types of thyroid hormone receptors, the alpha and the beta. And of course, the one that you want for a long-term treatment is a beta selective agonist, because most of the systemic side effects are due to the stimulation of the alpha thyroid hormone receptor. So we need to develop highly selective liver-enriched thyroid beta hormone receptors, because that will reduce lipogenesis, it will increase lipophagy, will improve mitochondrial biogenesis, will increase beta oxidation, and will also have, at least in the animal, anti-fibrotic effect. Such a drug exists. It's called resmetirom. The results of a phase 2b study have been already published. You might be familiar with the results. This drug was very effective in achieving NASH resolution after only 36 weeks. However, there was only a numerical difference in terms of fibrosis reduction. Of course, this is a short time, 36 weeks only. But what this drug has also, which has, by the way, excellent side effects, tolerability profile, what this trial has also taught us is that the more important the reduction in liver fat, the higher the probability to achieve NASH resolution, which is very interesting, because one of the yardsticks for early drug development in NASH is how much can you reduce liver fat. Now, there are other categories of drugs that more specifically target de novo lipogenesis. So part of the liver fat content comes from an inadequate production of liver fat in the liver, in the insulin-resistant liver. And by trying to block, to inhibit some of the key enzymes involved in lipogenesis, such as acetyl-CoA carboxylase, fatty acid synthase, steryl-CoA desaturase, it might be possible to achieve sufficient reduction in liver fat content so that to induce resolution of steatohepatitis and possibly fibrosis improvement. And so there are some drugs now in development in phase 2 that have been recently published, each one targeting very selectively some of the enzymes involved in lipogenesis. And I'm going to show you the clinical results of one of these drugs for which there is histological demonstration of the efficacy. And this is Aramcol, which is a steryl-CoA desaturase inhibitor. You can see that in this international trial over 1 year with histological endpoints, 2 doses of Aramcol, resolution of NASH was not statistically significant from placebo, but was clearly dose-dependent and numerically different. And this was true also for fibrosis improvement. There was a clear, statistically significant biochemical improvement in ALT and also improvement in HbA1c. Finally, another very promising drug, of course, is obeticholic acid. This is the only drug that has now phase 3 trial results at the interim analysis, very large international trial, more than 2,300 patients are now ongoing in this trial. And the results have been published 2 years ago. Improvement in fibrosis clearly more than placebo. However, no benefit in terms of NASH resolution, at least in this analysis here. What is interesting is that not only there were more people that improved fibrosis, but also there were less people that progressed in terms of fibrosis, which is very important if you look at the ultimate objective, which is less cirrhosis. There were 3 times more people on the high obeticholic acid dose that had fibrosis improvement than those that had fibrosis worsening. And if you look at a more stringent criteria of antifibrotic response, which is 2-stage fibrosis improvement, of course, the numbers are lower, but they're still significantly different from placebo. Interestingly, there are several FXR agonists in development, which are called second-generation FXR agonists. And the reason for developing those is that, as you know, the side effects of obeticholic acid are mostly an LDL increase and pruritus. And the assumption behind developing FXR agonists that are of a different non-biliary structure from obeticholic acid is that they might be more potent pharmacologically, but also they might have less side effects in terms of pruritus and LDL increase. Now, we have already in 2021 results from several of these second generation FXR agonists, and I'm showing you here some of the important molecules in development and the publications that are now available. And actually, what they all show is that these agents still have LDL improvement, LDL increase, probably less so than OCA, but they do have pruritus. And pruritus is therefore a class effect, and a class effect that is highly dependent on the dose. So the higher the dose, the more pruritus with all these agents. So we'll see whether this slightly improved tolerability profile will also translate into a maintained histological benefit or not. This needs to be shown in phase 2b trials, and those are ongoing. So in this very brief overview, there's still many unanswered questions that are very interesting in trying to understand where the field goes and whether our assumptions are valid or not. Is it sufficient to target a single pathway, or is it totally inefficient because redundant pathways will take over and compensate for that? Most drugs have pleiotropic actions, but how do you determine at an interim analysis whether one action is more important than others? Because you have to decide on an endpoint whether it's improvement in fibrosis or in inflammation, and you can't get this wrong because then the trial will fail. Is there a place for metabolic drugs that act other than by inducing weight loss? Are these going to be efficient or not? Or do you have to have weight loss if you have a metabolic drug in order to improve steatohepatitis? Also, does an improvement in metabolic dysfunction necessarily translates into an anti-inflammatory and anti-fibrotic benefit? We've seen that metabolic dysfunction is probably what drives lipogenesis and lipotoxicity, but is that sufficient to improve the disease once it is established? Is the pathological assessment as we read it nowadays with the pathologists, with human pathologists, sufficiently reliable to have consistently robust readings, especially in phase 3 trials? Does an effect on steatohepatitis result on an effect on fibrosis always? And how long does it take to have that effect? Does the efficacy on histological surrogates, whether you improve steatohepatitis or fibrosis, will necessarily translate into clinical benefit? This is the very big question that is being asked by the outcome phase of these phase 3 trials. Will it be possible to even complete these outcome trials over 2,000 patients and 5-year durations with a placebo arm? That is a question that still needs to be answered. And how do you define objectively risk benefit? And this is a very important question, knowing the story of obeticholic acid and the filing to the FDA. So there are many unanswered questions, but this is a very vibrant field of research. And with the results of the REGENERATE trial of obeticholic acid, we can say that we already had a very important milestone success, and I hope other positive trials will follow. Thank you for your attention.
Thank you, Vlad. That was an excellent wrap-up of the state-of-the-art potential therapies in NAFLD. We'll now ask my co-moderator to get some polled questions that came in. I think the first one is to Dr. David Victor.
Yes, this is coming in through the poll, and again, you can see there the mechanisms for asking your questions through whatever modality you're using to watch this. So we do encourage questions from as many of you as possible. This is for Dr. Victor. As a primary care physician, I've known there is no available treatment for NASH other than lifestyle modifications. Is any study drug, at least in phase 3, of any current research? And I'll direct that to you, and then as well to Dr. Ratziu.
I think Dr. Ratziu just probably, this was a little premature. My sandwich in the middle, the peanut butter of the sandwich, didn't quite answer this, so I'll defer to Dr. Ratziu on this one.
Okay.
Thank you. Hello, everyone. Very nice to see you again. You look great, by the way. Congratulations on the quality of the resolution of your screens here. You look, I won't say you look better than real life, but very close to it.
We're in Hollywood.
Can you briefly repeat the question? So the question was about dietary and lifestyle measures, and whether...
What are the phase 3 that are coming through that you're the most excited about?
with pharmacological agents?
Yes.
Well, listen, I've been really following this field for many years, so I'm excited about any phase 3 coming. But we did have some recent failures with agents that clearly did not have enough potential to succeed. So I was probably, my enthusiasm was misplaced for those trials. Nonetheless, those that are left are very exciting. The resmetirom drug is extremely interesting because of the excellent tolerance profile. And all of these have shown the GLP-1 receptor agonist. Now, here is probably short answer, something extremely exciting, because not only semaglutide has shown great results in terms of weight loss, but also NASH resolution, as I've shown, but also now there are second and third generations that are dual and triple agonists that achieve even higher weight loss. I didn't show data here, but there are some like GLP glucagon or GLP GIP or GLP FGF21 dual or even triple agonists that achieve even higher weight loss. And it will be very interesting to see how these perform versus semaglutide and versus placebo.
As a follow-up question to that, this goes to Dr. Jacob George first, and then Vlad and Dr. Victor. Clearly, I think we are all aware that NASH is a multi-pathway dependent disease. So we have all been looking at one drug being tested at a time to see which one would be the silver bullet, and as Dr. George said, it's almost impossible to find that single magic silver bullet. What do you think about combination therapies in NASH? Are there any potential drugs in development that are being looked in terms of combination 2 or 3 at the same time rather than going at it one at a time? So I'll say the first question goes to Dr. George, and then Vlad, you can chime in, and Dr. Victor as well.
Yeah. Thanks very much, Victor, and thanks to everyone. As Vlad said, the internet's really working very well, and as is the resolution. As I mentioned in my talk, I think fundamentally fatty liver disease is a disease of ectopic excess adiposity. Any drug that actually works with reduction in excess adiposity, ectopic adiposity, fundamentally hits the pause. If you hit the pause, then you get actually all the downstream benefits. Now, excess adiposity gives all the other concomitant risks that kill people in fatty liver disease, including the cardiovascular and the renal and other effects. So because of that, I fundamentally believe that metabolic drugs are going to be the way we get new therapies into the market, and they will be the first ones. And Vlad very elegantly listed some of these drugs. Now, to the question of multiple drug combinations, I think this is really important, and we've recently published several papers on talking about innovative clinical drug designs, adaptive trial designs, where you have a platform trial where you try multiple drugs, they go in and out based on multiple endpoints or a single endpoint in the liver. And I think it is going to be a much more efficient way for drug development. But currently, the FDA in cancer, adaptive trial design and platform trial designs are happening. It hasn't really happened in fatty liver disease, and it's really talking about one drug for one disease. And in liver, as Vlad pointed out, we've got a major problem in the fact that liver-related endpoints are so slow to develop, which makes it all very, very difficult. Whereas if we look at cardiovascular endpoints, they develop in populations much easier. So it is a big problem. But ultimately, to show an additive benefit, if you have a potent anti-adiposity ectopic fat drug of any other agents, I suspect will be very difficult to show.
Any other further comments, Vlad?
So all this is obviously true, and to put it simply, there's one major issue with combination therapies, which is the regulatory framework. So in order for the agencies to approve a combination, they have to define a regulatory framework that is feasible, because the way it's being defined now which is only alluded to in terms of transposing it to NASH. They take as an example what's being done for tens of years in hypertension or diabetes. And the way it's done in hypertension, diabetes, which is what they initially wanted to translate to NASH, is that you have to prove first that each individual component of the combination works better than placebo. And second, that the combination itself works better than each individual active component. So that means that you have to perform these very, very large trials with 4 arms, the factorial design, where you have placebo, drug A, drug B, and the combination. And you have to prove what I just said. And if the proof needs to come from histological outcomes, you can imagine that these trials will need such a large number of patients with biopsies before and after that will probably be impossible to perform. So either the regulatory framework changes or that will not be possible. Now, that is not a very scientific answer, but it is important because you have to go through the regulatory process. Now, in terms of combinations, of course, so it's interesting what Jacob says. He's very confident about the metabolic drugs because he probably thinks that by controlling the metabolic dysfunction, this will have an direct impact on the inflammation, lipotoxicity, and therefore on fibrosis and so on. Well, it remains to be seen. It kind of makes sense. It might take a while to have that effect, but the problem also, the second conceptual problem with combinations is that how do you combine and what do you combine? Because we had surprises when defining combinations. You would think, like, if you don't know anything about this field, you would think that you would have to combine 2 agents that are very effective. So you have to find 2 effective agents and demonstrate the combination works better. But it doesn't always work that way. Sometimes, and we had this example in viral hepatitis, an agent that is totally ineffective, such as ribavirin, if you combine it with an effective agent, then you can achieve a significant gain in efficacy. So it's not very easy to decide what to combine. Sometimes you can have surprises, such as the one I mentioned. And you need to be sure when you start these trials about which ones you choose, obviously, because it's enormous amount of effort and money. So it's not quite clear how do you combine drugs that work on different pathways? Do you combine drugs that annihilate each other's side effects? Do you combine drugs in order to have improved efficacy in a responder, or do you combine drugs that have a higher number of responders with not necessarily more efficacy? So it is not simple. And what I can tell you for now is that most combination therapies failed. And you'll see some results at the AASLD forthcoming 2021 edition.
All right, thank you.
I think an important point also to make, taking on to what Vlad said with combination therapy, is that the histological endpoint has got so many problems. And ultimately what we're dealing with is we want to be able to look at the outcome for the whole patient. And so as soon as you have agents that impact competing risks, cardiovascular, diabetic, renal risk, that is, in the larger framework of things, going to define what happens. And that's why I really believe that we need really rethink about what we are considering as endpoints for these metabolic diseases.
Well, thank you.
I very briefly, I think we have a philosophical difference here, but it will take another session to discuss that. I really believe our focus should be on improving the liver outcomes and not the overall cardiometabolic benefit, because we have drugs for that. But it's a different story, and everybody can feel differently about this. But I very strongly feel that we have to develop NASH drugs, not overall health benefit drugs in these patients.
Well, thank you so much to our guest speakers, Dr. Victor from our center, Dr. Ratziu, and Dr. George. I know that it's the evening in France, and it's 3 o'clock in the morning in Australia, but right now it's lunchtime in the United States, and so we're going to take a break now for lunch. I would encourage all of our attendees to visit the virtual exhibit hall, and Dr. Nkomase is going to give you the details on how to do that.
Sure. So for the virtual exhibit hall, you should go to the website where we are logged on, and you should find different exhibitors coming through. We also sent you a link, a Zoom link, that tells you about the Genentech Product Theater lunch session. That's also a Zoom link for 30 minutes. Dr. Kodali, myself, and Dr. Jalal will be talking about liver cancer and the awareness for liver cancer. So I strongly encourage you to visit those two sites, the Zoom link that was emailed to you, and also the links on the website for this conference. Again, thank you all. We'll reconvene again after those exhibits and product theater talks at 12:40. So you have about 30 minutes to kill, and then we'll see you back at 12:40. Thank you very much.
Thank you.
Thanks, Vlad.
Thank you,
Thanks,
Victor.
George. Yep.
Bye-bye, everyone.
Yep.
Bye, Jacob.
See you, Vlad. See you, Victor.
Yeah.
Bye, everyone.
Bye.
Hello, Anna. Hello, Paul.
How are you, Steve?
Very nice. You look very nice, Paul. I like that coat.
Yeah, it used to be a shower curtain. I cut it down and created a jacket out of it. But thank you for noticing.
You can only get that in New York,
Yes, very true.
not in
I,
Ann Arbor or Chicago.
How are you, Steve? Very nice.
Hi, Anna.
Hi.
It's nice to see you.
Good afternoon. Welcome back. I think everybody had a hearty lunch, and we are now on the third session of the program, Hepatitis Old and New. It gives me great pleasure to introduce the co-moderator for this session, Dr. Robert McFadden. Dr. McFadden is Interim Chief of the Division of Hepatology at the Houston Methodist Sherry and Alan Conover Center for Liver Disease and Transplantation. He is an excellent hepatologist, a lot of experience and a great interest in education. And he would lead off by introducing the first speaker.
Thank you, Dr. Comase. I appreciate the introduction. It's my pleasure to introduce our first speaker for a debate, which is the first set of lectures for this afternoon. Our speaker is Dr. Anna Locke, who currently is hepatologist and Alice Lorman Andrews Research Professor in hepatology. She is Director of Clinical Hepatology and Assistant Dean of Clinical Research in Ann Arbor, Michigan. Her expertise is the natural history of viral hepatitis and also has interests in liver cell cancer and fatty liver. And she has published over 550 papers. It's my pleasure to introduce her, and our topic this afternoon, first topic, can there be a cure for chronic hepatitis B? Dr. Locke.
Hello, everyone. First of all, I'd like to thank the organizers for inviting me to participate in this very interesting debate on can there be a cure for hepatitis B. I'm Anna Locke, and I'm from the University of Michigan. These are my financial disclosures. Our topic is whether there can be a cure for hepatitis B, and I've been asked to speak on the pro side. Well, as with all debates, success and the definition is really in the eyes of the beholder. For example, would you consider these two guys as having made it to space? Let's just come back to our topic today. Whether there can be a cure for hepatitis B depends on how is cure defined. What is the desired cure rate? How long a duration of treatment is acceptable? And what is the price patients and society are willing to pay? The key for today's debate is the definition of a cure. In the last 5 years or so, through consensus conference organized by the AASLD and EASL, we've all come to accept that when we talk about hepatitis B cure, we're referring to a realistic functional cure, which is similar to patients with chronic hepatitis B with either spontaneous or treatment-related S antigen loss using the current therapies. These patients will be surface antigen negative with or without seroconversion to anti-HBs, undetectable HBV DNA. They will be negative for hepatitis B antigen, but we expected the HBV DNA to still be present in the liver, though not transcriptionally active, and there will also be integrated HBV DNA. Liver inflammation is expected to be quiescent, but there may still be some residual fibrosis that regress over time, and the risk of liver cancer remains but declines with time. So we've all accepted that sterilizing cure with complete elimination of hepatitis B likely is not possible, at least in the foreseeable future. But functional cure with S antigen loss and HBV DNA remaining negative after a finite course of treatment is possible, because currently this does occur at a rate of roughly 1% per year in patients not on treatment, up to 5 to 10% of patients after 1 year of interferon treatment, and 2 to 8% after 10 years of entecavir and or tenofovir treatment. Now, we're not satisfied with this, and our current goal is to increase the success rate to at least 30% with only 1 to 2 years of treatment. One would argue, is functional cure good enough? Well, there are a lot of benefits, and there are incremental benefits compared to just HBV DNA suppression without S antigen loss, because there's further reduction in risk of liver cancer, and for the patients, the removal of the stigma of hepatitis B infection. The slide illustrates that spontaneous S antigen loss can occur over time, roughly at a rate of 1% per year, but in fact, it is not linear, rarely happening in younger patients and with accelerated rate as they get older. I've also mentioned that S antigen loss can occur, albeit not commonly, with currently available therapy. With pegylated interferon, 1 year of treatment and 3-year follow-up, roughly 10% of patients will achieve S antigen loss. With entecavir and tenofovir, after 10 years of treatment, the rates are about 2 to 8%. But more interestingly, in recent years, we've also learned that sometimes continuously putting the patients on NUC therapy does not result in the highest rate of S antigen loss, but rather stopping NUC may increase the rate of S antigen loss. Many of these are based on retrospective studies, but this is an example of a prospective randomized controlled trial in which E antigen negative patients with no cirrhosis and more than 4 years of NUC therapy with suppressed HBV DNA were randomized to either stop NUC or to continue NUC. And what you can see is that in the group that stopped the NUC, they had a higher rate of becoming S antigen negative, in fact, 10% at 96 weeks after stopping NUC. So this is certainly one interesting approach that merits further exploration. You would argue that all these would result in still very low rates of S antigen loss. But in recent years, there have been many new antivirals in drug development, in fact, in clinical trials. And this involved multiple classes of drugs, including the capsid assembly modulators, entry inhibitors, HBX inhibitors. Hepatitis B exon protein is involved in epigenetic modification of cccDNA. Inhibitors that block surface protein release, the NUCs that we all know very well. And then there are the siRNAs and the antisense oligonucleotides that block viral protein production, as well as packaging of virus particles. And there are also compounds that directly modify cccDNA transcription or increase the degradation. Let me show you a few examples. These are the RNA interference or antisense oligonucleotides. What they do is that they enhance the degradation of the viral RNAs, thereby blocking the production of viral proteins, but by also increasing degradation of the pregenomic RNA that prevents packaging into the virus nucleocapsid and replication of the DNA, and therefore production of virions. By reducing S antigen, it may also help to restore immune response. Well, is that true? So this is an example of one study in which 3 doses of siRNA are being administered, and within a very short period of time, you can see a marked drop in S antigen level by 1.5 to 2 log. And despite the fact that these were only administered over a short period of time, the decline in S antigen remained persistent for up to 9 months after the last dose in some of these patients. I indicated that many experts believe that the abundance of circulating S antigen may be suppressing the host immune response. And if we're able to grossly reduce S antigen level, maybe we can reawaken the immune response. And this is one example in which siRNA was given to the patients, resulting in a marked drop in S antigen titer of about 1.5 to 2 log. And here you can actually see an increase in CTL response to the virus surface antigen, indicating that if we're able to suppress the S antigen enough, we can restore CTL response to the virus proteins. So far, I've only shown reduction in S antigen level, but what we are hoping to achieve is actually S antigen loss. And can that be accomplished? And yes, this is a study of a modified antisense oligonucleotide with 6 doses given over a 3-week period of time. You can see marked decline in S antigen level. And in fact, 4 of these patients achieved S antigen loss at the end of treatment, and 2 of them remain undetectable for surface antigen for several months afterwards. So these are very exciting, promising data. Well, there are other compounds too, capsid assembly modulators. They work in different steps. The primary action is to prevent proper assembly of core particles, resulting in aberrant or empty core particles, thereby reducing HBV DNA replication, export of variants, and production of viral proteins. But at higher doses, they also prevent proper disassembly of the core particles and establishment of infection in the hepatocyte nucleus, and also prevent recycling of core particles and replenishment of cccDNA. This is one example in which a capsid assembly modulator, together with entecavir in orange, result in a more marked suppression of HBV DNA replication. And with 24 weeks of treatment, surface antigen decline up to 3 log was actually also observed. We know that we're going to need more than one class of drugs, and this is an example of a triple combination therapy of siRNA, capsid assembly modulators, and nukes, resulting in suppression of HBV DNA as well as S antigen. But more importantly, this provides proof of concept that triple combination therapy can be safe and well tolerated. And finally, there are also entry inhibitors. And this is mostly currently studied in hepatitis delta co-infection. But in this particular study, bulevirtide together with PAC interferon combination therapy also result in decrease in S antigen by more than 1 log. Most impressively are the nucleic acid polymers, the RAP 2139 or 2165. They block the assembly and all secretion of subviral particles, surface antigen. And you can see here, the patients were initially treated with tenofovir, and then they received addition of PAC interferon and the RAP. And you can see a marked drop in surface antigen, appearance of surface antibody, which you don't see if you just add PAC-related interferon alone. However, this study, this combination does result in quite substantial increase in ALT level. It is interesting, though, that even after treatment was stopped, on follow-up, 40% of the patients remain in functional cure with undetectable surface antigen, undetectable DNA, and normal liver enzymes. So you can see that there are multiple examples of new antiviral that might bring us closer to functional cure. For some patients, they may need extra boost by stimulating the immune response. And here again, there are multiple therapeutic vaccines, innate immune activators, checkpoint inhibitors, CTL vaccines. There are just multiple different approaches to stimulate the immune response as well as to remove the inhibitory blockade. Well, to date, immune modulatory therapies have not been very successful, but we heard earlier this year at the EASL conference, very exciting data, granted that this is a mouse model, in which they present altered surface antigen epitopes, similar to that which you can find in chronic hep B patients with clear surface antigen, and with just 3 doses of this therapeutic vaccine, the mice actually had a marked drop in surface antigen compared to those that received placebo, and this is currently being tested in humans. So as I've mentioned, we're going to really need combination therapy, but we have these tools now. We just need to pick the right one and the right duration and the right dose. So first, we're going to suppress virus replication using entry inhibitors. the NUCs and the core assembly modulators. Then we reduce the surface antigen production. This either would be in sequence or concurrently using siRNA or the antisense oligonucleotides. For some patients, this might be enough to achieve functional cure, whereas in others, we're going to need immune stimulation with either TLR agonists, anti-PD-1, or T-cell vaccines, B-cell vaccines, and maybe interferon would also play a role. So in summary, can there be a cure for hepatitis B? Yes, functional cure is possible. We'll need combination of 2 or more classes of antiviral drugs, and for some patients also immune modulator therapy. Treatment duration would need to be at least 1 year or longer. Cure rate will be better than current therapies with interferon or NUC. Initial cost will be high, but as more drugs become approved, competition will drive the cost down. Some medications may have more adverse events than NUCs and may need to be administered as subcutaneous injections, but we'll be able to offer our patients a choice of finite versus indefinite therapy. So I hope I've convinced you that I'm right, the functional cure is indeed possible. Thank you for your attention.
I'd like to take this opportunity to thank Dr. Victor Ancoma-Say and the organizers of this meeting for the opportunity to be with you here today. And I must say that it is an incredible honor for me to be sharing the stage, at least virtually, with Dr. Anna Locke, who I consider one of the world's preeminent experts in hepatitis B. And despite my admiration and respect for Dr. Locke, I think she's going to have a difficult time convincing us all that a finite cure for hepatitis B is coming anytime soon. So I have entitled my talk, Hepatitis B, Can There Be a Cure? And the answer is, I hope so. So what's the agenda? So I'd like to define how we're defining a hepatitis B cure. And because I don't think a finite cure for hepatitis B is coming anytime soon, I think we need to really carefully assess what are the current regimens that we have available and what are they achieving. So therefore, asking the question, is long-term viral suppression effective? The other question is there something I can do today to improve cure rates with currently available therapy? And then finally, we'll talk about, will future therapy be effective? Will patients lose surface antigen and become surface antibody positive or achieve a functional cure? Or will patients lose cccDNA and then develop a sterilizing cure? So when I have a patient with hepatitis B in my office, I take out a piece of paper and I draw this circle. And I tell the patient that we are going to go on a journey. Here's the starting line and here is the stopping line. And these are the things that we're trying to achieve with your hepatitis B therapy. So when we put patients on effective antiviral therapy for their hepatitis B, we can expect as we go down this pathway that we'll be able to achieve an ALT that's normal in approximately 80 to 90% of patients. We'll be able to eradicate or at least make their hepatitis B virus undetectable in between 70 to 90% of patients. But unfortunately, most patients get stuck at this spot along the pathway. But that's okay, because even if they're stuck here, we would expect an improvement in histology and an improvement in their levels of hepatic fibrosis and diminish their risk for liver cancer. Now, if we continue therapy, about 24% or so of patients will lose e antigen, about 20% of patients will lose their e antibody, but only a very small percentage of patients will lose their surface antigen, and even a fewer percentage of these patients will lose their surface antibody. Now, despite the inability for these patients to lose e antigen, lose surface antigen, and become surface antibody positive, if they can normalize their ALT and diminish or at least achieve undetectable viral loads for their hepatitis B, those patients are developing a significant improvement and a significant change in the natural history of their disease. There are multiple studies that show this, and this is an old study with the first tenofovir versus adefovir study, where patients were started on tenofovir or adefovir, and after 1 year, they were converted to tenofovir if they were on adefovir, or they stayed on tenofovir. Now, what was important about this study is that a liver biopsy was done at the beginning of the study, at 1 year, and at 5 years after the study had been started. And we learn a lot when looking at the histology in this patient population. So at baseline, when we're looking at the patients in orange, light blue, and green, looking at their fibrosis of 4, 5, and 6, you can see that year by year by year, the patients with advanced fibrosis diminish their advanced fibrosis quite significantly. And in fact, 74% of patients who had the most significant fibrosis, Ishik 5 and 6, no longer had cirrhosis at year 5. Now, this benefit was not something that you only see with tenofovir. This is an entecavir study where patients who were both e antigen positive and e antigen negative had a liver biopsy at the beginning of therapy and at the end of therapy, and between 57 or 59% of these patients had a significant improvement in their level of fibrosis. Now, what about liver cancer? And this is a nice study that looked at ways to predict risk for liver cancer using something called the REACH-B estimation, the risk estimation for hepatocellular carcinoma and hepatitis B. And you can see on the left, the patients who are non-cirrhotic at baseline, the observed rates of liver cancer, as shown in orange, were dramatically lower than what was predicted. Now, in the cirrhotics, clearly those cirrhotics remained at risk for liver cancer, despite the fact that these patients were treated with hepatitis B therapy for an extended period of time. This benefit was also seen in patients on long-term entecavir therapy. What you see in this study is that the observed rates of liver cancer, as shown in the circles, was much lower than what was predicted, the predicted rates of liver cancer. So therefore, again, another demonstration of the benefit of achieving undetectable viral loads in these patients and improving their ALTs. Now, there's been a lot of interest in the concept of when to stop hepatitis B therapy, when to stop the patient's tenofovir or their entecavir. And traditionally, we have been taught that we want to wait till patients lose surface antigen and become surface antibody positive, or potentially consider discontinuing therapy in patients who become e antibody positive. So in this study of e antigen negative patients who had been on tenofovir therapy with undetectable viral loads for at least 4 years, these patients were randomized to either stop their tenofovir or continue their tenofovir. And in this study, and granted, these were mostly patients from Europe with genotype D who were white. However, you can see that in this patient population, a fair number of patients had a diminution, a significant diminution in their surface antigen. And this is a really important concept to remember for now, as well as when we look at novel therapies and new therapies coming down the pathway for hepatitis B. So in these patients who had a dramatic reduction in their surface antigen, you'll notice that in the patients who continued on tenofovir, those patients had minimal change in their surface antigen. However, at the end of the study, which was actually significantly valuable and significantly beneficial, 62% of patients were able to stay off therapy, 19% of patients lost their surface antigen, and 43% of patients either lost surface antigen or had a hepatitis B virus DNA less than 2,000 international units, and these patients were able to stay off therapy. So this is one study, and you may say, hey, listen, show me another study. So here's a recently published study looking at 57 e antigen negative patients who are non-cirrhotic. All had been on hepatitis B therapy for a median of 6 years. All of them stopped therapy, but at the point where they diminished therapy, their hepatitis B virus DNA was undetectable. So at the end of the study, off therapy, 50% of patients did not require to be restarted on their hepatitis B therapy after a follow-up of about 65 months. 20% of these patients lost their surface antigen. And one really important concept was that patients who had low surface antigen titers at the beginning of the study, when they discontinued therapy, those patients were much more likely to be able to lose surface antigen. So if you look at patients on the dark gray bars, these are patients who remained without the requirement for retreatment At the end of the 2-year study, about 50% of patients did not have to go back on therapy. And if you look, about 37% of these patients had hepatitis B virus DNA less than 2,000 with normal ALTs. So this brings up the concept that maybe we can refine our current hepatitis B therapy and think that in our non-cirrhotic, chronically suppressed antibody positive patients, they may be eligible for treatment discontinuation with very careful follow-up. Now, as we move towards thinking about novel therapies for hepatitis B, and all of us clearly hope that there will be a day soon where we're going to have finite therapy for hepatitis B that's curative, we have to define what cure means. And in this very nice table from Dr. Locke, we know that in the vast majority of patients, we can achieve a partial cure. Can we make their viral loads undetectable? These patients, however, will remain surface antigen positive. In a certain percentage, they'll lose e antigen, become e antibody positive. And is this an achievable endpoint today? The answer is yes. Now, other definitions of cure would be, what is functional cure? So functional cure is achieving everything in partial cure, but developing a circumstance where patients lose surface antigen with or without the development of a positive surface antibody with an undetectable viral load. So in this functional cure, patients have lost their surface antigen and in the best of circumstances become surface antibody positive, and cccDNA, which we'll talk about, becomes transcriptionally silent. Now, of course, the best potential outcome would be achieving the complete sterilizing cure, where cccDNA, the reservoir of hepatitis B within the hepatocyte, is eliminated, integrated hepatitis B virus is eliminated, cccDNA is transcriptionally silent, we've lost surface antigen, viral loads undetectable, patients become surface antibody positive, they lose their e antigen, they become e antibody positive. And is this an achievable endpoint now? No. Is this an achievable endpoint in the future? I hope Dr. Locke can convince us that this will happen. So this is a nice way when you think about how hepatitis B replicates, and this is from a very nice recently published paper that Dr. Locke presented. So I know that she will go through this, but I just want to bring up the concept that in our patients with hepatitis B, this reservoir of intranuclear cccDNA becomes a continuous ability for patients to continue to replicate their virus. And potential treatments coming down the road. I'm sure that Dr. Locke talked about these, but I hope that she has convinced you that the way to achieve both a functional and sterilizing cure will likely be with a combination of these agents, either a core protein allosteric modulator or a CPAM, RNA interferons, single-stranded oligonucleotides, or some combination of multiple of these agents. Now, let's spend a moment, though, talking about what's happening in the nucleus and how to define success with therapy based on what we can measure. So if we're saying a sterilizing cure will require loss of cccDNA, it's very cumbersome to think that we would actually have to do liver biopsies to measure cccDNA. Is there a better way to do this? So one measurable component is something that many of you have hopefully seen, is something called hepatitis B core-related antigen. And hepatitis B core-related antigen is something that can be measured in the serum that is reflective of pregenomic RNA, infectious virions, and therefore is a surrogate for cccDNA. So one could argue that I would want to define success with novel hepatitis B therapy if we can knock down cccDNA, if we can knock down pregenomic RNA, and the way to measure that is a serum test called hepatitis B core-related antigen. If we really want to determine and define how these new hepatitis B therapies are going to be successful, we would optimally define this as, is the patient achieving an undetectable hepatitis B viral load? Are the patient's liver enzymes normal? Is there a significant decrease in hepatitis B virus surface antigen to undetectable with the development of surface antibody? And is there a decrease in loss of pregenomic RNA, which we are going to define with the surrogate test, the hepatitis B core-related antigen? And we want these changes to persist after therapy is discontinued. Now, as I stated previously, hopefully we are all convinced that achieving a functional cure and or achieving a sterilizing cure is going to require a combination of several different therapies. And I'd like to show you a couple of these studies. So this is a study looking at therapy with a triple combination of an RNA interference, a CAM, and a nucleotide. So these are patients who were already on entecavir or tenofovir. These patients had 2 agents added to their regimen, an RNA interference agent, as well as a CPAM. And you can clearly see that this combination was associated with a very nice drop in surface antigen and a very nice drop in hepatitis B virus DNA. However, the investigators said that reductions in hepatitis B core-related antigen were generally less pronounced. And this is potentially concerning because without this knockdown of hepatitis B core-related antigen, we're likely not getting a knockdown of cccDNA, and therefore achieving a sterilizing cure with this combination may potentially not be possible. Now, what about this other study, which has recently been published using a nucleic acid polymer, either Rep2139 or 2165, plus tenofovir plus pegylated interferon? So in the group of patients who received a 24-week run-in with tenofovir and then the addition of pegylated interferon plus this nucleic acid polymer, you can see very nicely that the surface antigen titers dropped very well and surface antibody titers increased as well. And in fact, at the end of the study, when patients were off all medications, 78% of these individuals were hepatitis B virus DNA undetectable, and almost 40% of these patients had achieved a functional cure. So the first question is, in this combination, what happened to the hepatitis B core-related antigen levels? Did they increase? Did they decrease? Did they stay the same? Because if they did not decrease, sterilizing cure would likely not occur. The other issue with this study is that these were all white patients, 95% genotype D, which may not reflect the vast majority of patients with hepatitis B worldwide. And the therapies were given as an infusion and unfortunately required interferon. So the bottom line is that this might be a difficult regimen for most patients to tolerate. So my observations on the potential for a hepatitis B viral cure is that combination therapy success and future therapy success will be defined by both achieving a functional and a sterilizing cure. Remember that the data that you see in these clinical trials, you have to think a little bit about the tolerability of these regimens. Remember, clinical trial patients are different than real life patients. And when you tell patients that they need to be on infusions and injections and get therapy like interferon, which may have some significant side effects, that this may be difficult, particularly if therapy is required for a long period of time. And without any question, a hepatitis B virus sterilizing cure is likely going to be possible, but we will all likely be retired when it is available. So I thank you all very much for your attention, and thank you again for the invitation.
Thank you so much, Dr. Gaglia, and Dr. Locke for those excellent presentations. So we are now going to move into a session to have some time for rebuttal. I want to remind the audience to join either by web, going to Poll Everywhere, so POLLEV.com, enter DeBakey, and you can respond to the activity by entering your questions there. The other option is to join by text. Text DeBakey to 37607 and enter your message for any questions. And at this time, I want to give first Dr. Locke a time to respond to the CON presentation.
So thank you, everyone. I hope you can hear me. I have great respect for my opponent, Paul, and he really highlighted 3 things. First, he said that the current therapy is highly effective in suppressing the virus, improving clinical outcomes, including reducing the risk of decompensation and liver cancer. And for the first 5-10 minutes, I thought he said it, well, we're in a good state. Why do we need to even think of any new therapies? The second point that he made was, yeah, there are all these new therapies, but they're not quite there yet. And the third point that he made was, we're all going to be retired by the time we get to a cure. So the first thing that I am going to say is, yeah, current therapy is pretty good. We've certainly seen many of the patients benefited with reduction in risk of clinical outcomes. And even some patients who present to us with decompensation gets recompensated again. We've all just finished watching the Olympic Games not too long ago. It's great to actually be selected and qualified to compete. But you wouldn't be quite satisfied with just being able to go and not get on a medal stand, right? So we shouldn't be satisfied with that. And when we talk about a cure, why we need to work on it is because we want to get on a medal stand. And not just the bronze, but actually the gold. That's why we're working on getting a cure. And yeah, I mean, I agree with Paul that with the current therapies, we're just still in early stage development, some of them preclinical, some of them are in phase 1 or 2 clinical trials, and none of them have actually moved to phase 3 clinical trials. So part of the reason why we're not seeing the maximum response is we're still trying to find the optimal dosing regimen and certainly the duration. As with all new drugs, when we test them initially, we test them for much shorter duration just to make sure that it's safe and it's doing what we expect it to be. Then we use the right dose for longer duration of time. And as I've shown you, with some of these drugs, we've already seen that patients can go on to clear surface antigen. And some of them, even though it's not clear, it's very durably suppressed for a long period of time. It's a matter of whether we can add additional doses. Paul also mentioned that surface antigen loss alone is not sufficient to indicate cccDNA clearance, that we need to look for the HBV RNA and the core-related antigen, and I absolutely agree with that. Majority of these clinical trials do measure these new markers, but none of these new markers have standardized assays, and so one assay varies from the other. And until we really have standardized assays with international units, we don't really know what it means when results are being reported as undetectable in one assay. Does it really truly mean that it's undetectable? I believe that Paul is younger than me. I have no intention of retiring anytime soon. We're having a good time working in a very exciting era. There are a lot of things that we never imagined we would see in our lifetime. And when I first started my career, we didn't have hepatitis C. We call it non-A, non-B hepatitis. But we're now curing hepatitis C in more than 95% of patients. And I'm still not retired. So I don't know what Paul is talking about. I certainly look forward to seeing a cure before I depart from this earth. Thank you.
So, Dr. Gaglia, would you like to respond? We can't hear. I think that you are on mute. Could you, we can't hear you. I don't know how to tell him he's on mute.
I think it's someone his.
Thank you so much for that, for those comments. And so at this time, I'll see if Dr. McFadden has any comments about the treatments for hepatitis B. At this point, we don't have any questions from the audience. So a few more comments, and then I think we can proceed to the next session.
Thank you, Dr. Mobley. I believe the future for hepatitis B treatment is certainly promising. And I believe that it certainly is going to be exciting as well. One question that I have, and does not particularly need an answer necessarily, is that we see so many patients with hepatitis B core antibody, and this always brings up the debate about what we do to use an antiviral or not. And perhaps that question can be directed at Dr. Gaglio or Dr. Locke personally. Thank you. Are we ready for
Dr. Locke? Dr. Locke, if you're still available, would you like to respond?
I think we're off.
I think that we have completed the connection, so we can move on to our next session, and Dr. McFadden is going to introduce our next speaker.
Our next speaker for this afternoon is going to talk to us about strategies for the elimination of chronic hepatitis C. Our speaker is Dr. Stephen Flamm. He is Chief of Liver Transplant and Professor of Medicine at Northwestern Feinberg School of Medicine in Chicago. He has been actively researching and has a program in chronic viral hepatitis, hepatic encephalopathy, and autoimmune processes such as primary biliary cholangitis, primary sclerosing cholangitis, and autoimmune hepatitis. Thank you, Dr. Flamm.
Okay, well, I'd like to thank everybody as well. I cannot tell if you have my slides. Can you let me know? Because I can't see my slides.
No, we cannot see them currently.
I am sharing.
Okay.
And they're not coming up. I just didn't want to have this happen. Or do you see them now?
I think they should be showing up soon.
I have mine up. It says I'm sharing, and my slides are up on my computer. Do you see anything, or you don't?
We can see them.
Oh, great. Perfect. All right. Well, with that, with the IT stuff behind us, I'd also like to thank Dr. Ankoma Say for inviting me to speak to you today about a different topic, hepatitis C. Dr. Locke just mentioned hepatitis C, and she segued perfectly into my talk, because where in the past we've thought that hepatitis C would not be cured in our lifetime 10 or 15 years ago, that certainly changed much more rapidly than any of us thought. And as all of you know in this audience, within the past 5, 6, 7, 8 years, the dramatic advances in hepatitis C therapy have been literally remarkable. And it's led to the point that in recent years, the World Health Organization has now attempted to devise strategies to eliminate hepatitis C. And we're going to talk about some of those strategies now and some of the recommendations that the World Health Organization has made in recent years, keeping in mind that these strategies have to be broad-based because they have to deal not just with the United States. We're talking about global elimination. So we have to deal with low, middle, and high income countries. And the strategies, again, have to be sensitive to that. First of all, what are the definitions? When you first hear the term HCV elimination, the first thought is this means we're going to eliminate hepatitis C from the planet, like smallpox. That's actually not what elimination means. Eradication means decreasing global prevalence of a disease such as this virus to zero. And if that were to happen, you would need no ongoing surveillance or control efforts. And that may be achievable, but only really if without a vaccine and a lot of other public health measures to distribute the vaccine. Elimination, which is what the World Health Organization has designed strategies to achieve, and what we're going to talk about in the next 30 minutes, means a decrease in local and regional prevalence of hepatitis C below a threshold to limit impact as a public health problem. You still need ongoing surveillance and control, and this is challenging but feasible with the right tools. Now, specifically, what does HCV elimination mean according to the World Health Organization? The hope was that by the year 2030, we would achieve these goals. And these goals mean a decrease by then of 90% of new infections and a decrease in the death rate from hepatitis C by at least 65%. The thought then was that, again, although hepatitis C would still be present, it would be much less impactful in a negative way across the world from a morbidity and a mortality standpoint. In this regard, the World Health Organization, beginning in 2014, started to design and publish strategies to achieve elimination of hepatitis C around the world. And there were publications on multiple occasions. The last I'm aware of was in 2018, accounting for advances in the field and refining the strategies to eliminate hepatitis C. And we're going to talk a little bit about the 2018 publication because it's the most up to date, and there actually haven't been a lot of changes in the field since then, where pan-genotypic direct-acting antiviral agents are now recommended for treatment of hepatitis C in the hopes of achieving this worldwide elimination. We're going to talk briefly about the story behind the guidelines, the main contents of the guidelines, clinical practice under the guidance of the guidelines, and a little bit of sharing of clinical experience where we talk about some of the pertinent challenges that we in the US and around the world face if we're going to really achieve the goal that we want, elimination of hepatitis C. Now, the objective and principles of the World Health Organization guidelines are listed here. The idea is to provide up-to-date evidence recommendations on the care and treatment of HCV-infected people, including when to treat them and what treatments to use, not only in adults, but in children and adolescents. And the principles are also outlined here. The hope was that the guidelines would achieve sustainable development of these goals by achieving global and national hepatitis goals, no matter what nation you're in. The idea was to expand the use of antiviral therapy for HCV and the development of HCV-related prevention, management, and treatment based on public health strategies around the world. And finally, the implementation of these guidelines really must, of course, be based on local conditions, including the epidemiology and prevalence in a particular region or area, availability of resources in that area, the organization and capacity of health systems in that area, and the expected cost-benefit ratios in that area. Now, the guidelines from a few years ago offer the following. First, the reasons that they're to be promoted are because we now have safe, effective, direct-acting antiviral regimens that we use in the US and are used internationally for all patients. And because they're so effective and well-tolerated, it improves the balance of benefits and risks in treating patients, even patients with early disease. Second, we have the pan-genotypic products now, and they've been approved generally around the world. And the cost of therapy has also reduced somewhat. It needs to be reduced further, but it's been reduced somewhat, especially in low and middle income countries, such that therapy is available in many places around the world. So what are the main contents? The guidelines are written with these strategies that include all types of different things. And we only have a few minutes to talk, so I picked a few out to highlight. For instance, there are recommendations on therapy, when to start therapy, what treatment types should you use, and treatment recommendations for different populations. When to start therapy, the types of treatments, I told you already, the recommendation in 2018 changed because of the advent of the pan-genotypic direct-acting antiviral agents, which really has been one of the major developments that really allow us to think about elimination of hepatitis C, even in low-income countries. And then these recommendations for adolescents and children. This is something that will change in the next iteration of the guidelines because we now have much more data and approvals in certain countries for pan-genotypic therapy in children, which weren't there in 2018. Why is the World Health Organization not only recommending pan-genotypic therapy here, but in countries all over the world? Well, this is obvious. We all know on this call the safety and efficacy of these medications. I will just review them briefly. This is sofosbuvir and valpattosvir, the 12-week regimen. And when you look overall or across the board at any of the 6 genotypes around the world that are observed, you see uniformly outstanding efficacy. And as Dr. Locke mentioned earlier briefly in her hepatitis B rebuttal, when she mentioned hepatitis C, we now achieve cure in at least 95% of all the subpopulations of hepatitis C, pretty much all of them, no matter what genotype you have. And the same is also true for the other pan-genotypic regimen that's been approved in many places of the world, glecaprevir and pibrentasvir, which is an 8-week regimen. And it too has excellent efficacy across the board in all 6 genotypes. Now, the way the World Health Organization guideline recommendations are listed is actually shown on this slide. And again, I didn't show all of the different recommendations. I just wanted to give you an idea of how they look in the publication. They actually have the different pan-genotypic regimens, the length of therapies, and other recommendations, if necessary, based on genotype. Again, a lot of this is similar to what's in the AASLD IDSA HCV guidance document, but again, this is in the World Health Organization document. And for example, here it shows adults with cirrhosis, adults with compensated cirrhosis, and there are other recommendations for other patient populations that are available. Keep in mind, this isn't just for the US. This is for all low, middle, and higher income countries. When you look at the summary of the World Health Organization guidelines, keeping in mind that their goal is to achieve HCV elimination, they have what they call the 3T treatment strategy: treat all, treat simple, and test simple. If you're going to achieve HCV elimination and have strategies that work in all countries with different public health strategies, different access to medications, you need to really simplify the approach: testing, treatment, and treating as many people as you possibly can. Now, this is a summary of the guidelines, and they have this treatment algorithm. And again, the idea is not to look at this and memorize it. It all kind of makes sense. It's all based on minimizing testing and the difficulty in treatment and follow-up. So, for instance, there's no genotyping recommended in this strategy by the World Health Organization. And this is particularly helpful in low and middle income countries where such testing may not be available or too expensive if it is available. You check an antibody test, which is relatively inexpensive. You need to do an HCV RNA test, which we'll talk about briefly in a few minutes, because that confirms the infection. If you're infected, they treat patients with the pan-genotypic products, which is why genotyping is unnecessary. There's no resistance testing, for instance, recommended either. You, in the end, check HCV RNA again 12 weeks after therapy. 2 virologic tests, baseline and 12 weeks after therapy is discontinued to determine if a patient has SVR. There's also fibrosis measurements that are suggested to be done because people, of course, that have advanced liver disease need liver cancer screening. And the recommendations are that very inexpensive and available testing, for instance, APRI or FIB4, are to be used for fibrosis assessment. And this is it. This is what is recommended to achieve elimination by the World Health Organization. So to highlight it, no genotyping, no resistance testing for virus, simplified liver function assessment and fibrosis, and keeping in mind that only 2 RNA tests are recommended by the World Health Organization, particularly in areas of the world where testing is too expensive or even unavailable. So what are some of the clinical issues we have to deal with if we're devising strategies for elimination? Keep in mind, 1, pan-genotypic regimens are optimal. This is not a revelation. 2, we always have to keep in mind drug-drug interactions, and these 2 are touched upon in the World Health Organization document. No matter where you are, this has to be kept in mind. Keep in mind, too, that protease inhibitor regimens are contraindicated in patients with decompensated cirrhosis. Of course, patients with decompensated cirrhosis should be cared for by, if possible, experienced treaters for hepatitis C. And the idea is to simplify the pre-treatment workup, on-treatment follow-up, and post-treatment follow-up. I have one slide here on protease inhibitors. A class effect for protease inhibitors in the DAA space is that they can have hepatocyte injury. Now, this certainly isn't an issue in patients that have no cirrhosis or compensated cirrhosis, but if you have a rare case of hepatotoxicity in someone with decompensated disease, there were and have been post-marketing reports of DAA regimens with protease inhibitors in them where patients deteriorated. And the thought was by the treating doctors that the deterioration might have been related to the medical regimen. So FDA here in the US does not recommend protease inhibitors in decompensated patients, and that is also accepted by other bodies around the world. We also, as I mentioned already, want to assess hepatic fibrosis, even in low and middle income countries, because having cirrhosis, I mean, if possible, having cirrhosis is something that you want to know for a particular patient, especially if there are some resources to follow them. I put this slide up because I think it's very instructive, because I even find that in hepatology units like mine, where we have very experienced nurses, nurse practitioners, physician's assistants, there is a tendency to believe that these fibrosis measurements are gospel, that they're right all the time, and they're actually not. And that includes FibroScan. The sensitivity for cirrhosis is about 75%, which means 1 in 4 people that actually have cirrhosis will not show cirrhosis on a FibroScan. And similarly, the specificity is about 90%, which means about 1 in 10 people that FibroScan suggests have cirrhosis actually don't. And when you look at some of the other non-invasive hepatic fibrosis testing that we do, that's true across the board. You'll note FIB4 and APRI which are free, actually have very similar, at least sensitivity than FibroScan. In fact, depending on the cutoff value that you use. So keep this in mind. These tests are not always right. And sometimes, at least in the United States where we have availability of tests, you may actually want to get 2 different non-invasive assessments of fibrosis, particularly if you have a suspicion that a patient may have advanced liver disease. This is a study looking at minimal monitoring. And I just wanted to put it up because this is a strategy that's being investigated and implemented around the world. The societies are also now, the liver societies are also mentioning minimal monitoring strategies for some patients with hepatitis C. I think you'll see this expand in the coming years. This was a study presented in 2020 at AASLD, looking at a multinational open label prospective study where patients were given soft-vel for 12 weeks with a minimal monitoring strategy. They had to have RNA positive at the beginning. They had a FIB4 assessment at the beginning. There was no genotyping done. Patients were given the entire course of soft-vel at the beginning. There was only a phone call at week 4 of therapy, and then another phone call at week 22, which was 10 weeks after therapy was done, and 2 weeks before the SVR assessment to remind the patients that they had an SVR assessment, which they did. This was a very minimal monitoring strategy. And when it was all over the world, it was done in North America, South America, Africa, Asia, and there were almost 400 patients enrolled. And when you look at the sustained virologic response, it was 95%. With the minimal monitoring strategy. 17 patients out of the 20 who didn't achieve SVR did have virologic non-response, and the other 2 were lost to follow-up, and 1 just had a sample that wasn't in the SVR window when they came in to get it. So this strategy worked around the world in the vast majority of patients. And by the way, there weren't a lot of patients that had unplanned visits, a small number. There weren't a lot of side effects reported, only 1 that actually resulted in soft-vel discontinuation amongst the 400 people. So I believe you're going to see, in an effort to achieve HCV elimination, particularly in low and moderate income countries, more of these minimal monitoring strategies. And now we're going to finish talking about the sharing of clinical experience. And I want to talk about some of the hurdles that we have to clear for us to really achieve elimination of hepatitis C, not only in low and middle income countries, but here in the US as well. We're going to talk briefly about screening and diagnosis, linkage to care, access to medical therapy, and treatment of challenging populations, in particular, people who inject drugs. As far as screening goes, we all know the difficulties of screening. We think in the US still, up to 50% of patients who have hepatitis C haven't been diagnosed even here in a high-income country. We have, as all of you know, in the past, relied on risk-based screening for hepatitis C. That doesn't work very well. Subsequently, in recent years, there have been age-based screening implemented on top of the risk-based screening. First, there was the birth cohort, and now, starting early in 2020, screening of all people from age 18 to 79 recommended by CDC and USPSTF in the US. And I will say that's starting to gain some traction. At Northwestern, at least in Chicago, I am seeing patients now screened, a lot of it because it's in the EMR. And we are picking up some patients with hepatitis C, and they're getting referred to our hepatology group that previously weren't being referred before. Now, of course, this has to be done, these types of screening initiatives, in other countries as well. Now, diagnosing hepatitis C also is a problem, or confirming it, because HCV RNA testing is difficult in some places. Again, not so much in the US, but certainly in low-income, middle-income countries. Fortunately, there are point-of-care PCR tests that are being developed, salivary or even blood, with finger sticks that are actually very accurate. And you can diagnose within an hour in the field a confirmed case of chronic hepatitis C. Right now, if you have to get an antibody test that gets sent out, there's a phlebotomy, the results come back, you got to go back to the patient again, get an RNA test if it's available, the results come back. It's a long journey. And if you're going to eliminate hep C, particularly in many parts of the world, this isn't going to work. But this finger stick testing, for instance, does. And this is relatively easy to use. It's not expensive. And it's very accurate. And you can see some of the accuracies here in terms of finger stick even, where sensitivities and specificities of HCV RNA are approaching or equal to 100%. It takes about 60 minutes, though, so it's not ideal because you have to have a patient sit around if you want to deal with them right there. And maybe we can improve upon the speed that the testing actually can be carried forward. But in the field, they can go to villages and places and do this testing and find out if a patient has active hepatitis C in an hour, and then administer therapy on the scene. We need to do better with prevention of transmission. Strategies are needed to minimize onward transmission and reduction of high-risk behaviors. That's not only transmission back to yourself. If we treat successfully hepatitis C, of course, you can get hepatitis C again if you are re-exposed or you re-expose yourself. And furthermore, you certainly can give hepatitis C to other people. So we need a lot more education with HCV awareness for prevention of transmission to others and ourselves. Safe injection practices for injection drug users are helpful, and sexual risk reduction, particularly in people that have anal receptive intercourse, which has a higher rate of transmission of hepatitis C, to actually prevent transmission of hepatitis C. Harm reduction interventions are always helpful too, and that can be, for instance, with medication-assisted therapy for opioid users and needle syringes. And then access, of course, if you want to treat patients, even patients that are disadvantaged, you need to have access to the DAA regimens. And remember, you're treating people, even people that might have a risk of getting hep C later, like a person who's injecting drugs. You treat them because when they're negative, they're a lower, they don't transmit hepatitis C themselves to other people. So the burden of virus in the society is lower. Now, fortunately, there are generics now around the world for many of the antiviral regimens for hepatitis C, including the pangenotypic regimens, and the cost of drugs when they first came out, remember, sofosbuvir was $84,000 and cimeprevir was $66,000 when we used SOF and SIM together, which was really the first DAA all-oral regimen that showed very high efficacy. This was not a pangenotypic regimen, but in the US, the cost, you might remember 6-7 years ago, was over $150,000. Yet the production price, you can see, for the two pills is more on the order of $200 or $300 together. The price has certainly come down around the world, particularly in low-income countries and even in the US. And because of that, we now have better access to therapeutics. How are people doing with elimination? Well, there are countries working towards elimination, not that many. 9 were on track a few years ago to eliminate hepatitis C by 2030, which was the initial World Health Organization goal, including the countries you see here. And some countries are actually ahead of the game, including Iceland, Australia, and the country Georgia, not the state of Georgia. World Health Organization HCV elimination targets. You can see red is bad, yellow is okay, not ideal, green is great. And sadly, you see lots and lots of red around the world, which means not on track for elimination of hepatitis C by 2030. And the other bad thing is, if you look closely, the red places are the places where the most people are. For instance, Eastern and Southern Asia, very high rates of people with hepatitis C because there's a lot of people, and not on track for elimination. The green countries, far fewer. We're in the yellow group here in the United States. We're working towards it, although at the current rate, because of the issues we have here with diagnosis, linkage to care, access to medications, and the opioid epidemic with new cases of hepatitis C, some of the estimates are we're on track to eliminate hepatitis C here maybe by 2050, actually, rather than 2030. And this is a slide looking at how are we doing with strategies toward elimination. And overall, around the world, not good. You see the green, which these are the good countries that are really on top of this. And you see the red, which are some of the others which have increasing HCV prevalence for various different reasons. So we need to do a better job. I'm going to finish in talking about treating people who inject drugs. This is important all around the world. And it's particularly important in the United States because the new influx of cases that we see with hepatitis C is largely young people caught up in the opioid epidemic. Now, in recent years, we never treated people that are using drugs or recently used drugs because we thought, they probably won't take Hep C medicine anyway, and we'll be wasting our time and energy. If they do, the fact that that they're using drugs may decrease their cure rate. And if they do get cured, they'll likely get reinfected because they're going to be using needles again. And yet in the last 4 or 5 years, there have been multiple studies around the world looking at treatment with different regimens for hepatitis C in people who inject drugs. And I just wanted to highlight one or two. This is one that was published a couple of years ago called the Simplified trial, which looked at 103 patients, genotypes 1 through 4, that were using drugs. They had to be either still using drugs, but had to be using drugs within the past 6 months. And they had to be treatment naive. These were not decompensated cirrhotics. These were not patients that had been treated previously. But again, they had to use drugs at least within 12 months, and many of them were using still at the time of the trial. When you look at the kind of people that were enrolled in this trial, 3/4 of them had used drugs within the last month. 1/4 of them had injected drugs daily within the past month. Almost 2/3 of them had used alcohol significantly within the past month. About 2/3 of them were on medication-assisted therapy, and 1/4 of them had unstable housing. About 10% had cirrhosis. This was a very challenging group of patients to try to treat. And yet, in the end, out of 103 patients, 97 of them achieved SVR, 94%. And there were no failures, none, of therapy. 6 people did not get an SVR. As I mentioned, 4 were lost to follow-up only. 1 actually died from an overdose, and 1 was reinfected. They did have a quote-unquote relapse, but the virus was sequenced and it was not the same virus. So antiviral therapy in people who inject drugs works, and it works at a very high rate, and it eliminates hepatitis C, even in very challenging patient populations. Now, this should dissuade us about whether they take drugs or not, or whether their outcomes will be hindered. And by the way, this study with other medical regimens has been replicated. There's one study, a similar study called the Anchor study using sofosbuvir and valpatisvir, and they looked at reinfection. And in about 2 years, in this study, out of 82 patients that had been cured, very difficult patients here, actively using drugs, high incarceration rate, very high homeless rate, very high alcohol rate, 82 patients cured. And in 2 years, 9 of the 82 were reinfected, but 73 of the 82 were not. So there is a reinfection rate, but it's certainly not what you might think. It's lower. So we should be very aggressive. And in fact, the AASLD IDSA guidelines do suggest treatment of patients who inject drugs, and other societies do too. We have to be very aggressive with these patients, not only to help the patients, but to help achieve our goals of HCV elimination. So in conclusion, the World Health Organization guidelines push for global elimination of hepatitis C. We will need different strategies depending on the public health sector of particular locales, access to medications, various different factors that are important for diagnosis and linkage to care in a particular society. But because we have highly effective therapies for HCV, cure rates approximately 99%, we can achieve HCV elimination, and we will do it with the pan-genotypic regimens. Certainly people 18 years and over should all be screened for HCV. Attempts to simplify medical therapy are ongoing in study and will continue to evolve in the coming years. HCV patients currently present challenges to effective therapy, but they can be overcome. And we should certainly, particularly in the United States, pursue aggressive treatment for people who inject drugs. Thank you.
Thank you and welcome back, everyone. Thank you so much, Dr. Flam, for that excellent presentation. We're going to go on to our next presentation. Remember that all questions and answers and a brief rebuttal from Dr. Gaglio will be following this presentation by our next speaker, who is Dr. Sami Saab. Dr. Saab comes from UCLA. He is very well regarded nationally and internationally. He's the medical director at UCLA in the adult liver transplant program. He's the chief of transplant hepatology. He heads the outcomes research in hepatology at UCLA. In addition to that, he is on the board of directors of several liver-focused foundations, including the American Liver Foundation, Liver Wellness Foundation, and the Chronic Liver Disease Foundation. He is a well-sought-after speaker internationally and had the very difficult job of teaching transplant surgery fellows hepatology at UCLA. So I would like to welcome my friend and colleague, Dr. Sami Saab. He is going to be talking to us about COVID-19 and the liver. Welcome, Dr. Saab.
Hello, my name is Sami Saab. I'm a hepatologist at UCLA. And today I'll be talking about COVID-19 and the liver. First, I want to thank our host for allowing me to speak today on this very important topic. Before we begin, I want to disclose my relationship with other companies. I'm the Speaker Bureau for AbbVie, Cicelis, Gilead, Adricep, and Salix, and I've been a consultant for the below 4 companies as well. In the next 25 minutes, 30 minutes, we want to cover 4 very important aims. We want to highlight how has COVID-19 affected patient care? How has it affected providers' practice? And you're going to see some ways that COVID-19 has affected people's practices and how we mitigated this to provide the best care possible. Next, we're going to talk about the frequency implication of elevated liver-associated tests when someone's infected with COVID-19. Thirdly, we want to talk about how does COVID-19 affect patients who have underlying liver disease, including those individuals who are immunosuppressed, such as transplant recipients. And fourthly, and equally important, we're going to talk about the efficacy of COVID-19 vaccine in patients with chronic liver disease and in people who've had a liver transplantation. So, providers' practices have had to adapt to continue to provide a high quality of care. As you know, people with chronic liver disease are at risk for a number of complications, ascites, variceal bleeding, hepatic encephalopathy, liver cancer. So unfortunately with telemedicine, patients have been reluctant to visit doctor's offices, to have blood drawn, to undergo procedures like endoscopy and ultrasound. So we've had to be creative and, how do we prevent and manage and treat these complications at a distance? So you see from the slide here some ways to adapt, like daily weight, the use of homemade delivery of medications, and a number of especially pharmacies have been doing this. Maybe lower the threshold for variceal bleeding prophylaxis with beta blockers or hepatic encephalopathy. So our threshold for being more aggressive with hepatic encephalopathy has been lowered. So we're more likely to prescribe lactulose or rifaximin if there's any question at all of the potential hepatic encephalopathy. But getting to this diagnosis has been also challenging. And so we have to make sure that we ask pointed questions during the interview. During the clinic visit, we're going to ask about, have people been forgetful, getting lost, trouble adding and subtracting? If their caregiver is present during the telemedicine visit, we'll ask them as well. Have their partner, their friend, their loved one been forgetful? And encouraging people to follow up with the ultrasounds. Now, this slide here predicted the impact of COVID-19 in clinical care. And many things have borne to be true. Unfortunately, there's been delay in many procedures, imaging, blood tests, clinic visits. And this has led to an increased rate of decompensation. Patients are not getting their fluid checked. They're going to get their weights checked. And they come to the ER with worsening ascites or edema. Patients have not come for transevaluation or follow up with necessary testing to remain active on their UNOS requirements. So the second wave has been an increased backlog of deferred tests and visits. And the third, unfortunately, is this loss of follow-up, misdiagnosis. Patients not getting ultrasound screening for liver cancer. And I'm sure we all have cases in our own practice where because someone delayed an ultrasound for 6, 12 months, when they do come back to the office, they have a tumor larger than it should be. And as you know, the treatment algorithm for liver cancer depends on the size, tumor burden, functional status, and severity of liver disease. And so the patient delayed their ultrasounds and the tumor grows, it will directly impact cancer treatment and their survival and prognosis. This is from a very controversial paper that was published this year and highlighting the impact on hepatitis C diagnosis. And argue that because of COVID-19, patients are not undergoing the recommended screening for hepatitis C with a simple blood test. And across the globe, this has led to a decrease of diagnosis of over 800,000 patients. This is translated to more liver deaths and liver cancer and viremic infections. I looked at these numbers a little closely and focused on the US in particular. And these numbers are not that off. So keep that in mind that many of our patients who should be screened for hepatitis C have delayed because COVID-19 infection. Now, needless to say, we've all seen an uptick in the number of individuals present to hospital with alcohol liver disease. And unfortunately, with COVID-19, this has been accelerated. And I'm sure your hospital back in Houston, you've seen more and more individuals presenting with liver disease, and these people are younger and younger. So what's happened is with COVID-19, there's been an increased isolation of patients. And we need the social aspect of drinking to a degree keep a check on what we drink and how much. When people have been isolated, that check has been gone and translates to more alcohol liver disease, more alcohol liver failure. And you see it from this recent paper in hepatology that after COVID and during COVID, the need for liver transplantation has increased significantly because of alcohol liver disease. So keep that in mind when in your practice, you see people in the clinic or in the hospital, and you see elevated liver tests. Make sure you think about alcohol. Because even our patients with PBC, autohepatitis, fatty liver, we're seeing an uptick in alcohol consumption. Now, this is from a best practice statement from the AGA last year when COVID-19 first started. And it highlighted to keep an open mind when people come into the hospital, particularly when they have elevated liver tests. And don't assume that elevation liver enzymes are always due to COVID-19. And make sure to keep a different diagnosis. For instance, DILI, autohepatitis, alcohol liver disease, hepatitis B and C. And make sure that when people are hospitalized, you check based on liver enzymes. And maybe monitor during the hospitalization. Because you're going to see here later that COVID-19 can raise your liver test to a variety of mechanisms. Or the treatment we use to treat COVID-19 can also affect liver-associated tests. At UCLA, we've had to develop a protocol because of COVID-19. As you know, when COVID-19 started, many institutions had put a halt or delay for the evaluation for transplantation and transplantation as a whole. The last thing we want to do is transfer someone here to our hospital who's COVID-19 infected and then expose the staff and other patients with COVID-19. So many hospitals, ours, have developed protocols to make sure that before patients are transferred to UCLA, they're COVID-19 free. This helps prevent, again, infection of staff and other patients alike. It also prevents patients from undergoing liver transplantation who have COVID-19. With the COVID-19, we have no idea what impact it will have on survival. After transplantation, we use many immunosuppressive agents. So next, what is the implication of COVID-19 and elevated liver tests? First of all, COVID-19 is a systemic illness. It affects many organs of the body, predominantly the lungs. The kidneys can be infected, intestines. It's the brain, eyes, nose, and heart and blood vessels. In fact, in terms of blood vessels, COVID-19 has been known to increase the risk of hypercoagulability, leading to pulmonary emboli, thrombosis, and liver vomit here shortly. As part of the systemic illness, the liver is involved. And about half the number of individuals who are admitted with COVID-19 have high liver enzymes. The potential mechanism of COVID-19 related injury can be related to two major buckets. They can be direct and indirect mechanisms. Coronavirus, COVID-19 can affect hepatocytes. And indeed, you can find virus in liver cells by PCR. ACE2 receptors are found in liver cells. And if people undergo liver biopsy, there's apoptosis reflecting direct COVID-19 liver injury. But as I mentioned earlier, COVID-19 caused problems because of a reflection of the systemic injury. When people have diseased kidneys or lungs, the liver can be an innocent bystander, an elevation reflecting systemic injury. Many of the medications we use to treat COVID-19 could also cause drug-induced liver injury. That's why it's important to get baseline liver tests and serum liver tests in people admitted. There's hepatic manifestation. We're going to talk about some more detail. Elevated liver tests, vascular thrombosis, and cholangiopathy. This is from a very nice, large study looking at median laboratory values at presentation, looking at the peak and most recent times. And you see here there's a large variability in terms of laboratory values. If you look at the median at presentation of alkaline phosphatase, disease 52, bilirubin 0.6, ALT, AST 4448, creatinine, INR, BUN, pretty normal. But at the peak, you see a large variation. Alk phos goes high as 2147, meaning be 1945. And look at the bilirubin. It could range and peak between 4 and 16.9, but the mean is 12.7. AST, ALT could also be significantly elevated as well. And the most recent laboratory tests, you see tend to trend down. So, but keep in mind, however, that elevated test is diagnosis of COVID-19 only by exclusion. And you got to do your due diligence, look for other causes. I want to highlight a new entity that's been described in the medical literature. So far, it's been described in the context of case reports. And it's called COVID-19 cholangiopathy. This is a secondary cause of cholangitis. And you see it from serial MRCPs, a progression, a worsening intrahepatic biliary dilation, and multifocal strictures. There's been now a number of centers that transplant individuals with COVID-19. These should be treated just like PSC, and strong consideration made instead of doing a duct-to-duct anastomosis, a Roux and Y. We have someone here listed now at UCLA with COVID-19 cholangiopathy. Fortunately, this is very, very uncommon. And during ERCP, what you see is tons of biliary cast. Unfortunately, ERCP is not diluted therapy. Many individuals have to be referred for liver transplantation. Well, we talked about a little bit of liver tests, talk about sclerosing cholangitis, and now I want to highlight thrombotic complications from COVID-19 in the liver. A number of studies have highlighted the increased incidence of thrombosis involving the mesenteric venous system, the portal vein, and even the inferior vena cava. We submitted a manuscript recently about a patient who had primary biliary cholangitis, doing very well for years on ursodiol. All of a sudden, she had flu-like symptoms. Her alkaline phosphatase quadrupled. She underwent abdominal imaging and found to have this very large blood clot, extending from the infrarenal inferior vena cava all the way to intrahepatic inferior vena cava, with extension to the left renal vein. She was admitted, underwent thromboectomy and heparin, and doing very well. Next, we're going to talk about how COVID affects people with underlying liver disease, including those who are transplant recipients. So early on, the CDC recognized that people with liver disease are increased risk of severe illness. Other individuals that are also increased risk include the elderly, people who are 65, people immunocompromised. This includes your liver transplant recipients, people with cancers, people with autoimmune liver disease, and patients who have severe obesity, defined by a BMI over 40. Now, this is a very important study that was published this year, and highlights when you have people with chronic liver disease and they have an episode of decompensation, worsening ascites, hepatic encephalopathy, bacterial peritonitis, variceal bleed. Keep a differential that what could have triggered this? What could have pushed patient over the edge? And there's been increasing experience with COVID-19 being associated with hepatic decompensation. So keep this in mind to make sure you're testing for COVID-19. We had a patient recently who was traveling to Wisconsin who developed severe upper quadrant pain. And turns out the patient had COVID-19. This is from a nice paper published recently, fresh off the press, looking at liver-specific factors that predict overall survival in people affected with COVID-19. And you see here, without any doubt, that people with alcoholic liver disease, chronic liver disease, and liver cancer have worse survival than individuals without the alcoholic liver disease, without non-liver disease, and no liver cancer. So having alcoholic liver disease, chronic liver disease, liver cancer does put you at increased risk of early morbidity and mortality. Now, the data for liver transplant, it's not that clear. We do know that there is increased risk of being hospitalized, requiring high ICU care and treatment, and the need for invasive mechanical ventilators for breathing if you're a liver transplant recipient. But fortunately, the death rate, the mortality rate is not necessarily higher after liver transplantation. So they may be sicker with liver transplantation in terms of COVID-19 manifestations, but it doesn't always translate to increased mortality. This is from a very nice paper published last year, highlighting again that having a transplantation does increase your risk of being hospitalized and your risk and potentially of having other complications. But in terms of dying and mortality, not necessarily. This is a nice paper that was published last year in Lancet. And it looked at case fatality, dying from severe respiratory syndrome, coronavirus, according to your age and liver transplantation. And again, it highlighted that if people have severe acute respiratory problems with COVID virus, they're not necessarily a higher risk of dying from liver transplantation. What makes a big difference is age. And as you know from non-transplant patients, that one of the biggest predictors of dying early is age. The older you are, the less likely you are to survive. And this is also particularly true after liver transplantation. So now we're going to talk about another major issue, and that is COVID-19 efficacy, chronic liver disease, and liver transplant recipients. So first, this is from a statement from a number of medical societies, including NIH and AST, that highlights importance that people on the transplant list, people on the liver transplant list, kidney transplant list, heart transplant list, they should get vaccinated, ideally as soon as possible. And these vaccines should be completed at 2 weeks prior to organ transplantation, or started 1 month after transplantation. In such situations, it may be possible to delay 3 months if someone's getting thymoglobin or rituximab. And that's because the vaccine may not work in such situation. But the short answer is that everybody on the transplant list should be vaccinated. Do not delay. The last thing you want to do is see a patient of yours with chronic liver disease, decompensate, and they cannot get a transplant because they're COVID positive. So please encourage patients to get transplanted, to get vaccinated. Now, how does the vaccine work? Well, this is sobering. So this is a very nice study that was published this year in Journal of Hepatology, looking at comparing the response to vaccine in transplant recipients and healthy controls. And the 25 healthy controls that got 2 vaccines, in this case by Pfizer, the response was 100%. Every single person who was a healthy control that received 2 vaccines had an antibody response. In contrast, of the 80 patients who had liver transplant, who got vaccinated, less than half had antibody response, less than half. And if you look of those people who did have an antibody response and look how many antibodies they had, you see here the controls antibodies that were formed from the vaccine were much, much higher than those who had liver transplant recipient. the authors then looked at, why do some people fail? Why did over half the individuals who were vaccinated not respond to the vaccine? And the predictors of vaccine failure are listed here in the right-hand part of the slide. Age, decreased GFR, in other words, the kidneys aren't working as well. They also found that certain medications and combinations are associated with vaccine failure. The use of mycophenolate, high-dose prednisone, or people on triple therapy immunosuppression. For instance, people who are on prednisone, tacrolimus, and mycophenolate had lesser response. But the societies do say that if someone's on a stable regimen, AST and other transplant societies do not recommend changing their immunosuppressive regimens because of the vaccine. Because it's unclear what benefit this would have. You don't want to risk a chance of rejection by doing that. Now, if you look at the percent of subjects with the antibody response after 2 vaccines and compare different immunocompromised conditions, you see here that cancers, hemodialysis, organ transplant suppressive therapies all have a variety of response. But the one that's the worst are the organ transplant recipients, our liver transplant patients, do worse hemodialysis, and people with hematologic cancers, and worse immunosuppressive therapy, like autoimmune liver disease, or patients with colitis getting biologics. So clearly, there's been a major unmet need. This is from a paper published in New England Journal of Medicine, fresh off the press. And this is the Sentinel paper is what made us relook at vaccine strategy for liver transplant recipients. And it highlighted that, again, after second dose, a very small proportion of individuals who had a solid organ transplant respond to the vaccine. Very, very few. But after a third dose, look at this. The vaccine went from 40% to 70%, almost double. Almost double. And if you look at figure B, if you look at the titers, how many antibodies? You see a significant improvement toward higher titers after the third vaccine. Now, in the past 4 months, many countries have adopted policies for additional dose for immunocompromised patients. France, Israel, United Kingdom, and Germany, they all recommended additional vaccines, given the efficacy as measured by antibody titers is suboptimal. Now, how do we define immunocompromised individuals in the United States? Well, these are defined by individuals who've had active recent treatment for solid tumors or other malignancies, recipients of solid organ or stem cell transplant, patients with primary immunodeficiency, advanced or untreated HIV, recipients of a number of medication, including steroids, alkylating agents, immunosuppressive therapies, and patients with chronic medical conditions like Messier spleen or chronic renal disease. So the FDA, as you know, just recently authorized additional doses for those immunocompromised individuals I just mentioned. And they recommended a third dose of either Pfizer or Moderna. This should be done no sooner than 28 days after a second vaccine. Unfortunately, those individuals who may receive the Janssen COVID vaccine, we just don't know what the optimal vaccine protection strategy is for those patients. So fortunately, and hopefully, most of our patients receive the Pfizer Moderna, and they should be highly encouraged to receive the third vaccine. We looked at our own experience at UCLA, looking at the incidence of rejection following vaccination of COVID-19 in heart, liver, lung, and kidney transplantation. We found the safety, efficacy, the safety to be very good. Tolerance excellent, no nuisance adverse events, no rejection, and unfortunately, the efficacy I mentioned was subpar. And so we highly encourage our transfer recipients to get the third vaccine. So in conclusion, COVID-19 has really transformed the practice of general and transplant pathology. It's important to keep a threshold for testing for COVID-19, even among your patients who have already been vaccinated. In Los Angeles, 30% of COVID infections that are being reported are individuals who have been immunized. These are breakthrough infections. So please check COVID-19 and your patients are decompensating or worsening liver function. Patients with cirrhosis and liver transplant recipients are at risk of worse outcome than general population. COVID-19 is associated with a number of liver complications, some which are very unique to COVID-19, like the thrombosis, like this new entity called secondary cholangitis. So keep them at differential. And we need contour vigilance in immunosuppressed patients. Because although they do benefit from a third vaccine, the response rate is still below that we see from the general population. At this point, I want to thank you for inviting me to speak today and pass it on to the host. Thank you, everybody.
Thank you, Dr. Saab, for that wonderful presentation. So right now, we'd like to remind our viewers to either join by WebEx and go to Poll Everywhere, POLLEV.com, enter DeBakey to respond, or text DeBakey to 37607, and we will be able to answer your questions. But right now, first we want to, as we had some IT difficulties, we'd like to give Dr. Gaglio a moment to respond, the rebuttal to the pro-con debate for chronic hepatitis B. So, Dr. Gaglio.
Yeah. So essentially, during my rebuttal, I was just making the concept or the comment that I'm not allowed to retire because my wife told me I'm not. So I do agree with Dr. Luck, though, and she has convinced me, at least, that we're getting closer to being able to achieve a functional cure, which, of course, we want to achieve with all of our patients. I think I would just remind everyone, though, that we have to be really careful about looking at these studies, understanding what the markers for success are. So surface antigen loss, surface antibody, seroconversion, and some measure of figuring out if we're knocking down cccDNA. And I think without those two things, the concept of a sterilizing cure is going to be difficult. So, I and Dr. Locke and everyone on this call hope that before we retire, we'll be able to achieve the same thing in our Hep B patients that we can with our Hep C patients. And thank you.
Thank you, Dr. Gaglio. We do have one question, which is for Dr. Flam. If a patient becomes decompensated while on hepatitis C treatment, would you recommend completing medication or stopping medication at that point?
That's a great question. And to my knowledge, there aren't actually official recommendations about that. If a patient's on a non-protease inhibitor-based regimen, such as sofosbuvir and valpatisvir, you can keep going on the regimen, even in the setting of decompensation, because that regimen is approved. In fact, that regimen is approved in decompensated patients in combination with ribavirin to optimize SVR. But at the very least, sofosbuvir and valpatisvir is not thought to be deleterious. If a patient's on a protease inhibitor-based regimen, our goal is do no harm. I know many people that will stop antiviral therapy if a patient becomes decompensated because you don't want to hurt a patient. I guess it depends what the decompensation is. I saw one time decompensation that I thought in the end was from a protease inhibitor regimen, but it was not. It was before we were not where we were recommended to not use them. And in that setting, the patient actually developed jaundice for about 6 to 8 weeks before they actually decompensated. And I told them to stop the drug earlier, but they didn't because they were negative with the virus and said, I'm not stopping it. I have cirrhosis. And then later they came back in with full-fledged decompensation. So a hint to decompensation from the drugs is bilirubin rising. But the general recommendation, I think, would be if you're on a protease inhibitor regimen and you decompensate, in my opinion, would be to stop the antiviral therapy. And if any of the other people on the call have any other different thoughts, please chime in, Anna or Paul or Sam.
No, that sounds completely appropriate. But like you said, it's very rare to see decompensation on someone antiviral therapy nowadays.
So thank you, everyone. Right now, we don't have any more questions from our audience, and we are a bit over time. So in the spirit of keeping everyone on time, I would like to, we can move on to our break. I want to thank all of our speakers, Dr. Locke, Dr. Gaglio, Dr. Flam, and Dr. Saab very much for their excellent presentations. And please join us we will be resuming at 3:10 and for our final plenary session for the conference today. Please, everyone, come back and join us.
Thank you.
Thank you.
Good afternoon. Welcome to session 4. Topic is liver cancer. I am Sudha Kodali. I'm a transplant hepatologist here at Houston Methodist, and I'm joined here with my colleague here, a friend and a colleague, Dr. Abdul Rahim. Maeen Abdul Rahim is a GI oncologist here at the hospital, Houston Methodist Hospital, and I'm going to go ahead and introduce our first speaker. Dr. Laura Kulik is going to give a talk on local ablative treatment for small hepatocellular carcinomas. What are our options? Dr. Kulik is a professor of medicine, Division of Gastroenterology and Hepatology in the Department of Medicine at Northwestern University. Dr. Kulik did her training in Chicago, and her major clinical research focus is on the therapy and diagnosis of hepatocellular carcinoma. Dr. Kulik works in a multidisciplinary medical, radiologic, and surgical liver tumor clinic and is involved in the recruitment of patients with hepatocellular carcinoma into clinical trials. In addition to her clinical and research efforts, Dr. Kulik has collaborated with clinical experts around the world to publish over 100 papers. So, Dr. Kulik, welcome.
Hello, my name is Laura Kulik, and I would like to thank the organizers of this conference for the opportunity to present today. I will be discussing local ablative treatment for small hepatocellular carcinomas. What are our options? These are my disclosures. Specifically, I'd like to point out that I am not an interventional radiologist, but rather I am a hepatologist. And at Northwestern, radioembolization is a local regional therapy that is used across the BCLC staging system. This is the BCLC staging system in 2021, and there has been a significant movement due to multiple systemic agents that have been approved in the last 3 years and the advanced setting. This is now forcing us to look at the use of these agents earlier, and you can see here that there are many randomized controlled trials which are either completed or ongoing, and we are awaiting the results, not only in the advanced setting, but also in intermediate, as well as in the adjuvant therapy in the early to very early treatment stages. We'll be focusing on the use of ablation in patients with very early or early HCC. I've taken the liberty of reframing this question to what are the factors to determine if ablation is the right therapy for a small HCC? And this brings up several questions, including what defines the size of a small HCC? Is this less than 2 centimeters, 3 centimeters, or up to 5 centimeters? And what is the impact on if surgical options should be considered even if the tumor is small? What other local regional therapies could be considered if ablation is deemed not feasible? And finally, what is the role of combination therapies with ablation? And I will discuss all these highlighted areas when determining if ablation is the correct treatment for a patient. Radiofrequency ablation has been around for the last 2+ decades as a treatment for HCC. It uses heat to induce coagulative necrosis. In tumors, the temperature can be as high as 100 degrees Celsius for 10 to 30 minutes. This leads to a complete response in up to 90% of patients with early HCC. RFA can be performed percutaneous, laparoscopic, or via an open laparotomy. Outcomes have been shown to be similar to resection, with 5-year survival rates that are excellent, up to 86%. However, recurrence rates remain high at 5 years due to the fact that patients, majority of the time, have underlying cirrhosis and therefore are at risk of developing new tumors. Now, there are several considerations or limitations for the use of RFA, specifically when it is monopolar RFA. When lesions are greater than 3 centimeters, the chance of a complete response with 100% necrosis is rare. There is concern for heat sink, which is a phenomenon where a tumor is located near a blood vessel and the flow of blood will dissipate the heat that is being generated by the RFA and therefore increase the risk of tumor surviving and lead to a higher risk of local recurrence. There are some areas in the liver that can be difficult to reach from a percutaneous standpoint, specifically in the dome and the caudate. There can be increased risk of bleeding or seeding. Seeding has been estimated to be anywhere from 0.5 to 3% risk, specifically highest in subcapsular lesions. At Northwestern, our surgeons have made a decision that they do not want to use ablation percutaneously in patients who are deemed transplant candidates due to the concern for risk of recurrence post-transplant. And in patients with a very nodular liver, it can be difficult to visualize lesions under ultrasound in order to target the tumor, and therefore other imaging modalities such as CT or contrast enhanced ultrasound may be useful. Now, this is a very well-written review of ablation in general by Knott et al., and this highlights the management of potential risks that can be seen with RFA, and in the light blue are the ways to potentially decrease the chance of these risks. I'll highlight a few of these as I just discussed. If you cannot see the lesion, you can use other imaging modalities and subcapsular HCCs in order to decrease the risk of tumor seeding and bleeding. A no-touch approach with a bipolar RFA can be used. In patients who have had a sphincterotomy or have a biliary stent in place, they carry the highest risk of developing a abscess after RFA compared to other forms of local regional therapies such as intraarterial therapies, and this can be decreased by prolonged use of antibiotics in such patients. If a patient has a pacemaker, then it's recommended that a bipolar RFA be used or microwave ablation, and if platelets are less than 50,000, one would consider giving a platelet transfusion prior to a RFA. Now, this shows the various different risk of recurrence based on location and the time element. As we discussed, we can see patients who will develop local recurrence if there's not 100% necrosis versus patients who will develop a distant or de novo recurrence, and this has several risk factors associated with it, including the number and size of lesions, the AFP, the degree of portal hypertension, and then looking at the time frame. If patients develop a recurrence within 2 years, this is considered an early recurrence. If this is greater than 2 years, this is a late recurrence. And some of the risk factors here can be if their viral hepatitis was treated, the degree of portal hypertension. This definition is also the same as what is used in resection in terms of late versus early recurrence. Now, one of the newer ablation modalities has been microwave ablation, and this uses heat to cause the tumor to die, but the heat is generated via an electric field. And one of the many proposed advantages over RFA have been that the microwave heats up quicker, and therefore this allows shorter ablation times. It may be able to work near large blood vessels due to less of a heat sink issue. There may be higher or larger ablative zones that can be created with microwave ablation, and no grounding pads are required in microwave ablation as they are in a monopolar RFA. Now, this is a meta-analysis comparing microwave ablation to radiofrequency ablation. There were 28 studies, of which 4 were randomized controlled trials. They found that local tumor progression was significantly lower in microwave ablation in lesions less than 2.5 centimeters. Over here, looking at taking into account all factors, not just the size of the lesion, there was an improvement in terms of less local tumor progression in microwave ablation, and this became even stronger when looking only at the randomized controlled trials. The risk of development of new intrahepatic lesions when only pooling the randomized controlled trials showed that this was significantly less in microwave ablation. The addition of TACE in either of the ablation arms did not change the overall results, and they also found that the frequency of the microwave ablation was directly associated with the risk of local tumor progression, with higher frequency being associated with a significantly lower risk of local tumor progression, and lower frequency microwave ablation was associated with a higher risk of local tumor progression compared to RFA. Now, a newer meta-analysis was just published in 2020, and this looked at only randomized controlled trials, and it was only HCC. The prior meta-analysis also allowed for the inclusion of metastatic tumors to the liver. That was not so in this, so I think it was a little more appropriate for the discussion that we are having. And their primary endpoint was complete response rates, and you can see that this blue square is right in the 0, so there was no significant difference in terms of the ability to achieve a complete tumor response rate with RFA versus microwave ablation. And in a sensitivity analysis, nodule size using a cutoff of 3, where the study was located or conducted in the east versus The West, and the quality of the study had no impact on the chance of achieving a complete tumor response. In terms of overall survival, 1 year through 5 years, there was no significant difference in overall survival. However, at 5 years, the disease-free survival became significantly improved with the use of microwave ablation, and the rate of distant recurrence was significantly lower in patients who were treated with microwave ablation. The adverse events were not different between the two groups, and the number of sessions required was also not different. I'd like to also mention briefly cryoablation, which uses a freezing technique to induce desiccation of tumor cells and therefore tumor death. You can see that the ice ball is here, and this is actually able to be visualized while it is being performed in real time, which is one of the advantages of cryoablation. It's also thought that it is less painful than ablations that use heat. The disadvantage is that there is not a way to ablate the tract. And there has been a randomized controlled trial looking at RFA versus cryoablation in patients with a lesion up to 4 centimeters and up to a total of 2 lesions. In terms of local tumor progression, there was a significant improvement in favor of cryoablation. When looking at lesions greater than 3 centimeters, local tumor progression was less at 7.7% compared to 18.2% in RFA. However, this did not translate into an improvement in overall survival at 1, 3, or 5 years. I'd like to now move on to resection. We've seen this. Here we have highlighted ablation in the very early and early. This is a somewhat newer risk assessment for resection. We generally have avoided resection in patients with portal hypertension. However, this algorithm does allow for the presence of portal hypertension as long as the extent of the hepatectomy is minor, which is no more than 3 segments. And you can see that you get a risk stratification, also including the MELD score here on the left side of this algorithm. So if a patient has no portal hypertension, it's a minor resection, and their MELD score is not greater than 9, then their risk of recurrence is the risk of decompensation is 5%. Whereas if their MELD score is higher, this raises the risk of decompensation, and the highest risk is in patients with portal hypertension who undergo a major resection with greater than 30% risk of decompensation. Now, looking specifically at lesions that are solitary and less than 2 centimeters are defined as very early HCC, you are aware that patients are not granted a MELD upgrade. So patients have 2 choices. They can either undergo a resection or ablation, and this is a very strong statement that liver transplant should not be considered as a first-line option for patients with early HCC who are well compensated, Child-Pugh A with a normal performance status, but only as a salvage therapy if there is tumor recurrence after ablation or resection. And the SSLD guidelines said a single tumor less than 2.5 centimeters that are favorably located may be equally well treated with either resection or ablation. There is this phenomenon, however, that has developed called not ablate and wait in tumors that are less than 2 centimeters to let them grow, not treat them so they become up to 2 centimeters, and one can then achieve the ability to get a HCC MELD upgrade. However, there is the risk that patients will leapfrog from a too early HCC to one that is beyond the Milan criteria. And the risk factors for this are greater AFP greater than 500 and lesions that are growing at a rapid rate, which is defined as greater than 1 centimeter at a 3-month interval. And these are patients who one should not consider the not ablate and wait. According to the SSLD guidelines, in patients who are already listed for transplant, who are found to have a very early HCC, it is reasonable to not ablate and wait so that these patients can achieve a better chance for access to transplantation. Now, there have been several trials that have looked at ablation versus resection. I've highlighted these here. These all failed to show an improvement in overall survival, except for Hong and colleagues, which is highlighted here in the yellow. The most recent trial was the SURF trial that published its trial, its overall findings in 2021, and the 5-year overall survival as well as the 5-year recurrence-free survival were not significantly different. And this was specifically in less than 3 lesions and up to 3 centimeters, and the majority of these patients had a solitary lesion with median size of 1.8 centimeters. This is a meta-analysis of 5 of these trials that I've shown you, but it specifically used a trial sequence analysis, and they showed that the 1, 3, and 5-year overall survival rate when using trial sequence analysis was insufficient to draw firm conclusions, although the meta-analysis did show that the 5-year overall survival rate was significantly improved in patients who underwent resection. Recurrence, not surprisingly, was higher in patients who underwent RFA. However, there was not a significant higher rate of distant metastatic disease in patients, regardless of what treatment, resection versus RFA. And not surprising, hospitalization was significantly lower in patients who were treated with RFA. So this is a publication that looked at resection versus ablation in the very early or early HCC, but specifically stratified patients based on age with a cutoff of greater than 65 and tumor size. And these tumor sizes ranged from 2 centimeters to up to 3, up to 3.5, and up to 5 centimeters. And the conclusions that they found were that patients over the age of 65 with an HCC up to 2 centimeters, that RFA is the recommended strategy. Patients greater than 65 with tumors that are greater than 2 centimeters, so 2 centimeters to 5 centimeters, that resection becomes recommended. And in patients who are less than 65, regardless of the size, that resection is the preferred option. So just reminding everybody that the whole point of transplant is to improve overall survival. So when you look at the gain in life expectancy post-transplant, minusing the waitlist expectancy mortality, that there should be an overall gain in overall survival. So we may have patients who are too high risk and they have recurrence rates post-transplant would diminish their overall benefit of transplant. But what we're talking about specifically in this talk is in patients who are at very low risk potentially of dropping out from transplant. And this has been defined as a single lesion, 2 to 3 centimeters, an AFP less than 20 after local regional therapy, Child's Pew A, and a MELD sodium score less than 15. And these are patients who are less likely to have a significant benefit of transplant because they will do well without transplant in terms of overall survival, looking specifically at HCC. This was a very, I thought, provocative and interesting study that looked at the use of RFA as a first-line treatment in HCC solitary less than 3 centimeters in patients who were potential transplant candidates. So patients were considered not resection candidates. They had to be considered a potential transplant candidate. So you can see that they ruled out patients who were too elderly or had contraindications. They had to have a complete response rate after RFA, and the primary endpoint was the incidence of recurrence beyond the Milan criteria. And they pre-divided these patients based on the size of the lesion using 2 centimeters as a cutoff and the AFP level prior to receiving RFA. And you can see that there were a total of 301 patients who were deemed that they would have been acceptable transplant candidates who had a complete response after RFA. Their median age was 59. The majority were male. You can see that the most common was hepatitis C as the etiology. Tumor size, it was 2 centimeters. Median MELD was 9. Median AFP was 9, and the majority of patients had a moderately differentiated HCC amongst the near 60% who underwent a biopsy. And not surprising, 66% overall had evidence of recurrence, and the median time to recurrence was significantly longer in patients with a smaller tumor, 2.5 years in a very early HCC versus 1.5 years in patients who had a tumor greater than 2 centimeters. And when looking at the primary endpoint here, which was recurrence beyond the Milan criteria, predictors of this were tumors greater than 2 centimeters at the time of RFA and an AFP greater than 100 at the time of RFA. And so when they looked at patients and divided them based on greater or equal to 2 centimeters, there was no difference in the number of patients who were listed, but the risk of dropout was significantly higher at 45.5% in those greater than 2 centimeters compared to 23.1, which translated into a difference in the number of patients who actually underwent transplantation. This kind of supports that if greater than 2 centimeters, that a transplant would be more advisable as opposed to RFA, and I think supports what UNOS has decided in terms of using 2 centimeters as a cutoff. Now, there are patients where RFA may not be feasible due to the tumor location. This is from Robert Lewandowski, who is at Northwestern, looking retrospectively at patients with a solitary lesion less than 5 centimeters who were not amenable to ablation, most due to their location. They were all Child's PUA, and none of these patients subsequently went on to have a resection or transplant, so you could really see their natural history. They were given a ablative dose to the tumor in a segmental, so this is 1 to 2 segments, and the ablative dose is greater than 190 gray. And specifically looking here at tumors less than 3 centimeters, you can see that the 5-year survival rate is excellent at 75%, and this is comparable to other curative options. Here is highlighted what has been published in resection versus transplant, etc., and concluded that radiation segmentectomy provides a response, tumor control, and survival that is comparable to curative intent treatments, and therefore patients with early HCC with preserved liver function, a radiation segmentectomy offers a very reasonable choice, specifically in patients who are not amenable to an RFA. And this was a study that led to TheraSpheres, which is glass microspheres, in March being approved by the FDA. These were single lesions up to 8 centimeters, but I do want to point out that the majority of the median was 2.7 centimeters, and that when you looked at the overall response rate at 3 years in these patients of the entire cohort, this was excellent at 86.6%, and their primary endpoint, which was local control or overall response rate and duration of response, was met, and this led to the approval of radioembolization in HCC. Now, what about the use of combination therapies? There has been a lot of thought that the addition of TACE to RFA could be used in lesions greater than 3 centimeters, and here I've highlighted that with ablation alone, that the chance of complete ablation occurring, and once over the 5 centimeter mark, less than 50% have had a successful ablation with a monopolar RFA. And the thought process is that the occlusion of the tumor supply would increase the coagulant necrosis that you then achieve with ablation, and that the combination of TACE plus RFA would decrease the local tumor progression, therefore lead to improvement in overall survival and PFS. One of the criticisms of many of these trials has been that the comparative arm has generally been RFA, and there have not been a lot of trials that have looked at the comparative arm being chemoembolization. So this is a meta-analysis looking at 8 randomized controlled trials for a total of 648 patients, and they used a time to event hazard ratio, which was pooled, and the improvement in recurrence-free survival and overall survival in combination therapy showed a moderate degree of heterogeneity. However, when they did a sub-analysis, they found that the combination group, specifically in patients who had greater than a 3 centimeter tumor, and in patients who were younger, which is defined as a median age of less than 60 years, had a much better outcome with the combination of RFA and conventional chemoembolization with zero heterogeneity. So this is the group of people that it may be reasonable to consider a combination approach with RFA and the addition of chemoembolization. Now, there's been this thought of combining local regional therapies with immune checkpoint inhibitors, and this is based on the fact that some of the tumors that we see are cold tumors, so they don't have the proper T cells that have infiltrated the tumor. So when you add a checkpoint inhibitor, there is going to be a limited benefit because they have not been primed with the T cells that can be activated with the addition of checkpoint inhibitors. And therefore, doing things such as RFA may release neoantigens when the tumor is undergoes necrosis, and this could then lead to appropriate T cells going into the tumor and leading to improved chances of tumor death when the addition of checkpoint inhibitors is introduced. And the first trial that really showed this was looked at the combination of either RFA with a CTL4, tremiluzumab, and also looked at this with RFA. So there was RFA and TACE with this combination, and which was really interesting is they used subablative doses of RFA or TACE, and they biopsied the lesions that were not treated with local regional therapy, and they found that there was an increased number of T cells in patients who received immunotherapy, which brings up the potential of what has been known as the abscopal effect. So patients may be able to achieve an increase in the appropriate T cells by the use of immunotherapy, even when those lesions had not undergone local regional therapy. And this is an ongoing trial. This is a phase 2 trial. And this is the use of pembrolizumab in combination with local ablation in early HCC. Patients will first receive 2 cycles of pembrolizumab with ablation occurring on day 1 of cycle 3. They will receive a total of 12 months of pembrolizumab, and this is for lesions greater than 3 centimeters. Ablation in combination with TACE can be performed. There can be no evidence of extrahepatic spread. Patients have to be well controlled from their cirrhosis and be Child-Pugh A. There can be no more than 5 tumors, and the longest access cannot exceed 7 centimeters when these are added together. This is a total of 30 patients, and the primary endpoint is going to be overall response rate. So it'll be interesting to see if the use of pembrolizumab added, that ablation after undergoing pembrolizumab and then continued, if this leads to improved response rates. So in summary, ablation for the treatment of HCC is an excellent therapy, but should be decided on a case-by-case basis to determine if other therapies should be entertained, such as resection, transplant, radioembolization, or even the use of combination, which I would say that safety and utility, specifically in immune checkpoint inhibitors with ablation, is eagerly awaited. And with that, I would like to thank you for your attention, and I look forward to a discussion with all of you. Thank you again.
Okay, great. Thank you, Dr. Kolek, for this comprehensive and informative discussion. Before we go to our next speaker, I would like to remind our audience to send their question to Dr. Kolek by joining us and going to polev.com, enter DBAKI, and respond to activity. Or you can send your question by text DBAKI to 37607 and text your message there. With that, it's my pleasure to introduce our next speaker, Dr. Robert McMillan. Dr. McMillan is an assistant professor of surgery at the Houston Methodist Academic Institution and Weill Cornell Medical College. He earned his medical degree from Baylor College of Medicine at Houston, Texas. Then he finished his residency at New York Presbyterian Hospital and Weill Cornell Medical Center in New York City. After residency, Dr. McMillan completed a fellowship in multi-organ abdominal transplantation at UCLA under Dr. Ronald Postel. He is clinically heavily involved in kidney, liver, pancreas transplantation, and hepatobiliary surgery. And his clinical research focused on liver transplantation for intrahepatic cholangiocarcinoma and liver metastasis from colorectal cancer. It's really our pleasure to have Dr. McMillan with us, and we're looking forward to listening to his talk. Dr. McMillan.
Hi, my name is Robert McMillan. I'm one of the transplant surgeons here at Houston Methodist Hospital. It's one of my pleasures to be involved in our cholangiocarcinoma program, and I'll be talking about liver transplantation for cholangiocarcinoma in this talk. Cholangiocarcinoma is diagnosed based on the location within the liver. In this cartoon, there's a depiction of the tumor in different parts of the liver. For perihilar cholangiocarcinoma, this includes any tumors which are located at the point of the cystic duct insertion and proximal up to the right and left hepatic ducts. And for intrahepatic cholangiocarcinoma, this includes tumors which are above the right and left hepatic ducts up into the liver parenchyma. The cartoon also shows the 3 different histologic subtypes of cholangiocarcinoma, which are mass-forming, periductal infiltrating, as well as intraductal growing or papillary tumors. Cholangiocarcinoma is the second most common primary liver cancer, second to hepatocellular carcinoma. And there's about 40,000 cases of primary liver cancer in the United States per year. For cholangiocarcinoma, it ranges somewhere around 8,000 to 12,000 cases each year. Categorized by location, you see the different division of the distribution of cases, with the largest distribution of cases among the perihilar case group. We'll talk about intrahepatic cholangiocarcinoma and perihilar cholangiocarcinoma in this talk because these 2 diseases include transplantation for curative treatments. For distal cholangiocarcinoma, the curative treatment is generally a resection, which is a Whipple procedure. And for distal cholangiocarcinoma, these include cases which are distal to the cystic duct down to the insertion of the common bile duct into the ampulla of Vater. The incidence of perihilar cholangiocarcinoma is about 1 per 100,000 person years, and this incidence is stable. The highest incidence of the disease occurs in Thailand, where it's endemic, and in Thailand there's about 85 cases per 100,000 person years. The main risk factors for perihilar cholangiocarcinoma include congenital choledochal cysts, choledocholithiasis, and primary sclerosing cholangitis. In Thailand, where the disease is endemic, this is largely due to parasitic infection with liver flukes. And we'll take a moment now to talk a little bit about primary sclerosing cholangitis. As the audience knows, this is a chronic inflammatory and autoimmune liver disease, often associated with ulcerative colitis, and it's marked by cholangitis and stricturing of the bile ducts. The risk of cholangiocarcinoma in these patients is increased by almost 160 times, and there's about a 10 to 20% lifetime risk of cholangiocarcinoma. For this reason, these patients undergo surveillance with serum CA19-9 testing and imaging in the form of ultrasound or MRCP every 6 to 12 months. The diagnostic criteria for patients with perihilar disease to undergo transplantation and receive MELD exception points are threefold. First, patients must have a malignant appearing stricture on imaging. And in addition to that, there has to be confirmation of disease either with cytology or biopsy, which shows adenocarcinoma, with serum CA19-9 measurement of more than 100 units per milliliter, or with aneuploidy or polysomy on FISH, or fluorescence in situ hybridization testing. The tumor must not be larger than 3 centimeters in radial dimension, and it must not, the disease must not be metastatic to the lymph nodes or distant site outside of the liver, and the disease must be unresectable, either due to its location or intrinsic liver disease. And unfortunately, it's challenging to diagnose perihilar cholangiocarcinoma. This is because brush cytology analysis has a low sensitivity rate. And you can see that there's a little bit increased sensitivity for fluorescence in situ hybridization and also for cholangioskopy using often the spyglass platform, which allows for a targeted biopsy. The disease is paucicellular. It's very fibrotic, so there's not a lot of tumor cells. Importantly, percutaneous biopsy is avoided. This is a contraindication to patients receiving MELD exception points. This slide shows a typical imaging result that we see in these patients with bilateral intrahepatic duct dilatation. And this slide is courtesy of one of our endoscopists, Dr. Dacha, here at Houston Methodist. And what we see here is a view from a cholangioscope, the spyglass platform. And in the picture to the right, you see the tumor within the bile duct lumen. And using tools through this cholangioscope, endoscopists are able to perform targeted biopsies, which really have increased the sensitivity of diagnosis as well as specificity. Tumors, or rather patients that receive meld exception points must not be resectable. And this can be because of intrinsic liver disease, either due to cirrhosis or the presence of primary sclerosing and cholangitis, or it can be due to the location of the disease. There is a bismuth diagnostic type system, which shows whether the tumor involves either either the right or left hepatic ducts or lower down in the common hepatic duct. Bismuth type 4 tumors involve the confluence of the right and left hepatic ducts, and the tumors extend up to the segmental bile ducts. This is traditionally viewed as an unresectable tumor because there are no bile ducts that can be sewn to a piece of intestine for biliary outflow, and because due to the infiltrative nature of the disease going up the bile ducts, it is difficult to get an R0 or complete microscopic and macroscopic resection of all cancer. Additional reasons why a location of the tumor may be unresectable can be the involvement of blood vessels, which cannot be reconstructed, involvement of ducts on one side and vessels which would feed the future liver remnant on the opposite side, or essentially issues that cause the functional liver remnant not to be a viable liver remnant. So these patients are not able to have the option of a resection. Patients who meet the UNOS criteria for diagnosis of perihilar disease and who also complete a neoadjuvant treatment regimen qualify for MELD exception points. The current MELD exception formula is the median MELD at the time of transplant within 250 nautical miles of the transplant center, -3. So for patients in Houston Methodist, where the median MELD at transplant is about 30, they're given an exception point number of 27 if they meet criteria stated above. The most common standardized neoadjuvant treatment protocol is the Mayo protocol, and it's named after the Mayo Clinic. This regimen was devised there, and it was based on some findings which were originally noted in the University of Nebraska, but it was really advanced at the Mayo Clinic, and it leans heavily on the use of radiation. The regimen involves chemoradiation using sensitizing chemotherapy with 5-fluorouracil and external beam radiation of about 4,500 centigrade to the tumor, followed by the use of brachytherapy, usually involving a radium coils given through a nasobiliary tube to give an additional bolus dose to the tumor, or SBRT. And this is followed by oral capecitabine until the time of transplantation. Before transplant, these patients undergo a staging laparotomy to exclude any cases where there's lymph node involvement or disease that's distant outside of the liver. At the Mayo Clinic, if there's a planned living donor transplant, this may be done the day before, and they report that for deceased donors, they will often do the staging laparotomy or laparoscopy as they near the time when they might receive exception points or have a liver offer. The outcomes of transplantation are encouraging for patients that go through this entire protocol. And these outcomes are separated based on whether the tumor arises de novo or without the presence of an underlying diagnosis of primary sclerosing cholangitis. For those de novo cases, the 1, 5, and 10-year survival is shown here at 90, 58, and 49%. For patients that have primary sclerosing cholangitis associated cholangiocarcinoma, their outcomes are superior, with 1, 5, and 10-year survival rates of 92, 76, and 70% at 10 years. And we can compare this to the outcomes for resection, which are 35 to 44% survival at 5 years and 17 to 30% at 10 years. In a recent review paper, workers at the Mayo Clinic report their survival rates. In these figures on the left, we show the overall survival in an intention to treat analysis from the start of neoadjuvant therapy. So these are all the patients that are enrolled on the Mayo Clinic protocol. At 5 years, these patients have a survival of about 50%. And you can see that the number that start the protocol is 349. For patients that undergo transplantation, this is a smaller number. That's 211 patients in this case. The 5-year survival was 69%, and this would include PSC cases as well as de novo cases. And as you can see, there is a decrease in the number of patients that start the protocol compared to those that complete the protocol or undergo transplantation, and this is all due to dropout. Dividing the outcomes for patients that have PSC versus non-PSC cases or de novo cases, you see that the PSC patients have superior outcomes in survival. Either on the left, we see at the intention to treat mark, which is just all cases that start on the protocol. And on the right, you see survival after transplantation. So as reported on the previous slide, 2 slides ago, the 5-year survival rate for patients with PSC and perihilar cholangiocarcinoma who undergo transplantation is 76%, compared to the de novo cases, which is 58% at 5 years. However, as those slides show, there is a dropout rate, which can range anywhere from 30 to 40%. The median time at drop-off per dropout from the time of the start of the protocols at about 4.7 months. This can be due to disease progression, a decline in the physical state of the patient so that they can no longer go through the protocol, perhaps due to advanced liver disease, or for other reasons. And their median survival for those who drop out from the time of their cancer diagnosis is 12 months, which is much inferior to those who are able to go through the point of transplantation. The protocol is challenging for many different reasons, and for the transplant surgeon, a lot of these challenges are related to the use of radiation. Radiation makes the surgical planes during hilar dissection difficult to identify. And there is a definite increase in the rate of vascular complications. And these are, again, Mayo Clinic data, which shows an increased percentage of patients with hepatic artery thrombosis and stenosis, as well as portal vein stenosis, which is a very uncommon complication of transplantation outside of the use of radiation. And for this reason, many times the vessels in the hilum are not used, and instead jump grafts are used. This illustration on the right, the inset illustration shows an aortoiliac jump graft using a donor iliac artery graft sewn to the infrarenal aorta. And then further to the right, we see a SMV jump graft, again using the iliac vessel of the donor, in this case going from the SMV up to the donor portal vein, therefore excluding use of the donor portal vein, or rather the recipient portal vein. Given these issues, here at Houston Methodist, we've used 2 a little bit of a modified protocol for some of our patients. And this is using gemcitabine and cisplatin, which has been shown to be a superior chemotherapy regimen for patients with biliary tract tumors, and a selective use of radiation. Some preliminary findings for this protocol have shown that our pathologic result on the right side, that the final pathology has been very good without the use of radiation. So this is an area that we are actively looking into to see if this is a viable protocol. We'll now go to speaking about the intrahepatic cholangiocarcinoma and the role of transplantation for these patients. In comparison to perihilar disease, intrahepatic cholangiocarcinoma is increasing in incidence, and this has been going on since the 1970s, where in 1973 the incidence was somewhere around 0.3 per 100,000 person years in the United States, to now it's comparable in incidence to perihilar disease, and it's increasing at about 2 to 3% per year in that time period from 1970s to the present time. It's unclear why it's increasing. Partly it may be due to an improvement in diagnostics, and in part it could be due to the increase in risk factors, the incidence and prevalence of risk factors in our patient population. The same risk factors for perihilar disease are also risk factors for intrahepatic disease, but prominent risk factors for intrahepatic disease are cirrhosis, and hepatitis C, and fatty-related liver disease. As a difference to the perihilar patients with intrahepatic cholangiocarcinoma are usually asymptomatic. They're not usually jaundiced. Some of our patients do have abdominal pain, however. And serum CA19-9 is not often increased. In our series of transplanted patients, only 4 out of the 32 listed patients that we'll describe later had a CA19-9 greater than 100. Outcomes for resection, which has been traditionally viewed as the one curative approach, are not very favorable. The overall survival for these patients at 5 years ranges from 22 to 44%, and recurrence-free survival is low at 16%. Factors that are prognostic to poor survival include the presence of lymph node disease, vascular invasion, as well as more than one tumor in the liver. And importantly, very few patients at diagnosis are resectable. We were here less than 30%, but that would be generous to say that it approaches 30%. Intrahepatic cholangiocarcinoma was transplanted in the early days of liver transplantation. However, the outcomes were very poor. These data were reviewed by Dr. Rana and Dr. Hong in a review paper, but they are data from the University of Pittsburgh and the Cincinnati Transplant Registry. And what they show are poor survival at the 2-year mark of 30% and a high recurrence rate at an early mark. However, recently we've seen that some patients undergoing transplantation for intrahepatic disease do have favorable outcomes. This slide shows results from a multi-center retrospective study reported in Hepatology in 2016. This study separated patients that had very early cholangiocarcinoma. That was 15 patients, and that was defined as patients that had a single tumor less than or equal to 2 centimeters in size versus patients with, quote, advanced intrahepatic cholangiocarcinoma, which was 33 patients, and these were patients that had a single tumor that was greater than 2 centimeters or more than one tumor within the liver. The cumulative recurrence of patients in the very early group was low at 18%. And the 5-year survival was favorable for the very early group at 65%. However, these were incidentally diagnosed cases which were discovered on liver explant, or they may have been thought to be HCC before liver transplant. None of the cases were diagnosis intrahepatic cholangiocarcinoma. None of these cases were intentionally transplanted with a diagnosis before liver transplant of intrahepatic cholangiocarcinoma. And as a result, there was no systemic neoadjuvant therapy. Some of the patients had local regional therapies, and these were, again, patients that were thought to have HCC lesions. So here at Houston Methodist, we asked ourselves the questions: can we prospectively transplant patients with a known diagnosis of intrahepatic cholangiocarcinoma? If we transplant them prospectively, can we select patients that have favorable biology? Can we use a neoadjuvant therapy with systemic chemotherapy, and will this improve outcomes? There were some data from UCLA which were shown in retrospective reviews, which gave us encouragement to look into this. Specifically, in retrospective review, patients that had received neoadjuvant therapy had superior survival after liver transplant. Additionally, improvements in chemotherapy were being made for biliary tract tumors. In the New England Journal, investigators in 2010 reported an improved overall survival for patients that had gemcitabine and cisplatin. So a protocol was devised, and it started in Houston Methodist in 2010. The first 6 patients were reported in this publication from our institution in the Lancet. This was a joint endeavor by Houston Methodist and MD Anderson, and it was a protocol of neoadjuvant treatment followed by liver transplantation for locally advanced intrahepatic cholangiocarcinoma. The protocol involves patients that have a histologic diagnosis of cholangiocarcinoma before transplant, locally advanced disease defined as a single tumor more than 2 centimeters or multiple tumors, no disease outside the liver, including no regional lymph node disease, unresectable disease, either due to tumor location or underlying liver disease, successful evaluation and listing, of course, and adherence to a neoadjuvant treatment protocol, which was largely reliant on gemcitabine and cisplatin systemic neoadjuvant therapy for at least 6 months. Exclusion criteria are listed for reference below. This image shows the tumor, which was present in these first 6 patients, and as you can see, these were large and often multiple tumors. And it is the case that some of these patients had previous resection. If they recurred and they underwent neoadjuvant therapy and met study protocol criteria, they were included. Results from this first trial, or rather these first 6 patients, showed favorable survival at 1, 3, and 5 years of 100% at 1 year and 83% at 3 and 5 years, with about a 50% recurrence rate at 3 years. We've gone on to report, or rather we're in the process of reporting our updated results. Since that first report, we've now been referred a total of 65 patients and listed a total of 37 patients for transplantation for this diagnosis. Of these 37 listed patients, 5 went on to be eligible for resection due to response to neoadjuvant therapy. So in our newest report, which is under review currently with one of our journals, we've transplanted a total of 18 patients, and we've listed but not transplanted 14 patients. And that was a comparison group. Comparing patients that were transplanted to patients that were listed but not transplanted, there was a survival benefit to the intervention of liver transplantation, and that's shown in an improved patient survival on the figure on the left. Our survival ranged from 71 to 77% at 3 years. We did include 1 perioperative death, which lowered that rate to 71%. At 5 years, with a Kaplan-Meier estimate, our 5-year survival range somewhere from 57 to 62%. Recurrence-free survival is shown on the right. The follow-up time was shorter after transplantation, so compared to the time from listing, and so we report our outcomes at 3 years. Important findings from this study was that there was a preponderance of FGFR and DNA repair genetic alterations in all the patients that we were able to list. So, again, I want to highlight these are patients that were able to have stable disease for a total of at least 6 months. I don't believe that was highlighted on the previous slide, so I want to highlight that now. An important facet of our protocol is disease stability for at least 6 months. Patients that were able to meet these listing requirements of note had an increased prevalence of these specific genetic alterations over and above what we see in the overall population of patients with intrahepatic cholangiocarcinoma. And we found that there was a favorable survival despite locally advanced disease. In our transplanted patients, the median cumulative tumor size for all lesions present in the patients was over 10 centimeters. And the median number of tumors was 2. So there were patients with more than 2 tumors. But despite this locally advanced disease, we were able to find favorable survival with our protocol. We did have recurrences. Out of the 18 that we transplanted, a total of 7 recurred, and there was a definite difference in early recurrences versus late recurrences. Early recurrences occurred within the first year, and some of these unfortunately included patients that on retrospective review of their imaging may have had a lesion which was indeterminate before transplant, which went on to become evident that it was a metastatic disease. So, potentially these patients had distant disease at the time of transplant. And also 2 patients that had disease at the margin of the transplant explant. These early recurrences that recurred within 1 year had an inferior survival to those that recurred late. So 3 patients recurred greater than 2 years after transplantation. All 3 patients are alive at the end of the study period, and 2 out of the 3 were alive greater than 5 years. Going forward with our protocol, some of our directions include the use of cell-free DNA to monitor for disease recurrence, similar to what's being done with colorectal cancer. This, we believe, will help us to treat the recurrences earlier with adjuvant therapy. And we would like to involve additional centers. This may mean some changes in our protocol in terms of tumor size and number, what we include. And it may involve a more important role of genetic alterations in choosing patients to transplant. We know, for example, that patients with FGFR fusion genetic mutations have an improved response to chemotherapy, a more indolent disease course, and may have a better survival after transplantation. In comparison, we know that patients with TP53, KRAS, and CDKN2A mutations have inferior outcomes. And it's possible that these will inform the inclusion of patients for transplantation, either in multi-center studies or in the future when hopefully this will be a more accepted indication for transplantation. And I will end there. Thank you so much.
Thank you, Dr. McMillan, for that presentation. Before I introduce our next speaker, I would like to remind everybody to please send your questions either by joining web, go to pollev.com, enter DBakey and respond to activity, or just post your question there. And you can also text to DBakey to 37607 and please post your question there. I'm looking forward to the Q&A session that we'll have after this last lecture or the presentation. It gives me immense pleasure introducing our last speaker for today's session. It's Dr. Ahmed Kaseb, that I've known for the last 3 years and I've had the pleasure to work with him. Dr. Kaseb is the professor of medicine in Department of gastroenterology, GI oncology, and director for the hepatocellular carcinoma program at MD Anderson Cancer Center. Dr. Kassab obtained his medical degree in Egypt and did his residency and fellowship training in Michigan. Dr. Kassab is very well known in the field of hepatocellular carcinoma. His major research interest is in the field of HCC, and he's authored several peer-reviewed research articles. He chairs several committees and advisory boards, and he's a principal investigator of several hepatocellular carcinoma trials and is a recipient of several NIH grants. Dr. Kassab is going to talk about his title is Towards a Practical Approach to Hepatocellular Carcinoma Management, Focus on Emerging Immunotherapy Role. Welcome, Dr. Kassab.
Good afternoon, everyone. I'm Dr. Kassab. I'm a professor and director of hepatocellular carcinoma program at MD Anderson Cancer Center. Thank you very much for the organizing committee. I'm always been very honored to participate at your annual meetings to our thoughts and brainstorm about our collaboration and research activities. Today I'll be talking to you about a practical approach to hepatocellular carcinoma management and focus on emerging immunotherapy roles in early and late stage disease. To my research support, I always like to start with this slide and use it as a stepping stone to walk you through presentation about hepatocellular carcinoma management in early and late stage. So this is to help us understand the challenge we face in clinic when we evaluate our hepatocellular carcinoma patients. On the left-hand side, you see hepatocellular carcinoma associated with cirrhosis. Although it's a small tumor, the liver is very shrunk and cirrhotic, and also it's a vascular tumor highlighting driven nature of pathogenesis of HCC. Therefore, there is limited surgical role here. If the patient is not a transplant candidate, there is no role for surgery, and therefore the options in terms of systemic therapy are palliative in this setting. On the right-hand side, we have hepatocellular carcinoma with no cirrhosis. So you have large tumor, healthy liver. So this patient ended up having surgery down the line. However, the challenge here the high recurrence rate. So dilemma number one is the fact that we don't have hypothesis-driven personalized systemic therapy approach, and the fact that the child circuit pure classification is the only hepatic reserve assessment tool, and it's challenged, as we all know. Therefore, we have poor outcome in advanced HCC patients to improve efficacy of systemic therapy and also predict response. Dilemma number two, which is applicable to surgical disease, is the fact that we don't have standard neoadjuvant or adjuvant approaches, and therefore recurrence rates are very high. This is the outline of my presentation. I'll walk you through current standard multidisciplinary therapies in HCC and also focus on systemic therapy and potential predictive biomarkers. Then move on to discussing the potential targets for systemic therapy in HCC, also look into the potential of systemic therapy in the immunotherapy era in both early and advanced stage disease, and finish with a roadmap to future clinical trial designs in HCC, and then conclude. This is the treatment guidelines. I like always to divide it up into liver-only disease versus metastatic to make it easier, especially for our young clinicians. So when we have a patient in clinic, we think about it that way. Are we up against liver-only disease versus metastatic or major vascular invasion, tumor thrombus and imaging? So if it is a liver-only disease with advanced cirrhosis, if liver-only disease with advanced cirrhosis, the only surgical option is liver transplant. So we go for local or systemic therapy to bridge to transplant, or local and systemic therapy alone if patient doesn't meet transplant criteria. For liver-only disease patients who have early or no cirrhosis, they can go for surgical resection, especially if it is unilobar disease, the classic surgical candidate, and local or systemic therapy if a patient doesn't meet resection criteria. And of course, for metastatic or major vascular invasion, systemic therapy is standard. Now let's move on to talk about systemic therapy options. This is the study that led to approval of atezolizumab plus bevacizumab. It was a randomized phase 3 study and led to approval of atezobev as the preferred frontline therapy in HCC. So this was the initial data, the hazard ratio in terms of OS and PFS, which were the two co-primary endpoints. And this is the updated survival outcome data here. Median overall survival on the atezobev arm 19.2 months compared to 13.4. PFS 6.9 versus 4.3. More impressive was the response rate here, 30% per RECIST 1.1 in the atezobev arm versus 11% on sorafenib. And to follow up on this, another paper looked into patient-reported outcomes on the combination compared to sorafenib and confirmed that if you look at all patient-reported outcomes, they all correlated with the improved clinical outcome as well in terms of survival and PFS. All of them improved in the combination compared to sorafenib arm. This is the other frontline standard approach, which is lenvatinib, was also approved a few years ago, about 3 years ago, based on non-inferiority study design. And also, I highlight here the higher response rate on lenvatinib, 24% compared to sorafenib. And this is the phase 3 studies in the second line setting that looked into TKI, then targeted therapy compared to placebo, and we will see here universally about 2 to 3 months improvement in OS and PFS. And finally, nivolumab plus ipilimumab, anti-PD-1 plus anti-CTLA-4 combination. This is a non-randomized study that looked into just different dosing of one regimen, nivo plus epi. So 3 different dosing and schedule, and this was not compared to any standard of care. However, it showed that patients under arm A achieved the highest survival. If you look at the dosing here, ipilimumab dose is 3 milligrams per kilogram every 3 weeks, which is high, and therefore almost half of the patients ended up needing steroid use or immune-related adverse events. So this is what we have now. In 2007, sorafenib was approved as the frontline therapy and the only available systemic therapy in HCC. Fast forward 10 years later, regorafenib and nivolumab approved in second-line setting. 2018, lenvatinib and pembrolizumab approved. Lenvatinib frontline, pembro second-line. 2019, cabozantinib and ramucirumab in second-line setting, and cabo was for AFP more than 400. 2020 witnessed atezobev at the frontline preferred regimen of choice in HCC, and then 2021 nivo epi came along and obtained conditional approval. So this is basically the list of the approved agents in HCC. The green boxes are the fully approved based on randomized phase 3 studies here in the frontline. Sorafenib, lenvatinib, and atezobev is the preferred one. Nivo versus sorafenib was negative. Rigo, cabozantinib, ramucirumab are all approved in second-line setting. Nivolumab was retracted in July 2021. Nivo plus epi conditionally approved. Pembro versus placebo was negative. However, pembrolizumab stayed in the conditional approval status because there is an Asian study, randomized phase 3 study as well, and it should be completed in the next few months. So let's start with the first clinical question here. Do we have response predictors for immunotherapy in HCC, such as immune staining or risk factors? This is an important study that was done in ad hoc manner, retrospective. However, it proved the concept that PD-L1 status correlated with response to nivolumab in HCC patients. Other biomarkers failed to do so. And this was shown in PD-L1 more than 1% in pre-treatment biopsy. Objective response rate was almost doubled here in sorafenib experienced patients, 26% versus 13% in those with low expression, and in those who are sorafenib naive, 28 versus 16%. And this is a follow-up study with pembrolizumab as well that showed the total PD-L1 expression to be associated with response to pembro. And then another approach, in addition to the immunohistochemistry, was looking into flow cytometry, neutrophil to lymphocyte ratio, RNA sequencing, Atezo-bev as well, compared to atezo alone, showed similar pattern in terms of RNA sequencing for VEGFR expression, T regulatory signature, myeloid inflammatory signature. And then finally, tremelimumab anti-CTLA-4 combined with radiofrequency ablation in a small study also showed some correlation between immunohistochemistry in the baseline flow cytometry assessment as well for baseline cells and response to therapy, and also TCR, for T-cell receptor sequencing. So it's evolving, the field is evolving in this area, although most of the evidence we have now is limited to pilot studies. We're waiting for large randomized studies to look into this carefully. And then in terms of risk factor, there has been a lot of research underway. This is a study published in Nature that we were part of that pooled analysis from clinical trials and also did very hectic animal modeling. So in the preclinical space, it showed some resistance in NASH models, NASH-related HCC to immunotherapy, and the culprit here was CD8 positive, PD1 positive T cells were associated with the resistance. However, this did not pan out yet in clinical setting, but it's also raising the flag that we should really start looking into this in a prospective manner to look into the correlation between immunotherapy response and specific risk factors such as NASH-related HCC here, or what we can call non-hepatitis HCC. So answer to question number 1, today there is no validated predictors of response to immunotherapy in HCC. How about response predictors for targeted therapy in HCC, such as molecular markers and risk factors? This analysis was a meta-analysis that was published in JCO 4 years ago that looked into all randomized phase 3 studies of sorafenib over a span of 10 years since its approval in 2007, and showed that hepatitis C patients benefited the most. Could also be an indirect effect because sorafenib has a positive effect on portal hypertension and fibrosis. In fact, if you dig deeper and look into the pathogenesis of hepatitis C-related HCC, you see the RAS, MAP kinase, also, which is the main target of sorafenib being involved in this pathogenesis. So that's why probably we had some trend towards better benefit in hep C-related HCC on sorafenib, and could also be related to positive effect on portal hypertension and liver fibrosis. And of course, alpha-fetoprotein level 400 plus was an indication for approval for ramucirumab. And if you look into the REFLECT and IMbrave 150 lenvatinib versus sorafenib and the IMbrave 150 atezo-bev versus sorafenib, subtle clinical points here I wanted to highlight. EGD was necessitated within 6 months of enrollment into IMbrave 150. Also for REFLECT, exclusion criteria included invasion into main portal vein or more than 50% liver occupied by the tumor or invasion of bile duct. So answer to question number 2, the only validated biomarker is AFP more than 400 as an indication for ramucirumab, a hint of better outcome to sorafenib in hep C-related HCC, and we have to use caution when we use certain agents in patients with main portal vein tumor thrombosis or patients with large varices, for example, as we mentioned. Moving on to question number 3, how about specific clinical scenarios that could be in favor of specific sequencing? So that takes us to how can we manage those patients knowing that we have multiple regimens in front and second line. The first question I always ask myself is, can we use immunotherapy here from the get-go? So if immunotherapy is contraindicated, then we are left with only lenvatinib, sorafenib in front line, and then regorafenib, cabozantinib, ramucirumab in second line in terms of FDA-approved agents. How about if immunotherapy is not contraindicated? Then the frontline regimen of choice would be atezo-bev. You still have lenvatinib, sorafenib, and then second line we have rego, cabo, ramucirumab, and of course nivo, pempro, and nivo-epi. Although we have to use caution with the nivo-epi, as I mentioned, because of the higher degree of adverse events there with the approved dose of ipilimumab at 3 milligrams per kilogram. And then if we look into patients who started on atezo-bev frontline here, then the second line option could still include lenvatinib, sorafenib. Also, we're not going to go to single agent, so you don't see single agent immunotherapy here anywhere in this box. You see Rivo, Cabo, Ramucirumab, and then Nivo Epi with caution, as we mentioned. And then if we don't use atezolizumab frontline, those patients who are already on sorafenib or lenvatinib and progress, we can actually still go back to atezolizumab or switch to the other frontline. And then second line, the door is open as well. Although with the caveat that Nivo was retracted recently, so the use of Nivo here will be off-label. How about sorafenib followed by regorafenib? So this study that showed that median survival from starting sorafenib was 26 months in this sequence versus 19 months in the sorafenib followed by placebo, and that's for the regorafenib randomized phase 3 study. So the practical question here is when to sequence sorafenib followed by rigo. A lot of people argue that if they did well on sorafenib, tolerated it, had some response. However, in this era, as we mentioned, in the immunotherapy naive patients, a lot of those patients could be candidates for immunotherapy. Another practical question, could approved second-line therapy be applicable after lenvatinib or atezolizumab? So that's a technical question. However, it has been addressed in the recent guideline, which is allowing patients to have access to these treatment options, even though sequencing was not done in a prospective manner in trials yet. So the answer to question number 3, sequencing, IO and TKI and HCC would depend on mutual decision between the patient and physician regarding adverse events records, comorbidities, and personal preferences as well, oral versus IV. And this is the ASCO recommendations here. I have participated in that, and we ended up recommending that following frontline with atezolizumab. Second line could be any TKI you can pick from frontline or second line agent, and also making sure that it is understandable that there is no data yet published on therapy options after frontline treatment. However, we still are allowing as a community to have patients to have access to those therapy options, as we mentioned, with our front or second line. So let's move on to discussing the potential targets for systemic therapy in HCC. This is a busy slide, but to simplify, we look at lymph node targets and tumor cell targets. For the tumor cells, for example, for it's an angiogenesis-driven tumor, so VEGF, ramucirumab, bevacizumab, tyrosine kinase inhibitors, different ones approved in HCC, and then immunotherapy agents here. The most commonly used are the checkpoint inhibitors, anti-PD-1, PD-L1, CTLA-4, and then, of course, adoptive cell therapy, such as CAR-T and T-cell therapy. And the most attractive targets here are alpha-fetoprotein and glypican-3. And then mixing local and systemic therapy such as radiation or RFA or TACE to induce the antigen formation and immune cell infiltration. And for those agents that can mobilize the lymphocytes from lymph node to the tumor, such as CTLA-4, ipilimumab, tremelimumab, are in clinical trials actively enrolling. So in terms of combining targeted and systemic therapy, the perfect example here is bevacizumab through dendritic cell maturation or the effect on myeloid cells. There is a lot of mechanisms for synergy, and it's been validated in clinical trial setting and led to approval of targeted plus immunotherapy. Here would be bevacizumab plus atezolizumab in frontline HCC. We have a lot of trials ongoing, Cabo-Nivo, Cabo-Atezo, and lenvatinib and pembrolizumab, who are eagerly waiting for further results in this space. Let's discuss systemic therapy potential in early and advanced HCC in this immunotherapy era. First, let's ask an overarching question here to look at this big picture. What's hindering our march towards cure using immunotherapy in HCC? Number one, single agent response rates are low, universally 15 to 17%. However, IO plus IO or combined with TKI targeted therapy, we could reach up to 30%, as we have shown. Development of resistance is also a challenge. TTP is about 4 to 6 months, even with combination therapies. Current role is therefore palliative, and response predictors are lacking. We know that a number of patients respond very well. We've seen even some complete responders, but we really don't have any way of predicting those responders. So improving the overall response rate and CTP is really a key in this era, and combining immunotherapy and targeted therapy can really achieve higher response rate, and this could be translated into using some of these regimens even in the neoadjuvant space to transform non-resectable to resectable, for example. And this is a selection of some ongoing trials here, looking into checkpoint inhibitors and local therapies, looking into combining with ablation, chemoembolization, and also HM90. This is a list of the key phase 3 trials looking into immunotherapy plus TACE. So these are randomized trials. BMS has a study Nivo versus Nivo, AP versus placebo, and all of this is with TACE. And then durvalumab and bevacizumab versus placebo in another study, AstraZeneca looking into combining this with TACE, another study Pembro plus Lin versus placebo, also with TACE on both arms, and then finally Roche atezobev plus TACE versus TACE alone. We looked into something similar, this study in press now, looking into 400 plus Y90 and showing much higher overall response rate that we have presented before, showing this proof of concept that you could improve OS and PFS when you combine systemic and local. How about our goal of understanding predictors of outcome and monitoring of therapy and developing resistance? An attractive approach here is ctDNA change while on therapy. We looked into that at baseline and found certain molecular alterations correlating with resistance to immunotherapy, PI3 kinase, PTEN, KIT. So moving forward, you could look into combining agents targeted these molecular alterations with immunotherapy, for example. Another attractive approach is looking to gut microbiota. We always get baseline microbiome signature before starting immunotherapy, and look into the diet questionnaire to look into the diet habits and try to correlate that with the microbiome signature and response to immunotherapy. And then we looked also into radiographic assessment. This is something that is fairly new. We looked into assessing the stiffness of the tumors measured by elastography compared to baseline. So this was at 6 weeks. So tumors were treated with immunotherapy after baseline biopsy and elastography, and 6 weeks later we obtained another tissue analysis in addition to elastography. And those tumors that experienced increased stiffness responded the best in terms of survival and also necrosis. So this was a marker in our studies that correlated with better outcome. Whether this is reflecting increased infiltration or something else related to the effect on fibrosis, it's ongoing work. Trying to improve on the Child-Pugh classification, LV score has been introduced in the last decade, and is looking into simplifying the approach to look into bilirubin albumin. We adopted similar approach before that, where we replaced ascites and encephalopathy with insulin-like growth factor 1, which is mainly produced by the liver, and transforming the Child-Pugh classification into all blood-based albumin, PT, bilirubin, and IGF-1. Compared them to the original Child-Pugh and showed superiority of the predictive ability of IGF score compared to the Child-Pugh score. In fact, we looked into that in the IMBRAVE study and showed that, in both arms, you can really see significant separation here in patients who are all Child-Pugh A. However, IGF score A versus IGF score B and C showed a significant difference in terms of survival outcome here in both arms. So this is also going to be tested prospectively in future clinical trials as well. And along this line of prediction of treatment outcome, an important study published almost 15 years ago looking into risk of recurrence after surgery. They identified very specific cell populations. Here is a ratio between T regulatory cells and cytotoxic T lymphocytes. And in those patients with higher ratio of Tregs, those patients had lower survival and earlier recurrence as compared to patients with higher CT cytotoxic T cells compared to T regulatory cells. So we use this approach to design our neoadjuvant study looking into nivo versus nivo-epi in resectable HCC, 30 patients enrolled, and then no treatment-related toxicity led to cancellation of surgery. And then in terms of adverse events, most grade 3 and 4 treatment-related to toxicity occurred in the adjuvant phase of the study because we did it before and after surgery. And this is the treatment outcome. 6 out of 20 resected patients achieved major pathologic response. In fact, 5 of them achieved 100% necrosis, and number 6 achieved more than 50% necrosis. And none of those 6 patients recurred, while the others had 50% rate of recurrence. And this is looking into immune and antigen presentation pathways in post-treatment tissues in those patients who achieved major pathologic response. And notably in the nivo plus epi, we saw increase at the post-treatment here. So you really didn't need to have higher percentage of these cytotoxic tumor-specific T lymphocytes. Nivo plus epi led to increase of this ratio at time of surgery. Based on this, we moved this concept to a national study of SWOG. It's going to be a randomized study of neoadjuvant nivo plus epi versus surgery alone in patients with resectable HCC. And this is emerging neoadjuvant and adjuvant trials here in this space at TazoBev. This is between our institutions, MD Anderson and Houston Methodist here in resectable HCC. I'd encourage you to refer any resectable patient to this study. We basically do 3 cycles of TazoBev followed by surgery. And then similarly, nivo plus Yttrium-90, nivo plus Cabo just finished, and it was an unresectable disease pilot study of 15 patients. Pembrolizumab plus nivolumab ongoing in England, and adjuvantly global studies nivo, Pembro, and Atezobev for surgery for high-risk population. So I'm going to finish with the roadmap to future clinical trial designs in HCC. So I would propose for resectable disease to look into neoadjuvant therapy after obtaining a biopsy for molecular, pathologic, immune, and even imaging profiling to look into stiffness of the tumors, for example, PET scan, another example, and then look into collecting samples and performing all the above again at surgical resection time. And then based on the profiling of the surgery in those non-responders, you can personalize an approach to go for adjuvant therapy. So for those patients with early stage resectable disease, obviously we have HRPUA, no portal hypertension, so we will go for pre-surgical treatment, neoadjuvant, and also adjuvant therapy post-operatively, as we mentioned. And those patients with unresectable disease, I would argue that you could look into vascularity and capsule here. And those encapsulated hypervascular tumors can benefit from intraarterial therapy. And the comparison here would be intraarterial therapy, which is standard of care plus systemic therapy. However, those hypovascular infiltrating tumors, we all know that they don't benefit from intraarterial therapy. So here we could look into either systemic plus systemic and ablative therapy such as XRT, or systemic versus systemic. Let's conclude. Despite recent approval of multiple systemic therapy options in HCC, we still have modest activity limiting their clinical significance. However, as we mentioned, advances in combining immunotherapy with immunotherapy or with targeted therapy are being translated into a higher response rate and longer TTP and OS, and predictive biomarkers are really needed here to maximize this benefit. Adjuvant and adjuvant immunotherapy also could lead to decrease in recurrence rate and improving survival. Along this line, we really need some personalized approaches here, specifically after tumor resection, to design adjuvant therapy strategy. Therefore, multi-institutional participation in HCC trials is really critical, given the heterogeneity of the risk factors and patient demographics. And I highlight here our collaboration with Methodist as a good example here. I know we have a Methodist audience today, so it's a good example of this approach. This is our overall HCC score at MD Anderson. We have Project 1 targeting a PD-1 pathway and looking into neoadjuvant therapy. We mentioned nivo versus nivo-epi, also combining this with immunotherapy with targeted therapy in advanced disease. Along the same line, looking into targeting STAT3 with oral small molecule inhibitor, also in the adjuvant and in the unresectable disease setting, similar to Project 1. And Project 3 is looking into non-invasive assessment of liver fibrosis stage and progression in obese and diabetic patients, focusing on Hispanic population. So there is a lot of opportunities here for collaboration. Feel free to contact me. And this is our international biomarker consortium here, which is also designed to enhance collaboration between major institutions to look at immune and molecular profiling, pulling our databases together. Every institution keeps their own clinical data and clinical samples, and we can collaborate on publications together and collaboration projects moving forward. I'd like to acknowledge our team at MD Anderson, and thank you so much for your attention.
Okay, great. Thank you, Dr. Kassab, for this impressive talk and comprehensive discussion. It's a really exciting time for HCC management with all these treatment options available for our patient. With that, we will start our discussion and start with a question from the audience. And I see there's a question coming from one of our audience stating that when using immunocheckpoint inhibitors in combination with ablation therapy for patients who are a transplant candidate, what timeline do you follow when considering discontinuation checkpoint inhibitor before surgery? I think it's a safety question. Any of our speakers can take this one.
So I think that this is Laura Kulik from Northwestern. I think this is a evolving practice, and we don't really have any standard guidelines at this point in time. There are been reports of patients receiving immunotherapy within the 28 days of the half-life and having suffered complete necrosis of the graft and death. And then there has been a recent publication from the Mount Sinai group where I think it was 6 out of the 9 patients had received their last dose of immunotherapy within a month's time. We at Northwestern have discussed this, and we have said that we are looking at potentially a 3-month time point from the stop of immunotherapy to transplantation. I think the Mount Sinai group has also been changing their protocol that it's going to be a 3 to 6 month time period. And it's an important question because we don't know, you certainly want to get the immunotherapy out to decrease the rate of rejection, as well as see what is the minimum time point to make sure that the tumor is still biologically behaving without the immunotherapy being on board.
I totally agree with you, Laura, and I know Man at Methodist, you've been, thinking about putting something together to do this in a trial setting, which is really the way to go. We need those trials, and as you alluded to, it really depends on the time, between the last dose and transplant. So doing this prospectively in multi-institution manner in a trial setting would be the best way to go.
Dr. Kolak, this is an area that is a lot of information is needed because it's, the use of immunotherapy, the impressive response that we had, the use of in the neoadjuvant setting, like the trial Dr. Kassab is using, that would be a time where we need to collect more data and safety data on this. Some suggestion, about, 3 half-life of the immunotherapy itself. That's one of the suggestions to add to the comment that from our speakers. But it's exciting time, and it's we need to utilize immunotherapy for our transplant patient to give them the maximum benefit and to get them to the curative treatment of a transplant. I think Dr. Kodali have a tag question for Dr. Kulik.
Yes, Dr. Kulik, this is partly related to your talk. So once you treat a patient with local ablative modalities, especially if it's a patient who's not a transplant candidate and you need to follow these patients along, do you see a role of biomarkers or circulating tumor DNA in those patients, especially if you don't want to delay the treatment? Or I know we have good imaging studies and we follow these patients very closely, but what are your thoughts on biomarkers or ctDNA in these patients?
I mean, ctDNA would be great to follow because then if you see this rising, you have something beyond just what you see in the imaging, which may lead to, performing an angiogram, which we sometimes will do if AFP is rising. We're not really seeing anything in the metastatic workup or on the abdominal scan. The issue is currently, because it's not become standard of care in this cancer, is I think the concern is getting it paid for. I've also used AFPL3 and DCP in patients, which This is approved more for risk of developing cancer as opposed to monitoring patients once they've had cancer and been treated. So certainly an area that it would be great for patients and reassuring them if their biomarker, whatever that may be, is remaining low or not detectable, to give them a better sense of security, especially when they're not a transplant candidate.
Have any comments, Dr. Kasab? Thank you, Dr. Kulik.
Yeah, Dr. Kodali, I agree with Dr. Kulik, and I really think we need to have more studies looking into other prognostic indicators. At this point, I know that a lot of transplant centers they rely on alpha-fetoprotein, and to a point where they can exclude some patients if the AFP is rising or above 1,000, and we all agree with that. But we really have to find some other prognostic indicators. Dr. Kalik talked about, the circulating tumor DNA. I have also seen some studies about imaging markers, looking into PET scan, doing PET scan right before transplant, and if it is still active on PET, it's an indication of poor prognosis and early recurrence. So I think we really need to combine our efforts in a multidisciplinary manner to look into blood and also imaging parameters to help us predict prognosis in those patients who are going into a life-changing, experience with transplant and post-transplant immunosuppressive environment, which can give rise to tumor recurrence.
Thank you so much. I guess while we are on the topic, Dr. Kulik, I have a follow-up question. You mentioned not ablate and wait modality, right? So for tumors that are less than 2 centimeters, especially if we are looking at somebody who could be potentially eligible for transplant, sometimes we want to wait and let the tumor grow a little bit and see if we can get those extra points for that patient who may be otherwise doing okay and have a low MELD. Now, what do you think should be the frequency of imaging in those patients? How often do you think we should monitor or do a scan, I guess, a cross-sectional imaging study? What should be the frequency?
So this is, the first point is, this is always where I say, what is the benefit to the patient versus what is the benefit to the center? Transplant centers want to transplant. So if you have a patient who has a Child's PUA with a early stage T1 lesion, I think that waiting to let it grow to 2 centimeters to get them a transplant because of this is probably not what I would do. If they are a B or C, they've had prior complications, that's a total different animal. But in patients who were doing this not ablate and wait, I would screen them every 3 months. There have been identifiers that have shown that the risk of high rate of going from a T1 and leapfrogging to a T3 and totally bypassing within Milan has been patients with an AFP that is high. They used greater than 500. Patients who are Hispanic was also a risk factor, and the rate of growth, which makes total sense, was a risk factor for this. So I think that we have to keep in mind that we need to treat the patient what is going to give them the longest life expectancy. And while transplant is a phenomenal resource, there are also complications associated with transplant. So if a patient can get 3 to 5 years out of treatment with a local therapy, and then potentially if they have another tumor, then moving towards transplant. So I think we're really learning, we're going to have to learn who is at higher risk of recurrence now that we have Hep C treatments. Patients may be, the further they're out from when their Hep C was active, they may be less likely to have a recurrence from what they were when they still had viremia present.
Okay, thank you, Dr. Kolak, for this response. My question to Dr. Kasab, actually, you highlighted in your talk the biomarker for IO and hepatocellular carcinoma. And you mentioned that PD-L1 is one of the biomarkers that's been looked at, and there's some correlation and maybe conflicting data. So my question to you, Dr. Kasab, about, ADA, basically like, anti-drug antibody. This is an area of interest that came about a couple of years ago about your response that might hinder the response to IO. Do you think this might be a good biomarker to follow? Should we check it when we treat our patient with immunotherapy that might not have the best response? Or this is like a premature for the prime time?
Yeah, it's a great question, Dr. Abdul Rahim, and me and you had this discussion before about how we can benefit from these emerging data. I think at this point, it doesn't rise to, the level of being, validated. There is definitely, specifically for certain drugs, there is some evidence there that there is some correlation. Whether this will change our management at this point or not, it is not really the prime time for it. So I think we all acknowledge that we have to use what's available for, front and second line in terms of immunotherapy. But this field is going to really be explored in a prospective manner. Most of the studies ongoing now, phase 3 studies, are collecting some basic PK samples to look into that. Standard of care still remains the same, but it's definitely something that could help us going forward if we can validate this in certain drugs. So upfront, we can start using other combination strategies. But at this point, I don't do it routinely. And I think we're still waiting on some new data, especially now with the nice responses of combination immunotherapy with targeted therapies. We're going to even see less and less of that. You could have some targeted therapy or tyrosine kinase inhibitor on board that could overcome part of this resistance. So that's another thing that could complicate the picture, because it's not monotherapy alone in these cases, which has been associated with the ADA resistance to mainly for monotherapies. But now we're going to have a lot of studies, coming out, just like atezolizumab did last year, in the next 6 to 12 months with other combination strategies. So the validity of this will be tested, but I don't know how we can use it in clinic, because I really think it's still going to be affected by the combination drugs in that case. So we may not know the answer to this question, because we're not going to use a lot of monotherapies down the line.
Thank you, Dr. Kasep. Now, I can't tell if Dr. McMillan is on the call for answering some questions, but we do see a few questions coming in about liver transplant for perihilar and intrahepatic cholangiocarcinoma. One question is, for patients who are transplanted for hilar cholangiocarcinoma, if the explant demonstrates viable disease, do you actually consider chemotherapy? And just to extrapolate that question, the other question that often comes across when we see patients is, if a patient has a lot of viable tumor, when we do intrahepatic cholangiocarcinomas, which is a very kind of rare indication, and we do those here, what would you do, or do those patients need to go on chemotherapy?
Yeah, feel free to, Amin, to speak up on this, because I know you take care of a lot of our patients. Yes, we certainly do use adjuvant therapies for patients with viable tumor on our hilar cases, and the same for our intrahepatic cases. We certainly made an effort to do next generation sequencing to see if there's any targetable mutations for those types of therapies for these patients too.
Thank you, Dr. McMillan, for your answer. And I think this is an adjuvant therapy question, in addition to, you mentioned in the Mayo protocol that patients have neoadjuvant chemotherapy and then Xeloda as a maintenance till they transplant. And in our center, actually, we use GEM-CIS, and we use GEM as an adjuvant, or not adjuvant, rather than a maintenance therapy. So in addition to what McMillan discussed, patients who have, we think they have a high risk feature for recurrence in the explanted liver, we usually take this in consideration. Some of those, if the margins are closed, or there's a lot, as mentioned in the question, like a viable disease burden, or we think that is like poorly differentiated, highly pathological feature, we end up giving an adjuvant therapy to those patients. And usually adjuvant therapy is depend what they got in the new adjuvant. If they have really good response to the new adjuvant, we give them like 3 months of what they had before, just to sterilize the field, give them the benefit of adjuvant therapy, and to decrease the risk of recurrence. But this is like a good question and a topic of interest. So while we're doing that, actually, I'm going to ask Dr. McMillan, that's in the Mayo protocol, they mentioned Xeloda as a maintenance, and we use GEM. I don't know if there is like, to best of my knowledge, I didn't see like data comparison, head-to-head comparison for Xeloda as an adjuvant, or rather than a maintenance, or GEM as a maintenance. I'm just concerned about the Xeloda for long term. It might cause hand-foot foot syndrome and not able to tolerate. Rather, we have a good luck with GEM. So do you think that is GEM as maintenance therapy might be taken over for the perihilar, the way we're doing it in our center?
You know, I think this is something that we really need to look at, man. We haven't done that yet with our data, but as you pointed out, we have really used a lot of gemcitabine in these patients, whereas, yes, the Mayo protocol mostly been using capecitabine neoadjuvant. So, you know, this is actually absolutely something that needs to be looked at, but I can't tell you that we've done that just yet.
Thank you, Bobby. Again, another question about transplant, and I get this question a lot in the clinic, especially from patients who fly in from different state or from a different institution where they've been diagnosed with intrahepatic cholangiocarcinoma, they've been on chemotherapy, and they hear that we do transplant those patients. So they come in and they say, well, I've been told that I'm not a transplant candidate, so what kind of liver am I going to get, and how do you put me on the list, and how long do I wait? So if you want to comment on that, I'd really appreciate it.
Yeah, so can you repeat that? So the question would be, what is our candidate selection, and how do we do the logistics? Is that correct?
So yes, because these patients are not eligible for exception, patients ask me, how long do I wait, and what kind of liver am I going to get, because I'm not going to get those extra points. So do I get a perfect liver, or are there different kind of livers that patients get eligible to get transplanted? So I think the question is, how do patients get transplanted if they don't go through the regular path getting exception points?
Sure. Yeah. So we've managed to use so-called orphan liver allografts, which were not being used, or rather were given to us as open offers by our OPO, either due to donor age or fat content, in some cases very long cold ischemia times. So we have asked our patients to relocate to the Houston area so that we can do that. A couple of our patients in our series did have underlying liver disease and some liver decompensation, and were able to get standard criteria donor grafts, and I think that was on the order of 3 or 4, and we used 1 DCD. But as we have relied on deceased donor grafts, we've asked people to actually move here. The tempo of our referrals has been such that we've probably had about 1 person here at a time. We haven't been too crowded, if you will, with folks being here waiting on livers. I know that at the University of Chicago, they have used living donor livers, the same, at least for 1 case at the University of Pittsburgh. And we are going to selectively offer that to some of our patients. The challenge is some of these patients have had previous resection, previous radiation. So selecting for living donor candidates is not everyone's going to be a good candidate for that.
Okay, thank you, Dr. McMillan, for your answer. We have another question coming from the audience. The question is that, do you think there is a role for TKI as a bridging or downstaging approach for liver transplant? And if so, do you think should we hold TKI before the transplant, given that it is a safety question, if there's a risk of complication after giving TKI in a short before transplant? And this is a question for all our audience to comment on.
I can jump in, and Laura, of course, we have massive experience with that. So for bridging to transplants, we always, and we learned that from you guys, all the transplant teams, so local therapy, of course, is the treatment of choice, hopefully with either ablation if it is that small, or with intraarterial therapies, case of Y90. And I always reserve systemic therapy in this population for patients who progress despite local therapies, or they have residual disease that is not amenable to local therapy. So we always try to avoid systemic because, as you know, Man, you're a transplant oncologist. Sometimes those patients get the transplant quicker than expected and to go into transplant with some anti-angiogenesis on board could complicate the course after surgery and the biliary complications and healing complications. So we always try to avoid systemic unless we really have to. So in these cases where we have to, we do it very carefully, low dose, and go slowly as tolerated. And we try to have very good communication with the transplant team. So if it is expected to be anytime soon, we try also to hold therapy if there is evidence of disease stability, if the alpha-fetoprotein is normalized. So these decisions will have to be made, like always, in a multidisciplinary fashion, consulting with the transplant hepatology and the surgeon.
So I primarily used the TKIs when someone has been downstage successfully with local regional therapy in the hopes of keeping them downstage. We don't have a lot of data to suggest that that actually is doing anything. It's being extrapolated from the registration trials that specifically with lenvatinib that showed a higher response rate. Our surgeons do get nervous. We did do a trial with Y90 and sorafenib as a bridge transplant. It was a very small proof of concept, and it did show higher rates of rejection as well as biliary complications, which was also shown by a group in Miami, but another group did not experience this. So I don't know that it's 100%, but it's certainly from a biological plausibility, it does seem to make sense that an anti-angiogenic could lead to issues, particularly with the bile ducts as well as wound healing. So our surgeons do get nervous as they're coming close to the top of the list. We generally will stop it.
With that, we'd like to conclude our session. I would like to thank Dr. Kassab, Dr. Kolek, Dr. McMillan for this very informative and interactive discussion. It was really informative for all of us. We appreciate your contribution to this. And I would like to move to Dr. Nkomese to conclude our symposium.
Yeah. Okay, thank you very much. We had a wonderful conference with quite a number of participants, although it was virtual. I wish to thank all the attendees for staying till the end. Also wish to thank the speakers who did an outstanding job, giving us up-to-date and latest on in terms of topics of management of liver disease, as well as our moderators who also handled the sessions very well. My thanks also goes to JD Pantoya. She did an outstanding job in coordinating and getting this conference going. She does all the heavy lifting, and I really want to thank her personally, as well as Miss Ricky, our coordinator, Grace, for also helping. The AV team, led by George, were excellent. We had a wonderful session and very, very smooth sailing through this virtual conference. And again, thank you, and we hope to see you next year, hopefully either live or hybrid. I think we are all itching to meet in person again. Thank you very much.
Thank you, everyone. Bye.